I would like to now request Dr. Sarachandra Mowli, Organizing Secretary of this conference, to deliver the welcome address.
Good morning, everyone. Welcome you all for CRC 2024. This is the third edition of this Clinical Rheumatology Conference. So, as you know, Rheumatology is a pearl city. So, here you have come to collect the pearls of rheumatology, I would say. So, I guarantee that in these next 2 days, whatever you are exceeding 2 years of your life here, to get that knowledge, I guarantee that you get 100% you're happy with the clinical cases. We got a wealth of material. We received around 260 plus abstracts and email submissions. And the top ones are selected for the oral and rapid fire. And also in the email section, top 30 were selected. So, regarding quickly about my review, because we were running late in 2 minutes I'll complete. We started the department in 2004. Initially we started as a fellowship program. In 2017 converted to DRM Rheumatology. 4 people came out so far. Out of 4, 2 people got the prestige for the national boards. And for the past 2 consecutive years, ACR 22, ACR 23, our cases are selected for at least market as a oral presentation, also for the posters. So that is also a good achievement. And we have been doing a lot of awareness programs. Awareness works, lupus works. And for the past 3 consecutive years, we have been doing lupus work in the same hall, where all the lupus patients who improve, who are in remission, then we encourage them to do the work here. And we also give prizes for the winners. This is to break the stigma of lupus. We are doing so many things to increase the awareness both in the medical fraternity and also among the public. And also we have been doing clinical rheumatology workshop. Rheumatology workshop for GPs, mainly to educate the non-rheumatologists. Always I feel that rather than doing rheumatology conferences for ourselves, I think we should educate more the non-rheumatologists so that awareness will be more, then we get a proper referrals. So since 2012, I have been doing annual rheumatology workshop for the non-rheumatologists like GP. So where the live cases will be demonstrated with clinical signs and symptoms. And this CRC, we started in 2019, second one 22, this is the third one. The main idea is, again, what I feel is slowly we are, getting Americanized way, for everything they do investigations. But Indians were very good clinically. For that reason, I thought we should, probably the new generation is losing touch with the clinical skills. So that is the reason, with that motto, I have started Clinical Rheumatology Conference, where only the complex clinical cases will be discussed by the well-known, experienced academicians and rheumatologists here. I welcome you all again for CRC 2024. Thank you.
Thank you, sir. Now I request Dr. Bhaskara Garu, Honorary Chief Patron for this conference, to address the gathering.
Good morning, everybody. Today's the chief guest, Dr. Minu Bajpai, Executive Director, National Board of Examinations, and Dr. Moli Thabba, Dr. Sarachandra Mowli, Dr. Raj Kiran, Dr. Chandrasekhar, Today is a very important day for all of you, as a few important things, as Charat Chandra Mouli has pointed out. Rheumatology is not known many of the people, including doctors. Of course, if the doctors doesn't know, the patients also doesn't know. We need to create more of awareness. Because today everybody is treating if there is a joint pains, that's why with the analgesics and they spoil a lot of their health and come to the later stage of the rheumatologist. Some of them may not able to come. So that's why you people need to create an awareness in the medical colleges, medical schools, general practitioners, for everybody. That's why you keep doing about the walks and other things. That is one important thing. Second important thing, the significance of this today's 2024 CRC meeting is unique in one sense that rather than a routine one-way direction of giving lectures, a case discussions, we are in KIMS the last 20 years we are doing in the Department of Cardiology under the guidance of Professor Dr. Dasagar Rao, nearly on August 14th and 15th. Those are all fixed. They only discuss for 2 days all the cases. The students will come and prepare and present. The other important thing for all of you here, whoever comes, I always tell, if you want to improve the medical education, also we all to improve our own standards. The teacher and the student should have an attitude, is a challenging attitude. It is not a one-way direction of the teacher is teaching and the students are listening and going. The challenge each other. The relationship between a teacher and the student should be challenge each other. When do you challenge the students? When do they challenge the teacher? When you get prepared of the topic what you are going to discuss, then you have come here to clarify your doubts rather than listening and going away. So that way these case discussions will help. I'm sure how many of you read all the things has been given in this book, the cases, the discussions, what are going to happen. If it would have been read and come back with what is the doubts that you need to clarify here, the conference would have been much more useful. With that, the type of questions that you ask, the teachers also will be able to improve so that they will be able to pass on to the next generations. So I congratulate Dr. Charat Chandra Mouli and all the professors come throughout the nation to give this guidance to the students and actually participated, all of you. Thank you very much for giving this opportunity.
Thank you very much, sir. Now I invite Dr. S. Chandrasekhara, President of IRA, to speak a few words.
Good morning. Dignitaries on the dais and off the dais, and the students and my colleagues. I think this is the third one, and I was a part of you in the first one. I think second one somehow I have missed, and this is the third one where I am again. I mean, this format is quite unique and really well appreciated by everyone. The best part when we discuss about the cases, especially little strange case, little off-the-track cases, I always keep telling sometimes the students who sit across will be 1 year ahead of what he would have been otherwise. Because the difference between an experienced physician versus a new physician, what differs is the exposure to the cases. And certain of the things we learn by pattern, because quite often a senior may just look at the case and say, this is the diagnosis. It's not just out of the intuition he judges it. He judges it by learning the pattern which we learn over a period of time, which makes us uniquely different from what otherwise. I think I just read one of the caption, which was, of course, shared in the WhatsApp. It really said that, I complete my work in 30 minutes. And that's for what I, as a senior, I charge you, because this time of reduction, I have come to 30 minutes because I have spent 30 years in learning to do this job. And that's where an experience differs from a newly practicing physician. This bridge can be built in if we participate in work in sharing the experience over a period of time. But of course, there is one threat for all this, is artificial intelligence. Probably down the lane, the artificial intelligence could help us in working with the patterns, because AI and ML works very nicely with reference to the pattern. More the number of informations are put into the artificial intelligence that can bring a decision making little more easier and smoother than that, because this is one of the areas where really things can help. The data that are gathered here, if it is processed and built into a decision-making processes, can slowly work across to help and facilitate these kind of things. So of course, as we know about, the rheumatology is still in its infancy. Many still do not know. And April happens to be the month declared by Indian Rheumatology Association as Rheumatology Awareness Month. This is the month where we are requesting and putting across everyone to put in efforts to sensitize the general public about rheumatology. It's not about arthritis, to sensitize them about the specialty called rheumatology, because if it is arthritis, it's to be treated and managed by rheumatology. This is the message if we go across. Hopefully, down the lane, in decades, people should know almost rheumatology equal to cardiology. That's a point of time where things would be better for both the rheumatologist as well as the patients who suffer from rheumatological disease. I think with this brief note, I literally congratulate the entire CRC team for putting up this show, and I wish them all the best in the next 2 days to successfully organize this, and as promised by the organizers, a feast of knowledge sharing should enhance all our efforts. Thank you very much.
Thank you, sir. Now I request Dr. Molly Thaba to share her thoughts.
Good morning, everyone. Respected Professor Vajpayee, sir, Professor Bhaskar Rao, sir, Dr. Raj Kiran, Sharad, sir, and President IRA, Dr. Chandrasekhara. Like has already been said, that this conference is unique in that it brings students and teachers together from all over India, like for a case-based learning. So it was awesome to receive so many abstracts, I mean more than 250 odd abstracts, and going through them one by one has been a real challenge. It took a lot of my time, but in the process I also learned a lot from this. And out of these abstracts, much of the work, like screening through them, goes to the awesome work done by all our abstract reviewers who are working behind the scenes to screen each and every one of them. So I really thank all the abstract reviewers and all the image reviewers who have spent their time to go through all of them. And out of these 200 odd abstracts, we have selected top 4 cases from each category to be presented here. It was really difficult to really select which one is the best. Actually, all were equally challenging. But somehow, based on the abstract reviewers, we managed to score certain cases based on novelty, clarity of presentation, based on the way it was written and all. I hope we have selected, and we also selected, like, there's a combination of novelty and also not so rare cases also. So with this, I thank all of each and every one of you, all the students especially, who have shown so much great interest and enthusiasm to display their best and memorable cases of their career, and which will teach us also in the future. Thank you, everyone. With these words, God bless you all. Thank you.
Thank you, ma'am. Now I'd like to request Dr. Minu Bajpai, our chief guest for the day, to deliver his address.
Thank you. Chairman and Managing Director, KIMS Group, Dr. Bhaskar Rao Garu, President, Indian Rheumatology Association, Dr. Chandrasekhar, Dr. Raj Gopal, Senior CT Cardiothoracic Surgeon and former Dean of NIMS, Dr. Molly Thaba, my erstwhile colleague at AIMS, Dr. Sarath, Dr. Raj Kiran, all members of the organizing committee, members of the IRA, many friends in the audience, Dr. Uma Kumar, Dr. Harsha I met yesterday, and many of you here. It is a great privilege to have been invited to KIMS, and thanks to the members of the organizing committee who have invited me here. This is the 3rd Clinical Rheumatology Conference, which is an event, as was told just now, held biannually. And the core format is case-based discussions. This is where the crux is. And I was discussing with Dr. Bhaskar Rao, who was very passionate about this format, as just like Dr. Sarath Chandra. Dr. Sarath has been always. Now, I'll tell you, we align completely and synchronize with the activity of this kind at the National Board. I'll tell you briefly, we have less time today, but we'll tell you briefly about what National Board is about. So we conduct the examination entrance for the postgraduate throughout the country. This is under the Supreme Court order. No other body can undertake that exam. So last year we took the entrance examination NEET for 210,000 MBBS students, and we could offer only 67,000 PG seats. Now, we have actually increased the seats significantly over the last couple of years, and there are various ways by which we have done it, and we are continuing to do it. I'll come to that also briefly if we have time. Now, when you increase the number of seats, the major concern is not only the quantity, but the quality should also not suffer, because that's an immediate concern. There are many programs that should be high standards and there should be uniformity. To bring that, we have a headquarters at Dwarka in New Delhi, from which we have been conducting webinars, which we have further augmented. These webinars, many of you are teachers of that, participate into it, and many students attend it throughout the country. So there are lectures, there are complex case scenarios being discussed, and there are procedural videos which are being transmitted. We are further augmenting it by many other methods. Bedside teaching for the clinician is extremely crucial for their training, for their clinical practice, and for the depth in the academics which they can acquire. So we realize that because there is a very heterogeneous environment of training across the medical college, we give about 2/3 of our selected PGs to the National Medical Commission, which distributes it to a lot of medical colleges. 1/3 we keep with ourselves at the National Board, which are DNB and DRNB and fellowships. We continue to monitor these 1/3 students, 15,000 PGs, throughout the 3 years of their training. We do formative assessment tests periodically. We make sure that their theses are written properly, etc., etc. Whereas the seats given to the National Medical Commission, they are given to the medical colleges, and each medical college has a flavor of its own. There are some extremely good ones, and some are not good ones. This leads a lot of gaps. For ourselves, what we do, that we want to make sure that every hospital which is accredited, which is giving the DNB training or DRNB training, should meet the standards, and there should be uniformity of the SOPs that are being transmitted. In order to enable it, we created an app through the Tata Consultancy Services, something like which Dr. Bhaskara was telling they have done in the form of EduTech. So that TCS enabled, we have made an app which is smartphone-based app. For each specialty, the course material will be populated in the smartphones. And at the end of a ward round or a clinic or an operation theater, wherever, a resident would look at it and see what if he has seen 3 or 4 cases, he will tap and see, is he able to answer questions, the relevant questions from that? Have he learned something? And if he has not, he will go to the next step to see the core points of that case. Now, this he is doing throughout the day, wherever he is, and throughout his training, which would bring him center stage to his own formative assessment. Where is he? It is not punitive. We have not given marks to it yet. In fact, it is yet to be properly launched because we were facing issues of how to populate what material to use, because we were fearing plagiarism when you take material. So we created a tender for e-library, and then we'll be totally sacrosanct in populating it. This is just in brief about what is being done to bring uniformity and training, and to bring bedside training, about which we are all concerned, and Dr. Bhaskar Rao very eminently, and Dr. Sarath yesterday night when we were together in the dinner, throughout that period we discussed that part. So we believe that the clinical scenario-based teaching interactive with students is very important. We are creating already in a very advanced stage of a National Center for Skill Development, which is as important for the training as anything else. This will more for surgeons, simulations, but also soft skill development, clinical history taking, how to break a bad news, etc. This is skill development. It will be a central national center, but we have identified 25 centers across the country so that local regional centers, doctors, DNB don't have to travel all the way to Delhi every time. We are endorsing those centers and it has already been launched, should be on the website already. Fourth thing which the President IRA mentioned just now about the AI/ML. AI/ML we cannot escape. Elsevier group of publishers, you may all know, they conducted a survey in several countries and they came out with a crisp conclusion from 3,000 clinical physicians that technology literacy will take the upper hand on their clinical literacy if it is not addressed. So people ask, is AI going to replace doctors? That is not true. But a doctor who is AI enabled is going to replace the doctors who are not AI enabled. Concerned with that, and there is a lot of economy involved, the total economy projected by 2035 globally GDP through AI and ML is $15 trillion. 1/4 of it is health related. Obviously, because of the academics, because of the necessity, because the development of medicine can happen only through that route in the times to come, we are launching a fellowship in AI/ML along with Madras IIT. We had a meeting with all 6 IITs, including adding Institute of Science in Bangalore, and we have all synced that we are going to have a 2-year fellowship. The minimal eligibility criteria would be MBBS. Any PG can also join. Like an ophthalmologist, if you want to work on artificial retina, a nephrologist on artificial kidney, cardiologist for those catheters. And I'll just tell you, the best cardiac catheterization catheter, at the tip of it is a camera which is developed by NASA. Imagine the level of quality which is required in today's time, the precision. Gone are the days when the Vaidya used to see pulse and give diagnosis. It's very molecular, and Dr. Sarat Chandra practices that very well. Finally, the President mentioned about, Dr. Rao mentioned about challenging the doctors, the challenging residents to the teachers and vice versa. So if we, as Dean Academics in New Delhi, I realized that the MBBS students don't attend classes. This was going on for 10 years. They don't come to the classes. Let us punish them. Let's do biometry and then do this and that. I said, we are actually barking the wrong tree. If they're not coming to the classes, there are reasons for it. We select the best students. If they don't come to the class, the fault is with us probably as well. So I looked at the American survey on a similar problem, and that is a very clear verdict on that. Students, even in the US, don't attend classes. They want to crack the board examination, and they get enough material on the platforms, social platforms. Why should they come to the classes? But here is what when I had a meeting with all the HODs in Delhi, I only appealed to one thing, that we have to make sure that the students know that past notes of the seniors which they rely upon when they don't come to the classes are already outdated. Therefore, if you go only to the social media platform, the material will be superfluous. You will not know what to actually distill out. The teacher's role would be to tell you, this is right for you, this is the middle of the road. And teachers should do it also. Cannot just declare and expect. Now, while we are contemplating this, the new mode of training has now come up for the UGs. And same can be applied, just like the app I was talking about, to the PGs, which is called blended learning. And this has been going on in Harvard for decades. In Harvard, about 40-odd Nobel laureates take classes for their students. Similarly, today's trend is that the students are given material before they come to the class so that their basic foundation is well known. The teacher will only take them further. These are flipped classroom concepts where there will be interaction. And these interaction can take several levels depending upon how deep you go. And when we say you go, teachers, us, we have to hold the hand. We can't be just professors and additional professors. By name, we have to contribute that way. So our activity has to go dig deeper. There are models available. this is going to be the way. The old libraries with books decorating the shelves is not anymore working. You don't see students going to the libraries anymore unless we change the format of the libraries. And that's why I wanted Dr. Srinivas to come here. He is also the patron of the National Medical Library. Unfortunately, he couldn't come. I had a meeting with him at the National Medical Library, Delhi, along with some major publishers like Elsevier's and all. The idea was, let us change the format of the libraries of the country, make them interactive, create those platforms of the blended learning type so that students can go there. If they can't do it in the class, they can go there off time, etc. These are many things which are happening. One more thing for the administration point of view, I'll just briefly mention to Professor Bhaskar Rao, is that we have also launched joint accreditation. Now, we are short by 15 lakh specialists in our country. We produce only 65 to 67,000 every year. Now, this way we can never reach the target. A lot is happening global level, that global health economy is going to be $12 trillion, just health economy, in addition to the AI I told you about. Therefore, our doctors will be poached away unless we create enough for ourselves and create surplus for the world. So we have launched the joint accreditation scheme when a major hospital like KIMS can reach out to a district hospital, hold hand, this will be official. And your trainees can go there. There is plethora of cases in the district hospital. But the only thing, they are not regulated, they are not guided, the treatment is not very guided, technology is not available for investigation. But with, for example, KIMS and a district hospital nearby, you can have a DNB program, student coming, numbers of seats would increase, the teaching bed numbers will double up, if not triple up, and those hospitals will get technology which KIMS has, you will get the patient for your training, etc. This scheme has already been launched last year by the Honorable Minister, Dr. Mansukh Mandaviya ji. So all this is happening. It's a very dynamic state in which National Board is. I'm extremely happy to see the growth of KIMS and similar hospitals in the country. Today is the time of multi-specialty hospital. They're going to mushroom. It has brought in huge economy in terms of more than 120 billion in the projected 2 years. So I'll stop at this and compliment the organizers for creating a wonderful platform for training. Thank you so much.
Thank you very much, sir, for your valuable insights. Now I'd like to request Dr. Sara Chandramouli Garu to propose the vote of thanks and also outline the rules and roles of the faculty.
Thank you, Dr. Minu Bajpai sir, for coming all the way from New Delhi to inaugurate the conference, sir. And I also thank Dr. Bhaskar Rao Garu, our CMD, and our President of IRA, Dr. Chandrasekhara, Dr. Moli Taba, Professor HOD, Jipmer, and the scientific chair for this conference, and Dr. Raj Kiran. And thank you all the delegates and senior faculty for coming for this conference and sharing your knowledge and also giving a good teaching material for the students. We are missing out one important person here. Dr. B. Srinivas, he is Secretary to National Medical Commission. Yesterday evening, I got a message from him saying that his father fell. He is unwell, so he had to cancel his flight. So we missed him. So first time probably in the history of Indian rheumatology, the conference is endorsed by the National Medical Commission and also by the national boards. So and also in the CME credit hours, the certificate, now we call it the CPD, Continuous Professional Development Certificate, the NMC and also the national board dignitaries signing the certificate. It's the most valid CPD certificate. With that, we'll go to the rules and the roles for the faculty. Quickly, I'll wrap up in a couple of minutes. So we received around 160 abstracts and around 96 images. So we categorized the abstracts into disease-wide, session-wise. In each session, the top 4 abstracts, the judges, we sent it for reviewers. They selected the top 4 in each session. So those cases will be discussed here. And ultra-short cases selected from these abstracts will be in the rapid-fire session. And followed by rheumatology quiz today and tomorrow. Preliminaries followed by finals tomorrow. Then tomorrow evening, the sessions will end with image competition. So quickly, I'll tell about oral session, oral presentation, how it works. 4 top cases, selected ones, will be discussed. 8 minutes for the presentation, 20 minutes for the discussion. That's the beauty in this conference. So more discussion than the presentation. I request all the presenters stick to the timing. We actually told everyone, don't pass more than 12, ideally between 10 to 12 slides. But there are some presenters, they made up to 20, 23, 28 slides. So I told them to cut it down. You couldn't, then at least stick to the time of 8 minutes only. Then next 12 minutes for the discussion. So 20 into 4 cases it makes 80 minutes. Then last 10 minutes, the rapporteur will wrap up the session with the take-home messages. This is the format for all the oral presentations. Rapid fire, we selected 12. If you have case, we have 2-3 cases also to add. So each case will be given 5 minutes, 4 to 5 slides ideally. If you have more than that, stick to your timing. 3 minutes for the presentation and 2 minutes for the discussion. So in 1 hour rapid fire session, we'll be able to discuss 12 cases. In image competition section, 96 I think we received, top 30 were selected. So 30 seconds for each image or each case. So in 15 minutes we can finish 30 slides or 30 cases. In the last 5 minutes will be quick discussion followed by the panel will tell who are the top 3 winners. And the panel is so impressed with the kind of image cases they received. Dr. Yojana yesterday told that it's very unfair to lose some of the cases. They're good enough to get top 3, but I couldn't place them because the other also good. So she suggested 4 special prizes, consolation for the next 4 also. So with that I conclude the inauguration. And now I request the dignitaries on the dais to release the souvenir for the conference. It came up very well. Dr. Srinivas from our KFRC, that is research wing in KIMS, and Dr. Moli Taba helped very well. They worked hard to make it available for us.
While the dignitaries are here, I would like to request Dr. Sarath Chandramouli Garu to present a token of appreciation to all the dignitaries on the dais. to Dr. Minu Bajpai. Next to Dr. Bhaskar Rao Garu. To Dr. S. Chandrasekhara.
Sorry, small surgery reverse.
To Dr. Molly Taba. To Dr. Raj Kiran. And I request Dr. Bhaskar Rao Garu to present a memento to Dr. Sarah Chandramouli. We will now proceed to the scientific program, and I hope you will all have a scientific feast.
Can we all have a moment of silence for Professor Dr. Devashish Danda, sir? Thank you.
We will proceed to the scientific session, and we'll start the session on rheumatoid arthritis. I request the chairperson for the session, Dr. Sanjeev Amin, to kindly take over. And I would also like to invite the panelist, Dr. Dr. Arul Rajamurugan, Dr. John Matthew, and Dr. Venkatesh Pai. Thank you, sir. Over to you.
A quick announcement. Dr. Minu Bajpai, I request him to stay for some time. If any of our senior faculty would like to interact with him, take some advice, suggestions, or if you want to give any inputs to the national boards. So he's there, and we have a meeting room next door in the same floor. So you can utilize his services while he's here with us. Thank you. Over to Dr. Sanjeev Amin sir and his team. And I request everyone to stick to their timings. We're already 45 minutes late. So everything will be dead. Please excuse me for that. It's not in our hands. So at least try to maintain the time. Thank you. What is it?
Thank you, Sharad. Thank you, the great dignitaries. It was Dr. Bajpai who's given us a huge eye-opener onto what we have to look forward in our country. I think the National Board is doing a fantastic job, sir. Very impressive. Your talk was excellent. I, for the sake of time, will not occupy this position for more than a minute. Most of you are aware that now I'm into my 35th year of practice. Professor Ramnath started at SGPGI. I started a private practice in two parts of the country, different parts of the country. And I have been lucky to be able to implement what is known as an EMR-driven practice. I take this opportunity that I did an audit of the last 100 patients who attended my office last month, and 40% of them were rheumatoid arthritis. So 40% of the patients attending an office clinic in a private setup in a metropolis city, Mumbai, rheumatoid arthritis is the absolute reason why we are beginning this great CRC 224 with this topic. I have gone through the 4 cases being the chairman, and the panelists have also gone through it, the rapporteur also gone through it. 4 excellent cases. And as clinicians, this is a clinical conference, the essence would be that in that office practice, when you have that 15 to 30 minute interaction of a rheumatoid arthritis being the bulk of the patients coming to you, how would you be able to quickly pick up in a single instance the correct diagnosis of these 4 patients? So we are going to discuss this in detail. The panelists, the rapporteur is going to wind up everything, and you are going to ask as many questions as you can in the given time space. Thank you, sir. Can we have the first speaker? It's an 8-minute. Is it Ruby? Come, please. Come, please come.
Good morning, one and all. I am Dr. Ramyashri from St. John's Medical College, Bangalore. I'll be presenting an interesting case of rheumatoid arthritis today. She's a 34-year-old female with no comorbidities. She presented to us for the first time in 2016 with chief complaints of joint pains for 3 years, which were additive inflammatory RA pattern involving both small and large joints. She denied any history suggestive of connective tissue diseases or no history of any psoriasis or IBD. She did not had any deformities or no other extra-articular manifestations. On evaluation, her rheumatoid factor was positive and her anti-CCP was high titer positive and inflammatory markers were positive. She was diagnosed to have seropositive rheumatoid arthritis with moderate disease activity and she was initiated on methotrexate and HCQ. Further, she was on regular follow-up visits every 3 to 6 months, and in 2020, over time, she has achieved clinical remission, and she was on stable doses of methotrexate and leflunomide. Then she presents to us in 2022 with history of exertional dyspnea for 1 month, which had worsened for 1 week, nocturnal dry cough for 1 month, and she also had developed pregangrenous changes of her left third toe. On examination, she had tachycardia and all her pulses were well felt. She also had tachypnea and her JVP was elevated. Her respiratory system showed evidence of crackles bilateral and also her S4 was hurt. However, there was no active joint inflammation at that point. She also had Lewis discoloration of her left third toe. Looking at her routine investigations, we were actually surprised to see that her total counts were significantly elevated, with her differential counts majority being eosinophils. Her absolute eosinophil count was about 20,000. Her inflammatory markers were mildly elevated. When we look back at all her complete blood count picture reports, we found that there was some amount of eosinophilia being persistent from 2016 since the time we had seen her. So when we went back and asked her history, whether she had any history of allergy or asthma, there was no history, and there was no history of any parasitic infestations in the past. She did not had any constitutional symptoms. She denied any significant drug history apart from being on methotrexate and leflunomide. So she's a case of RA with persistent eosinophilia without any allergic manifestations. For her breathlessness, when we evaluated, her chest X-ray showed bilateral CP angle blunting, and her 2D echo showed thickened posterior wall of the left ventricle and also biatrial enlargement. She had grade 4 LV diastolic dysfunction with severe PAH. Her ejection fraction was well preserved. Her NT-proBNP was about 10,000, suggestive of failure. So we went ahead and did her cardiac imaging. She underwent cardiac MRA. Which I am pointing out is a normal heart, where we can see the short axis view and also the long axis view, where we can see synchronous contraction of the left ventricle with the normal ventricular wall. This is the video of our patient, where we can see the left ventricle is significantly thickened, and at the same time we can identify some synchrony. And delayed gadolinium contrast showed enhancement with peripheral rim enhancement and also an overlying thrombus which is present adherent to the left inferior lateral wall. So now we had a lot of questions in our mind at this point of time. What could be the etiology of hypereosinophilia in a patient with RA? And whatever the cardiac disease she has developed and digital gangrene, whether everything is relevant to eosinophilia, and what could be the reason for the restrictive cardiomyopathy, and whether the whole disease process is related to long-standing RA itself or not. So the various differentials which we had put up in an order were hypereosinophilic cardiomyopathy with cardiac amyloidosis and also small vessel vasculitis, especially EGPA. So to understand further, we had further evaluated her. Her serum IgE levels were normal. Her stool for OVA and cyst was negative. We had done ANA and immunoblot, which were positive, but however were not relevant in the current context. APLA was negative, and PR3 MPO ELISA were negative, and the test to rule out amyloidosis was also negative. So we also, to rule out malignancy, eosinophilic malignancy, we also did a bone marrow which had showed significant eosinophilia, but there were no plasma cells or any blasts. And we also had done special staining and also karyotyping, which was negative, and FISH studies were also negative for chronic eosinophilic leukemia. So finally, we labeled her as seropositive rheumatoid arthritis with primary idiopathic hypereosinophilic syndrome, since we did not identify any specific diagnosis for hypereosinophilia, and restrictive cardiomyopathy, that is Loeffler's endocarditis. We started the patient on steroids, and she received anticoagulation, diuretics, and antiplatelets and beta blockers. Over 4 weeks of follow-up, she had significant improvement, and her breathlessness has improved to NYHA class 1, and her repeat eosinophil count has reduced from 20,000 to 11,000. So these are my following questions to the panel members. Sir, what could be the prevalence and what could be the cause of eosinophilia in a patient with long-standing rheumatoid arthritis? And could this eosinophilia in our case be related to the RA disease process, or is it anything else? And if we treated this patient with steroids, and how long are we supposed to give steroids to this patient? And in case the patient doesn't respond, will there be any role of second-line immunosuppression?
Thank you, Dr. Ramya.
Yes.
She's finished in perfect time. Here? Sorry. Now, am I audible? So, if I'm not audible, just bear with me. Simple, straightforward case. It's not a long-standing rheumatoid arthritis, Ramya. About 8 to 10 years.
10 years,
2016 is
yes.
when you've seen it.
By then, she had 3 years of history of joint pains, sir. So,
And largely doing well. So just
Yes.
on a methotrexate, leflunomide, did very well. And more recently, you got those 3 cardinal symptoms: dyspnea, cough. But a small catch was that gangrene or P. gangrenus in a toe,
yes.
which sort of was the beginning of the entire thought process. And you had clearly more than 1500 AEC, that is absolute eosinophil count per cubic millimeter, which said that yes, she qualifies for hypereosinophilia. Now, the panelists are going to discuss, the questions are going to come there, but one thing that we are missing on, what is the relevance of that anti-histone antibody that was reported. 2 is the leflunomide, whether that is a somewhat contributor, or is this a purely independent case? Because when I did a small WHO, or a small Google search, it's from Durga Prasad Misra.
Yes, sir.
There is one
Yes, sir. One review
publication,
article.
because in that part of the country, I think helminthiasis is more, and there is some
Yes,
mention
yes,
about it.
Yes.
But this is, your patient is nowhere near it. To me, to my sense, it is that it's an independent thing altogether. And it's what I wrote to you, worth case reporting, right?
Yes.
So panelists, would you like to discuss?
Actually, this patient has 3 problems. One is rheumatoid arthritis,
Yes, sir.
which is a chronic one. Number 2, eosinophilia. Then cardiomyopathy. These are the major causes.
Yes.
In one study, they have done the estimation of eosinophils in rheumatoid arthritis. The prevalence is around 20%.
Yes.
Actually, it is 21.6% exactly. This is mostly due to this disease activity.
Okay. Okay.
Then they have looked at the other causes of hypereosinophilia. Helminthic infection tops the list, and disease, and the drugs like methotrexate. Methotrexate is implicated as one of the causes of eosinophilia. But whether it causes to the extent of this one, going for cardiomyopathy, is not in the literature. So like any other patient, a rheumatoid patient might have developed this hypereosinophilic syndrome. So that is one idiopathic hypereosinophilic syndrome. Maybe that has led on to this cardiomyopathy and so on.
Yes.
Then coming to the gangrene aspect, either it could be a rheumatoid vasculitis or it could be a thromboembolism. You have
Yes.
shown that
Yes.
demonstrated thrombus, no?
Yes, sir.
Even hypereosinophilia can cause gangrene. So there are many causes for gangrene in this case. So the aspect is, looking at this is, one is disease activity per se, or maybe idiopathic hypereosinophilia associated with rheumatoid arthritis. So in this angle, if you approach, the drugs as of now, you have used this as steroids. That is well and good. Then next one is omalizumab. You can try that omalizumab.
Okay, sir.
So other than that, it's managed well. And last question is the duration of steroids. Maybe like any other hypereosinophilic syndrome. Steroids used for 3 months, then taper down. Then you can add other drugs. So this is how this case may be managed. So these are the likely possibilities.
Okay.
Anything more to add?
Actually, when I look at it, actually, first time when the patient came in 2016,
Yes, sir.
actually she had a hypereosinophilia.
Yes.
And a couple of times more she had it. So by definition, she fulfills criteria for hypereosinophilia right at onset of presentation.
Yes, sir. Yes.
And as hypereosinophilia without any organ manifestations, you don't have to do anything. You have to closely monitor.
Yes, sir.
And you are always worried about myeloid or lymphoid variants of hypereosinophilic syndrome causing a malignancy. And then probably the case is excellently managed. One thing we carefully look for is a peripheral smear, always looking for blasts and follow-up. And the myeloid variant of hypereosinophilic syndromes, they tend to have a high B12 levels.
Okay,
So that monitoring could have helped.
Okay.
And another way of looking at it is, when you are treating rheumatoid, and there is data saying methotrexate helps hypereosinophilic syndromes, other than the first line aging means steroids. So knowingly or unknowingly, probably we were treating the hypereosinophilia as part of management of rheumatoid arthritis. And so that's, and the case is excellently managed. But if I get a case of cardiac involvement due to hypereosinophilia who comes breathless, maybe I would have pulsed her because I'm worried about whether the eosinophils will damage her myocardium, and the eosinophils have already damaged her digit, has called. So maybe I would have pulsed her and then steroids and see the response. But definitely, even in the long, so that's about the management issues and whether we need to follow up and see whether we need to give any tyrosine kinase inhibitors, because imatinib has been given in myeloid variant of hypereosinophilic syndrome malignancies. So, and actually there is data coming up, everything we give to tofacitinib, but even there is data saying like probably a JAK kinase inhibitor may help in management of the hypereosinophilic syndrome per se. And so that's regarding the management thing. And long term, definitely she should be under, you have done a bone marrow, but a single bone marrow, there is a small possibility you miss out a eosinophilic blast, and also that is one thing you would keep under follow-up. And anyway, you have done the mutation, which is negative. Yes. So that's what I would say.
No, sir, they were actually not willing for that. And do we need to monitor this absolute eosinophil count frequently to understand the response for the treatment, or will it go hand in hand? Or
I would say the steroid dose and medication dose is depending on your eosinophil. That's what you go. But now you have an organ involvement here, the cardiac myocardial involvement, and so definitely you will go by the organ involvement. And actually, clinically, you said the patient had crepitations, but HRCT I didn't see.
We didn't perform HRCT, sir. Only chest X-ray we had done it.
Because lung infiltrates is quite commoner in hypereosinophilic infiltrates. So definitely there are two organ systems which can go by on follow-up. One is the myocardium, and second is the lung. So if so, those will be the way you decide on steroid dosing and the second line agent. But on a day-to-day regular follow-up visit, probably the eosinophil count, keeping it normal would be the thing.
Yeah, we had ruled out them. Yes, sir, we had done that.
There was a mention when I was reading up is that we should also treat these patients empirically with ivermectin, strongylides, also in our country, maybe one of the contributors to eosinophilia. And the other little thing that I could pick up was that the release of the eosinophil granules causes nitric oxide to get consumed, and therefore that toe could have been a part of the vasospasm just because of the eosinophilia in that little toe over there. Any questions from the audience, sir, on this case, please? 1, 2, yeah. Can we get a mic there, please?
excellent presentation. I am Dr. Israrul. I just wanted to ask about the management. We had a myocarditis-like picture in this patient and a underlying possible diagnosis of vasculitis or hypereosinophilic syndrome causing a myocarditis, which is a severe organ involvement. The usual approach in most of the autoimmune diseases is starting giving a methylprednisolone pulse. Plus, we also give a second immunosuppression in most of the patients. So the last line that's sir, what is the opinion regarding adding a second immunosuppression? Will methotrexate and leflunomide will be sufficient for this patient at this stage?
I think current data of hypereosinophilic syndrome is pulse methylprednisolone and steroid with a tapering dose. Upfront, second line agent, I think the data is not there. But with there's a relapse of peripheral eosinophil count, which probably would be what's happening in most of the situations, then you can add the second line agent. So of course, methotrexate is a possible option. Hydroxyurea also, even though it's like not a malignant situation, hydroxyurea, or maybe there might be data coming up on tofacitinib because JAK inhibitors, which contributing to the eosinophilic causing the proliferation and tissue damage. So maybe a possibility. So I think it's a good question, but I think they had done the mutation analysis, which was negative. I would always get a hematology opinion. So probably imatinib as per se for the myeloid variant of HES may not be an indication, but still people use imatinib at a lower dose just for hypereosinophilic syndrome without the malignant thing. And maybe that's what, like taking it a little forwards, maybe another JAK inhibitor like tofa may be an option actually.
Actually, why not put the diagnosis as idiopathic hypereosinophilic syndrome? Because everything, this patient had polyarthritis initially, then had various autoantibodies positive, like rheumatoid factor, anti-CCP, ANA, and anti-histone. So it is known that various autoantibodies can be present in various proportions, pretty high number of patients, even to the tune of 30%. And then this patient had hypercoagulable state. There was cardiac involvement and possibly there was lung involvement also, because you said patient has crepitations. And eosinophilia was documented from the very beginning. So what is...
It's an excellent question actually, yeah. A difficult question. But anyway, when somebody comes with a hypereosinophilic syndrome, my first concern would be I want to rule out a primary hypereosinophilic syndrome because it's a malignancy and it is treatable. So I wouldn't want to miss that. And second is the secondary hypereosinophilic syndrome, which have an associated condition which needs to be treated. The treatment response will be good. And as Dr. Umar said, which most likely this case is an idiopathic hypereosinophilic syndrome, but it's always a diagnosis of exclusion. You rule out the first and second, and which is less common, but you make sure they are not, 75% will be idiopathic hypereosinophilic syndrome, but you want to make sure you're not missing out 1 and 2 before you treat 3. So that's why.
From Ahmedabad. It's a process which we are interested in. Is it a vasculitic process leading both with the time of? Okay, whether it's a vasculitic process causing both the gangrene and the myocardial injury, because we know now in EGPA the subset is ANCA negative, affects the heart, although it's not classically restrictive, and it also affects, causes gangrene, so something like that. A biopsy from somewhere would have probably.
Two things which I felt against EGPA were the long disease process. She had the symptoms from 2016, arthritis, and she's doing good. And the other thing is she didn't had any constitutional symptoms, sir, which again with so much process happening, I felt she may develop some constitutional symptoms which is actually not there.
Be an overlap, no?
So, Sapan, the answer is eosinophilic granule deposition in the myocardium gives rise to the chylomyocytis. And it is the nitric oxide which gives rise to that venous vasculitis. So it's very clearly in the biopsy would of course been helpful, but there are special stains for that. I think that's great, Ramya. That was very nice. Yes, Yojana?
No, ma'am. She followed up for a very short period of time. After that, she's lost to follow up. Only eosinophil count is what we had done it, and she had clinically improved. Her breathlessness had improved, ma'am.
Yeah, but actually cardiac MRI helps in monitoring as
Yes,
well.
yes, ma'am.
Because like, those, that uptake which you said, no,
Correct,
post
yes.
like enhancement, that will go once the patient
Yes, ma'am.
is showing
Yeah.
improvement. So that will help.
Thank you, Ramya. Thank you very
Thank
much.
you, sir.
This was
Thank
very
you.
good. Thank you. We'll go with our next speaker, right? The next presentation. Molly, who's the next presenter?
Sir, I'm
Oh, you're there. Ruby, okay, fine, Ruby.
Good morning, everyone. I'm Dr. Ruby. I'm a DNB resident at KIMS Hospital, Hyderabad, and I'll be presenting a case titled RA or TB, the joint confusion, which is quite frustrating. Thank you. So this is a story of a 39-year-old female who came with 1-year history of pain in the right shoulder, which was more at rest and accompanied by early morning stiffness lasting for 30 minutes, which improved with activity. She experienced gradually progressive difficulty in reaching overhead objects due to painful restriction over the next 6 months. Additionally, she reported pain in her left hip, which was present both at rest and while walking for the last 4 months. Upon review of symptoms, there were no indications of other joint involvement, low back or neck pain, psoriasis, or inflammatory bowel disease. Symptoms suggestive of connective tissue disorders were also absent. There was no significant past history. She was evaluated elsewhere. Investigations revealed elevated inflammatory markers, an ESR of 52 and a CRP of 12.8. Rheumatoid factor was positive, whereas anti-CCP was negative. MRI was done. The right shoulder demonstrated cortical irregularity with marrow signal abnormality in the head and neck of the humerus and proximal shaft. There was mild synovial thickening with fluid in the bursa, suggestive of inflammatory arthritis with erosion. MRI left hip showed mild effusion with minimal synovial thickening and mild marrow edema in the femoral neck and acetabulum. So she was diagnosed as seropositive rheumatoid arthritis. The initial treatment was with low-dose glucocorticoid along with methotrexate, 7.5 mg weekly, which was escalated after a month to 15 mg weekly. 2 months later, she had no response, so leflunomide was added at 20 milligrams once daily. And 3 months down the line with this combination treatment also, she continued to worsen. Her movements were restricted, so an imaging was repeated. This is the MRI of the right shoulder, showing synovial thickening with mild effusion in the glenohumeral joint, multiple erosions and joint space narrowing. There's mild edema of the supra and infraspinatus tendons and bicipital tendinopathy. MRI left hip showed diffuse synovial thickening with reduced left hip joint space and reactive marrow edema. At this point, she was being treated by a doctor outside, and she was switched from the combination of methotrexate and leflunomide to tofacitinib 5 milligrams twice daily. She visited us because there was no improvement in symptoms. She still had persistent pain in the right shoulder and the left hip, and there was stiffness with restriction of all movements of all planes. On examination, she was conscious and coherent. Vitals were normal. General physical examination was unremarkable, no lymphadenopathy. Musculoskeletal examination showed tenderness in the right shoulder with painful restriction of movements in all planes. There was tenderness in the left hip and painful restriction of the internal rotation of left hip. Other systemic examination was unremarkable. We performed further investigations. Her inflammatory markers were persistently high. ESR was 40 and CRP was 10.2. So this is a case of a lady who's come to us with a 1-year history of involvement of 2 joints, the right shoulder and the left hip. and very rapid progression of a disease causing restriction with persistently elevated inflammatory markers despite being on treatment. So we just wanted to rule out alternate etiologies. So instead of doing an MR because she had already undergone multiple scans before, we proceeded with an ultrasound of the right shoulder. Large erosions were noted in the right humeral head and greater tuberosity, with collections extending into the bicipital groove and periarticular soft tissues. It's highlighted by arrows, with internal echoes. And there was a peripheral color flow noted surrounding the collection. So synovial fluid analysis was done from the right shoulder. Smear for AFB came positive. Gene expert for Mycobacterium tuberculosis was positive. And later on, we did get the TB culture, which was grew Mycobacterium tuberculosis, which was pan-sensitive. She was initiated on anti-tubercular therapy, that is isoniazid, rifampicin, pyrazidine, and ethambutol. And we revised the diagnosis to tubercular arthritis. So just a slide on the discussion between rheumatoid arthritis versus tubercular arthritis. So points favoring rheumatoid arthritis would be a middle-aged female, elevated inflammatory markers, presence of erosions, and rheumatoid factor positivity. But points against rheumatoid arthritis, the rapid progression of the disease, atypical involvement of joints, there are 2 large joints involved here, marrow signals not only in the joint but across the bone as well, including the neck and the shaft, and there was no response to treatment. Points favoring tuberculosis was presence of large erosions, a rapidly progressive course of the disease, and large joint involvement. And against is the absence of constitutional symptoms. So my key questions to the panelists, what are the clinical clues that can help in differentiating between inflammatory versus infective arthritis? And what are the imaging findings that could aid in distinguishing between these 2 conditions? Thank you.
Thank you, Ruby. Now, very relevant questions. We are endemic tuberculosis. So amongst all infections, this is more likely to happen. I just want to make a very other small point is that globally we are moving away from the use of corticosteroids steadily and progressively. One has to consider that in an endemic country like India, exposure to tuberculosis may be one of the reasons to have a higher incidence than would have been otherwise. I did send your presentation to a musculoskeletal imaging specialist in Mumbai, who's been working with me for the last 3 decades. And he only said one thing to me, is that from an imaging, that's your second question, how could you differentiate between the 2? That's difficult. So his proposal was we have to lower our threshold to using intervention to get a diagnosis. So imaging, according to a specialist, has limitations to make a precise diagnosis. But imaging should be used for a tissue biopsy. So that's very important.
Actually, first question is infective arthritis. Do you want me to discuss tuberculosis or even non-tuberculosis? So non-tuberculosis, everyone knows the presentations. Tuberculosis arthritis sometimes deceiving. Most of the times they present with monoarthritis, swelling disproportionate to the pain. And we ask for family history or exposure history of tuberculosis in an immune suppressed state, age, associated malignancies. So all these things are the predisposing factors for the development of tuberculosis. So especially when it is knee monoarthritis, always we think of tuberculosis as a first possibility if it is a chronic arthritis, not an acute presentation. Rarely you get acute presentation in tuberculosis. So this patient has presented with shoulder arthritis. So obviously it's not the first diagnosis. Tuberculosis arthritis may not be the first diagnosis. So we want to rule out other causes. So this one, this patient has presented with shoulder as well as hip arthritis. So diagnosing tuberculosis, we now depend on synovial biopsy. Imaging features, MRI has some features which we suspect tuberculosis. Whenever there is a soft tissue inflammation, abscess formation, new bone formation, and actually we are not routinely saying looking for that, like involucrum and sequestrum. These are the two radiological findings that will give us a specific findings for tuberculosis. So whenever there is soft tissue involvement, even in sacroiliitis, whenever there is a soft tissue involvement, we suspect tuberculous etiology. The next thing is we can do this routine manto and quantiferon. Quantiferon now they have a newer one, TB platinum. The recent study, 2 days ago, I listened to one of the scientists talking about this plasma biomarkers in tuberculosis. Now they have come out with plasma biomarkers, chemokines and cytokines, which are more diagnostic of tuberculosis, and they use these biomarkers to assess the treatment response as well as the remission. Now the concept is, using these biomarkers, they are planning to cut short the treatment of duration of treatment of tuberculosis. Maybe if the biomarkers are normal, they say it is disease is under remission, so that we can minimize the exposure to anti-tuberculous drugs. Now this is the clinical challenge for everyone. So that's why as soon as I joined Madras Medical College, first study I took up was looking at the biomarkers in musculoskeletal tuberculosis. We have sent the proposals, but it is waiting for the funding. So we are planning to do that. Because most of the times patients may not be willing for synovial biopsy. So we are looking for biomarkers. Maybe in future we will get some biomarkers to diagnose tuberculosis. So whenever there is a chronic monoarthritis, we think of tuberculosis. There is a risk, think of tuberculosis. When there is soft tissue involvement, tenosynovitis, and low signal intensity synovitis. That is another feature of tuberculosis. Then of course, osteomyelitis, bone involvement. The next question, anything else? I think I have answered all your questions.
Maybe a comment actually. First of all, I know Kim's has managed this case very well. But before that, why was the rheumatoid factor done at all?
So this was done outside.
Yeah, that's what I was saying. So if somebody comes with a shoulder joint arthritis, when you order a test, you should be ready to make a decision of what if it's positive, what if it's negative. Just because somebody comes with a shoulder joint arthritis and a left hip joint pain and the rheumatoid factor is positive, does not mean it is rheumatoid arthritis. That's the first learning point actually. Yes. Actually, suppose if it's a training registrar with me, I would have given a piece of my mind. If you do a rheumatoid factor for, a shoulder joint pain and monoarthritis, and, so that's the first thing. And then, then we went along a track, immunosuppressed, and then we created a culture for the mycobacteria. Yes. And then, so for the second doctor, the diagnosis became easier because, it's always like that. But, so we got a good culture for the bacteria. But a few comments I would like to make is, one thing we swear by is expert for diagnosis of TB. But I think being a registrar's meeting predominantly, we have to always understand that expert has a sensitivity of only 80%. Suppose you had taken out a fluid and sent an expert and it was negative, in a patient with monoarthritis, don't think it could not be TB because there's a 20% you could have messed it up chance. And even if you do an ultra expert, which is said to be much more sensitive than expert for TB, MTB, it's also only 90% sensitive. Again, there's a 10% loss in diagnosis. And culture, obviously, it's only 70% sensitive. But by the time a patient had come, he had been enough immunosuppressed to that. Actually, there are two situations. Like I had a patient. One thing is tuberculous arthritis is common in the hip and the knee. Yes. Compared to the other joints. The commonest is osteoarticular tuberculosis. Maximum is the spine, spondylitis, and the joints commonly affected are the hip and the knee. Yes. And this is like which shoulder is uncommon, Yeah. But I had a patient who had rheumatoid arthritis, deforming inflammatory arthritis, long-term immunosuppression, developed a single joint is not going into remission. The same right shoulder was not going into remission. And then we evaluated it further and found to have Mycobacterium tuberculosis. So that's a rheumatoid arthritis having a tuberculosis arthritis. But this is like a primary tuberculosis arthritis presenting thing. And then this is the points which I would like to mention, like, not to miss out the first initial diagnosis had to be right, and then be careful when you rule out tuberculosis, the investigations. And then, I think Dr. Arul sir had discussed all the other things. And as they're rightly done, probably MRI would be the investigation of choice compared to a CT, because you can as you saw, like, you picked up all the soft tissue involvement, abscess formation, muscle involvement. So MRI would be probably the best imaging investigation to do for which could differentiate particularly from a inflammatory arthritis from a infective arthritis because of the extent of involvement. And even like for an X-ray, in tuberculosis arthritis, probably the cartilage is better preserved till later on. So early inflammatory arthritis, you may have a more joint space narrowing compared to tuberculosis arthritis, you may not have it initially. And juxtaarticular osteopenia can happen in both on infective and inflammatory. This doesn't help. Yeah, I think that's what I would say.
Questions from please.
Sorry.
So we didn't find those reports actually, so yeah.
Yojana?
Yeah, actually, Dr. John Matthews said why RA was done in this patient, and you said that it was done before
It was
the
done
patient
before
came
he
to you.
came.
So my request to the residents is, because I actually analyzed some of these abstracts, is whatever was done before the patient came to your institution, please mention this was done before patient came to us, and this is after, because it is actually, especially things like vasculitis and all, you feel, oh my, these are interesting cases, why the things are messed up. They are messed up before the patient came to your institution. So before reaching us and after reaching us. That makes it more interesting.
Okay.
And Yojana, can you just remind us of your report on brucellosis of the spine?
Yeah.
Because when John talks about even ultra gene expert being 90%, so we are missing the 10%. So just brief us of how you identified those patients and did that. This was on the spine.
Yeah, most of those patients were admitted in ortho and were getting treated as a TB, whether involvement was of lumbar spine or dorsal spine, they were getting treated as TB. Now, to differentiate between the two, brucellosis is more common in the lumbar spine, whereas TB is more common in the dorsal spine. Coming to the diagnostic test, around clinically trying to diagnose, about 70% of them would give history of some fever, but then that fever may be, few months back to many months back also. Exposure to cattle or unpasteurized milk product is absolutely rampant in our country, in poor as well as in rich people. Rich Marwadi families and Gujarati families from Mumbai use tabela milk only, acha ghee aata hai, acha cream aata hai karke. And the poor basically don't buy half liter milk at a time. They buy when they drink black tea, and when some guests come, they go and buy 10 rupees ka milk or something like that. So they buy local tabela milk. Now coming to the diagnostic test, clinically this much, and unpasteurized milk is one thing. Even cheese, that is cottage cheese, paneer, may be prepared just by chemical or physical emulsification of milk, so may not be from pasteurized milk. Now lab test wise, radiologically it looks very much like tuberculosis. So you can get paraspinal abscesses, discitis, vertebral osteomyelitis, psoas abscess, so many things. Lab test, ELISA, IgG, IgM for brucella, and don't go for tube agglutination test, because tube agglutination test becomes false negative in a very short period of time. By 6 months time, almost 100% of the patients are brucella tube agglutination test negative. So go for ELISA, IgG, IgM. Actually out of this, IgM becomes negative by 1 year. So, and actually before 1 year when we analyze our data, in most of the cases, the average delay in diagnosis is 1.5 years, 15 months. So IgG positive, because if you are not treated, then
So the point to make is that we have to consider in our population brucellosis and non-mycobacterial for similar situations also.
Okay.
Yeah, one more question only, please.
Hello, I am Dr. Rajkumar from Patna. Actually, this case clearly shows how history and clinical examination is very important. This patient was never fit into the diagnostic criteria of rheumatoid arthritis. So this is the basic part. And if when you go to the investigation, MRI or ultrasound, pictures are not indicative of rheumatoid arthritis at all. If you see the picture of rheumatoid arthritis, you will see simply like subacromial subdeltoid bursitis, bicipital tenosynovitis, or little bit of supraspinatus tendinitis in case of like diagnosed case of rheumatoid arthritis. Yeah. So all those MRI finding bony irregularity and bone marrow edema, that was suggestive of infective rather than the what reported. It was reported like inflammatory, but it was likely it was infective.
Yeah, thank you, Dr. Kumar.
Thank you.
So I am Jyoti from Bhubaneswar. Actually, from the history and everything that we have seen, there is no doubt in the diagnosis. I have only two peculiarities. I have only two questions. One is, how frequently we get two joints involved, two very distant joints involved in tuberculosis, like this case. Number two is, what is the sensitivity of synovial fluid? I think the gene expert 80% have told of biopsy or fluid, but many a times we do synovial fluid analysis and we don't get it. Although this is tuberculosis. So these two questions. No, so how frequent is this two different joint involvement?
I'll answer your question, sir. What has happened is since this PET CT has come and we have been using it extensively, we find multifocal tuberculosis quite common, which is not symptomatic. So this is fairly common, and we assume that this is partly hematogenous spread, and also because what Dr. Yojna mentioned, we get mycobacterial from unpasteurized milk in our country, and most of it goes, and that is usually atypical mycobacteria. So this is extremely common. Thank you.
Thank you.
Can we now move on to the next case for the sake of maintaining our time? Molly, who's the next? Thank you.
Good morning. I'm Dr. Nandita from NIMS, Hyderabad. So this is an interesting case of an unusual association of a particular disease with rheumatoid arthritis. This is the case of a 42-year-old female who presented to us in 2018 with joint pains, both small and large joints of upper limb and lower limb, with early morning stiffness for about 2 years. On examination, she had multiple tender joints with swelling over the small joints of the hand and a fixed flexion deformity at the bilateral elbows. She also had a history of easy fatigability, also paler on examination. On investigations, her rheumatoid factor anti-CCP was positive. X-ray hand was suggestive of erosions at the MCP joints. There was carpal crowding, also juxtaarticular osteopenia. Her hemoglobin was 6.8. Iron studies had revealed an iron deficiency anemia and also an anemia of chronic disease picture. The patient was treated with parenteral iron and started on methotrexate, but she was lost to follow-up and non-compliant to medication from 2021. In December 2022, she had reported elsewhere with an arthritis flare, episcleritis, and a low hemoglobin again with a low MCV. She was treated elsewhere with low-dose steroids and HCQS. In June 2023, she presented to us with severe anemia and failure and arthritis flare. On investigating, her hemoglobin was 3.7, platelet count was 90,000, MCV was 85.9. She had anisocytosis, macrocytes and microcytes and elongated forms in the peripheral smear. And there was a conjugated hyperbilirubinemia also. So the differentials considered at this point of time were B12 of folate deficiency with an iron deficiency anemia, CLD, and hemolysis. So her B12 and folate levels were done, which was normal. Iron deficiency anemia was present. We had done an upper GI endoscopy, which was normal. Ultrasound abdomen was done, which was negative. In further evaluation, her LDH was elevated with a low haptoglobin, but DCT was negative. Her complete urine examination had revealed plenty of pus cells and trace albumin. Urine spot PCR was 1.18 and the 24-hour urinary protein was 450. We suspected a lupus overlap in view of hemolytic anemia, thrombocytopenia, and probable nephritis. ANA-IF was done, which was +3 rods and rings pattern. However, ANA blot was negative, dsDNA was negative, but she had low complements. The patient was treated with 1 mg per kg body weight of steroids, and 2 units of packed RBCs were given. Renal biopsy was planned to rule out a lupus nephritis, but her urine culture showed an ESBL E. coli, so we had to postpone the renal biopsy. On 1 mg per kg body weight of prednisolone, the patient had a worsening thrombocytopenia. In view of the same, a bone marrow aspiration and biopsy was done, which was reactive, however. On day 3 of the hospitalization in the first visit, the patient developed a left lower limb swelling, and we found a common femoral vein thrombosis on the Doppler. But her APS workup was negative. Eventually, her platelet count eventually improved to 1.1 lakhs, and the thrombocytopenia we thought was multifactorial, attributed to lupus disease activity and sepsis. So the patient was discharged on prednisolone and oral antibiotics, and we planned her for a renal biopsy at a later date. So the final diagnosis at that point of time was lupus with deforming polyarthritis, a lupus nephritis, thrombocytopenia, and a hemolytic anemia. In September, the patient came back to us with an ongoing hemolysis with anemia and failure. At this point of time, her hemoglobin was 4.8. Platelet count was 1.2. She had a low haptoglobin again, but this time the complements were normal, dsDNA was negative, and complete urine examination was normal. So why is the RBC still stressed? Is further evaluation necessary or just a change in immunosuppression? In view of the Coombs negative intravascular hemolytic anemia and a thrombosis, we had done a flow cytometry for PNH, which was positive. So 18% of the RBC clone were negative for the surface markers for PNH. And the granulocytes and the monocytes, it was 80% and 70% respectively, the PNH clone. So we can see here in the top image where this is the flow cytometry of a normal patient, wherein over the y-axis it is a surface marker for RBCs, while in the x-axis are the surface markers for the PNH. We can see that in the normal patients, it's positive for both the surface markers for RBCs and PNH. But in our patients, in the RBCs, 18% of the cells had an absence of the PNH clone. While in granulocytes and the monocytes, about 80% of the granulocytes and monocytes had an absence of the PNH clone. So our final diagnosis was RA with PNH, and we had started her on cyclosporin and steroids. So my key questions are, the complement deficiency in PNH is one thing, and in cases of a Coombs negative, in cases of Coombs negative, hemolytic anemia in lupus, do we have to work up further? Or we can stop at the diagnosis of lupus in cases of SLE.
You didn't give us some questions to answer. My panelists have to answer some questions.
The complement deficiency in PNH was the first question, sir. And the second question is, in cases of Coombs negative hemolytic anemia, in cases of lupus, do we have to investigate further, or we can stop at it and say that it's secondary to lupus only? Because we do see cases of Coombs negative hemolytic anemia and lupus too.
Correct. So this is what you did is perfectly fine. It's a normal, natural process to think in terms of lupus, rheumatoid lupus, because your hemoglobin went all the way down to below 5. So obviously lupus comes top of the line. And if I'm trying to think back and recollect, I don't remember of any patient in my few thousands of patients where I have picked up PNH or I have missed PNH. Yeah. So it's a very important case because our minds have to be open to things beyond lupus when we are sitting in a rheumatology clinic. I think, could you, Arun, can you?
One problem is anemia. In rheumatoid, whenever someone comes with acute onset anemia, first we think of drug-induced complication, either a bleed or a bone marrow suppression. Or if it is the patient is on methotrexate, think of folate deficiencies. The next is development of hematological malignancies and amyloidosis. These are the rare possibilities. This patient has had thrombotic tendency in the form of DVT. So when there is, of course, anemia, thrombosis, first possibility is yes, lupus. In this case, is there any evidence for lupus? ANA is not suggestive of lupus. Other than this, she doesn't have anything else. Whether biopsy was tried, renal biopsy?
Actually, the first visit, the complements were low, so there were 37 and 5. And the first visit, there was an ongoing UTI. So we planned a renal biopsy at a later date. When she came back, her complete urine examination was normal. So we hadn't gone ahead with a renal biopsy because the urine examination itself was normal.
So in our setup, when somebody comes with this type of presentation, one is we think of rheumatological illnesses like SLE. Next is we have to rule out whenever there is hemolysis, thrombosis, PNH. That's one possibility we should think of. But in that case, patient might be giving history of hemoglobinuria, passing brownish urine in the morning. But even in that, the recent concept is it is not actually a paroxysmal nocturnal hemoglobinuria. It can be a sustained persistent hemolysis in PNH. Previous concept was this nocturnal hemolysis occurs during the sleep because of acidosis and complement activation. Now the concept is it can be a persistent hemolysis. The patient need not have paroxysmal hemolysis, nocturnal hemoglobinuria or hemolysis. So these are the new concepts about PNH. But this is considered when somebody gives history of hemoglobinuria. Not in our patients, we don't see such a clinical person. It's more of a clinical suspicion. So that is one thing. But thankfully, have suspected this entity and worked up for that. For lupus, there are no points to say, specific points to say the patient has got lupus. Otherwise, he may fit into lupus. In PNH also, renal involvement can occur because of hemosiderin deposition. In that case, if you do an MRI of the kidneys, that will show the hemosiderin deposition and that will be a diagnostic of PNH. So in that case, you can treat it as PNH. You need not suspect lupus in this patient. These are two different entities. Next is anything else? APS workup negative. I think
Actually, any clinician, there are few wow moments like, you like to diagnose, you feel like, okay, you have achieved something. Or something like, I would say for a rheumatologist, if I diagnose PNH, I would be like really excited. And actually, I have never diagnosed a PNH. Maybe one reason is we send to a hematologist if you suspect something and then they do it. But I think probably why we would be missing PNH would be, as we all know, like, we are from second MBBS, we learned that PNH is intravascular hemolysis. And we are always looking for evidence of intravascular hemolysis, that is hemoglobinuria. Then if you look back at the numbers, actually, only 2/3 have hemoglobinuria. Yes. And 1/3 don't have hemoglobinuria. So absence of hemoglobinuria does not rule out a PNH. That is one thing. Yes. And second thing is, as interesting, it is any sort of inflammation, which could be like infection to whatever, which triggers the hemolysis and the thrombosis. So actually for this patient, because she had rheumatoid, and probably every flare she would be having hemolysis. Yes. And actually during the flare is what you're checking your counts. So basically every time they get a rheumatoid flare, they come to the rheumatologist, then you check the count, and then you have the hemoglobin which is low. But if you have something in between, probably I was just assuming it would have been normal. So that is one thing which I would like to highlight. And another, probably a significant part of PNH patients have aplastic anemia or MDS. Yes. So maybe at least 1/3 of them will have MDS, or down the line they develop at least like 10 to 20% develop aplastic anemia or MDS. So I think that is one thing we have to be looking for.
Yes.
And second comment I would like to look at is, you looked at the CD55, 59 deficiency on the RBCs, yes, which is what we generally do for a flow cytometry diagnosis. But I think if you look at what I understand is if you look at the granulocytes, yes, And those are the patients, if you have a deficiency CD55, 59 on the granulocytes, they are the people who will develop an MDS or a aplastic anemia. So I think probably that is one thing which should be interesting in this patient. And obviously other evaluation for previous thrombosis in other organs, like Arul sir had mentioned about the renal infarcts, and probably need to be evaluated for myocardial involvement or pulmonary involvement. Pulmonary hypertension is maybe seen more frequently. Those are the things which I would look for in this patient actually.
There was no evidence of pulmonary hypertension or Budd-Chiari syndrome also, sir, because we had done a splenoportal Doppler, because that is one of the common presentations. And in the granulocytes and monocytes also, the clone size was 80%, while in the RBCs it was around 20%.
So it is like type 2?
Yes.
Type 2, okay. Yeah, another common area is the CNS. So if they have neurological manifestations, you need to do a MR venogram to look for any thrombotic events in the CNS. So these are things which I would like to.
Yes.
Questions? Amita?
This is for the residents. There were actually enough clues there for us to suspect, because the patient had non-immune hemolytic anemia, very severe anemia. Generally in lupus, to see a hemoglobin of 3 and 4 is very unusual. Second, the haptoglobin was so low, it was in dumps. When you have such a low haptoglobin, you always think of intravascular hemolysis. And if you have non-immune intravascular hemolysis, the first thing to exclude is PNH. And there was icing on the cake, the thrombosis. So there are only 3 diagnoses if you have hemolytic anemia, thrombocytopenia, and thrombosis. One is lupus, which you thought of. The second is APS, which you also thought of. And the third is PNH, which we got the last.
So AI won't beat this clinical observation.
Can I say something?
Yeah, please.
Yeah. For the postgraduates sitting here, don't go with this idea that PNH will always present with hemolysis. It generally presents with chronic iron deficiency anemia requiring recurrent blood transfusions. If you suspect this and you feel like there is no other cause for iron loss in this particular patient, think of PNH. And you can diagnose it simply by doing a urinary hemosiderin, which is probably available at most of the laboratories. You don't need any hemoglobinuria test to be done, because hemoglobinuria only happens in cases of acute exacerbation. But in chronically, they are losing hemosiderin. I think everybody knows why PNH is happening, because there is activation of the alternative complement pathway. So it keeps on going daily in the night when the pH drops, and there is some kind of hemolysis going on. So pick up the diagnosis of PNH. We have diagnosed many cases. We have published a case report way back in 2004. And I think in our unit, because we were trained with hematology background, because earlier our department was seeing a lot of hematology cases, so every now and then we were picking up these cases of PNH in rheumatoid arthritis as well. So, but iron deficiency anemia is the clue that you should be working up for PNH.
Thank you. Any more questions? Yeah, please.
2 interesting learning points. One is, as Dr. Agarwal said, that you need to look at if there is iron deficiency, hemolytic anemia, you think twice as a possibility of PNH. Other important thing which I think, apart from the PNH, we have to look at is proteinuria which was there, which we misled you to think of a lupus nephritis. And you also simultaneously thought there was an infection. When there is an infection, treat the infection and re-evaluate the proteinuria. That should be a message that we should take up. One of the wrong clue we picked up to call it as a lupus because you thought there is a nephritis. And that misled you to think in terms of more on lupus rather than coming back forth to a PNH. So when there is a proteinuria, if there is a plenty of pus cells, not parallelly matching to the proteinurias, exclude infection, do the culture, exclude infection, make sure yourself that it's not infection responsible for proteinuria, and then work back to the lupus nephritis. It's good patient refused in the first instance to go for a biopsy. Probably would have messed it up because it would have been an infection. A biopsy would have really created a hell of a problem to both the clinician and to the patient.
Thank you. So can we have John to tell us what is new in treatment for this?
Right, this eculizumab have tried PNH.
Yes.
systems available also. So I think the future is bright. We may not be giving steroids perhaps a decade from today at all. Of course, patients are very few, so that's it.
I think just one comment. I think those places where eculizumab is available, the outcome of PNH and longevity has been much better than in countries where it's not available. And probably if I remember right, the new onset of aplastic anemia and MDS is also less if you treat them long term with eculizumab.
That was good, and we are excellent. So we are doing very well with time. And now we will have the last presenter for the RA session, I think from KIMS. Great, fine. Thank you, sir.
Good morning, everyone. I am Dr. Mohit from KIMS Hospital. Today I am presenting a 66-year-old male with well-controlled diabetes and hypertension, presented with history of joint pains for 2 years from 2015 to 2017, and he presented to us in 2017 with complaints of joint pains which were symmetric and additive in nature, involving small and large joints of the upper limbs and lower limbs. Pain was more in the mornings associated with early morning stiffness for more than 1 hour, which used to reduce with activities. And he also noticed the swellings over the same joints, and he was initially treated with NSAIDs for 2 years. Later, on examination, we found that he had a tender joints of 12 and swollen joints for 10. When we went ahead with the investigations, we found that rheumatoid factor was positive and anti-CCP was also high. And ANA was negative, and his baseline creatinine was 1.27, and we evaluated with the nephrologist. It was found to be secondary to diabetic nephropathy. Uric acid was 8.6. So initially he was started on the low dose of methotrexate and gradually titrated up. He was maintaining well with the 20 mg once a week and HCQs with 200 mg OD. So he was doing well on this treatment and he was in remission for 3 years. So now coming to the present problem, all the symptoms were started in the October 2022, where he suddenly developed painful red eye associated with watering of eyes and photophobia. So we took a consultation with the ophthalmologist also, and we ruled out all the other causes, and ANA and ANCA were also done at this time, and all the other vasculitis workup was done negative. So we diagnosed him with right eye diffuse scleritis, and intraocular pressures were monitored that time, and he had a right eye glaucoma was there with IOP of more than 20. In this patient, it was 24 mmHg. So at that time, we have treated him with topical steroids and topical dorzolamide, and methotrexate were continued, and we started him on the low dose steroids because of the background history of diabetes and uncontrolled diabetes at this time. Later again, he came back with in November 2022. When he tried to taper the doses from the 5 mg to 2.5 mg, he again started getting the red eyes, and history continued the same, and we again increased the dose to 5 mg, and this time we increased the methotrexate also to 25 mg once a week. Next, he presented again in February. This time he came us with not improving on the right eye redness, and he also developed a new onset of pain and redness on the left eye also. So again, took a ophthalmology consultation and did all the workup, and second time again it was diagnosed to be as only superior diffuse scleritis, and no necrotizing or nodularity was not found that time. So again, IOP was monitored, and this time both eyes were having glaucoma also. So we changed from the topical dorzolamide to brimodinine, and we increased the dose of the steroids also to 5 mg to 10 mg. And since we suspect, since it is a bilateral disease and it is rapidly progressive, we started him on the IV cyclophosphamide also, 500 mg monthly once. Later, he presented again in the April with again the same complaint when he tried to taper the glucocorticoids to 2.5. Again, he is developing the eye pain and redness in both the eyes. And this time also again the ophthalmology consultation was taken, and still it is non-necrotizing only. So we went ahead with IOP monitoring also, both are still having glaucoma. So we changed from the topical dorzolamide to topical to tab acetazolamide, and we continued the cyclophosphamide since it will take some time in some patients. So we wanted to monitor how he is going to respond at least after 2 doses. So prednisolone again continued with 7.5 mg and tapering doses. And after 1 week, his IOP has reduced on the right eye, but left eye it is still persistent. In May first week, by this time patient already finished the course of almost 7 to 8 months. Still he is having the persistent symptoms, and his IOP again has increased, and this time we did the fundus examination also, which showed a new onset of cup disc ratio with 0.6 to 1. Bilateral concentric disc cupping is there secondary to glaucoma. So this time the diagnosis was made as left eye non-necrotizing scleritis with open angle glaucoma. So since cyclophosphamide along with low dose steroid is not working, so we went ahead with the pulsing steroids also. Still the patient didn't show any response. So at this point, we switched from the, we did the literature work, and we switched from the cyclophosphamide to the TNF-I. Within 10 days, his IOP normalized to in the both eyes. So this was the first image, this was the first time when he had a bilateral involvement in the February 2023. Then this was before adalimumab, and this was immediately after 10 days after the adalimumab. So here I present a difficult to treat case of RA with scleritis with impending glaucoma with optic nerve changes also. So discussion, rheumatoid scleritis, associated scleritis is most commonly usually in the 6 decades of the life, and it more frequent in the male and often bilateral. And initial signs, scleritis can be an initial sign, or it can present with the remission also. And scleral inflammation in RA may extend to the adjacent structures, which can present as keratitis and anterior uveitis and glaucoma, cataract, retinal and choroidal changes and optic nerve changes. In this, in our patient, he developed glaucoma and optic nerve changes. And patients with rheumatoid scleritis have more advanced joint disease and more extra-articular manifestations also, but we couldn't see any of these manifestations in our patient. So whenever we see a scleritis, we need to rule out whether it is infectious or a non-infectious, because the treatment is going to be very different for the both. So all the time, because since we patient was given steroids also, every time he came to us, we tried to rule out all the infectious causes. Then only we went ahead with the immunosuppressions. So this was published in the 2021. It's a expert guidelines where they have given that first presentation with scleritis, we need to work up with the infectious workup. Once it is ruled out negative, then we need to see whether it is a diffuse nodular variant or a necrotizing variant. See, necrotizing variants will go very rapidly, and we need to treat aggressively. And if it is a posterior scleritis involvement also, we have to treat very aggressively like a necrotizing variant. So in this our patient, we kept him with oral steroids for some time, but though we kept him on the lower doses, then and DMARDs were continued, still there was no response. Thinking that rapid progression, we gave the immunosuppression also, still there was no response. Then our last result was anti-TNF, but lucky that he came out of it. So my questions will be, best treatment modalities for scleritis in RA, and role of pulse glucocorticoids in the setting of a raised IOP, and drugs to treat refractory scleritis, and for how long do we need to continue adalimumab when patient is on remission with scleritis.
Thank you, Mohit.
Thank you.
That was very nice. We are winding up this session. And I just want to make one small point, but the panelists are going to answer the questions and give you a little more information. I did a little review on this particular topic of extra-articular manifestations, and all that I gather is that in the decades to come, we are unlikely to see these extra-articular manifestations. So perhaps this is going to be historic for the future. The reason being that with these biologics, TNF-alpha inhibitors, IL-6 inhibitors, and the JAK inhibitors, the burden of the rheumatoid disease process is being brought down substantially, and the extraarticular features are going to be seldom seen and will be very, very uncommon in the future. Finally, sir, Arun will.
Questions, can I focus? So, in rheumatoid, whenever we manage extraarticular manifestations, we consider two things. One is the presence of active disease, arthritis or not, and the type of extraarticular manifestation. If the arthritis is severe, we go with the drugs which are active against arthritis. Otherwise, it is very difficult to manage extraarticular manifestations. So, when you consider scleritis, NSAIDs, steroids, methotrexate stand first. If the patient, unless the patient has scleromalacia perforans or necrotizing scleritis without inflammation, which is a serious one, we have to choose either cyclophosphamide or rituximab. So otherwise, you can manage with methotrexate. The next options available are MMF, TNF blockers. These drugs will be more useful in managing arthritis as well as scleritis. If the patient has ILD, then the dilemma comes whether to use TNF blockers or rituximab. Maybe we can prefer rituximab. Then refractory, you asked about refractory scleritis. Now in AARDs, the term refractory may not be used in future because we have so many drugs. No disease is refractory to all the drugs. So unless you exhaust all the drugs available for us, you cannot call it as refractory. So you can say difficult to treat. Even rheumatoid, it's called difficult to treat. So difficult to treat scleritis. So they are trying each drug when somebody fails one drug. So now for managing refractory scleritis, they used, fortunately, JAK inhibitors. They work better in refractory cases. If they are resistant to TNF blockers, rituximab works. If they are resistant to rituximab, JAK inhibitors work. These are the studies which say the response to drugs. Then they have done a study on prevalence of scleritis before and after biologic era. But it looks the same. It has not improved the situation. Sir has claimed that maybe if you control the disease well in early, maybe in future we can see less number of scleritis cases. Then usage of steroids, when there is glaucoma, you have to avoid steroids. Now the protocol is to do the surgical correction of glaucoma. You do trabeculectomy. If they need steroids, do the surgery and continue steroids. Otherwise, steroid is not going to be, it's going to be harmful. Then how long do we continue fortnightly injection ad libitum? TNF blockers, they give remission at the end of 3 months. There are many studies. They have seen good response at the end of 3 months. And most of the studies, they have used up to 1 year or 18 months. At the end of 18 months, they have declared it as the scleritis is in remission. To say scleritis is in remission, the patient should be symptom-free for 1 year at least. So if you use it for 12 months or 18 months, maybe you can stop adalimumab and you can follow up with other conventional drugs.
I think Arul sir answered all the questions. So just a few comments actually. This patient first presented with unilateral red painful eye. And generally, it's unusual for rheumatoid for having a unilateral scleritis. When somebody comes with unilateral scleritis, you think of something else.
Yes,
and when somebody comes with bilateral scleritis, you think of rheumatoid. So that is one thing. So whether the first time he had was rheumatoid-related scleritis, one thing. Next way I would look at it is, see, the commonest eye manifestation of rheumatoid is sicca, dry eye.
Yes.
And that is the commonest reason to predispose the eye for infection. So infections are actually common in of the eye in those with secondary Sjogren's. Okay, and actually it is difficult to pick up those infections. So what they say is you culture and reculture from the eye for an organism. And commonly what you find is it is a common organism, like, gram-positive cocci or streptococci or staph, which are common, which are generally missed out. And the problem is we immunosuppress them again, thinking it's just an immune-mediated inflammation, and it doesn't get better. It gets worse. Okay, so this is one common problem which happens. Another thing we have to be careful in scleritis is numbers, I think about 40 to 50% of patients with scleritis have keratitis also, a corneal involvement also. This is which is really worrying. And keratitis which can go on to visual disturbances. So the keratitis we have to be very careful about. The corneal involvement which have to be very careful about. And another thing is whether your patient was responding or not. Actually, what happens if the scleritis doesn't respond? Actually, there is a lot of inflammatory cytokines, inflammatory cells in the sclera or cornea, wherever there's inflammation. And it's like a thin tissue. So it gets damaged. There will be damage. And then, if there is damage, it becomes painless. It's quickly you get, so they quickly shift from being a painful red eye to a painless red eye because the disease worsens. As a clinician, you think like, okay, this was a painful red eye and now it becomes painless, so it is better. But actually the disease has worsened. And when I look at the case you presented, actually, the pain persisted and actually had increasing pain. So actually it was not like your treatment was not working. It was working. Otherwise it would have become a painless and had gone for scleromalacia perfens. It was doing something but not as much as you wanted. So there's 2 points. First is make sure there is no infection. Second is, if it is not responding, it would have been not been painful. Okay. And yeah, third thing on management, particularly when you have the raised intraocular pressure, I think scleritis should be a joint management between an ophthalmologist and a rheumatologist, because every time you need them in, because ophthalmologist meaning somebody who is willing to operate. If the pressures are going up and if you need to, they are going in for visual loss, then if, as Sir had also mentioned, if you need to operatively reduce the pressure, you have to do that. So that is one thing which probably I would be very careful when we manage this sort of scleritis.
Yeah.
Yeah. One more question before you.
Yeah, I'm Dr. Gupta from Hyderabad. See, can we use, whether it is a comment or question, I don't know. If the sclerity is not responding to early MAM, generally it will respond. Can we use it weekly? Somewhere literature I reviewed, they said that we can use it weekly also in severe scleritis. And in India, financial constrained country, so most of the times we'll get scleritis we use for 6 months that are giving a good results. It is not possible to use for the 1 year or 18 months. In 6 months we are getting very good results. Can we shift over to the TOFA in the case of scleritis? Can we use 6 months Adalimumab, then we shift over to the TOFA? Is it a good choice?
So these will be very individual sort of decisions that the clinician will take in the office. All the options has very little literature. So it will be a more judgmental decision, more circumstantial division depending on cost and what is available. So you're right. We can go weekly. We do that. We have been doing that even in the case of Remicade, the infliximab. We had been increasing the dose because we get antibodies. So you're right in all the questions. Yojana?
What was the B scan of the patient? Ultrasound B scan of the patient?
B scan. Ultrasound, was it probably not done?
No, not done.
It was
so
not
because
done.
you're saying that optic nerve was involved, it's possible that the patient had posterior scleritis. And the B scan would have helped you to detect posterior scleritis. And in that case, like, you don't have to wait for patient to be having, necrotizing scleritis. Straight away give full dose of cyclophosphamide. I mean, 1 gram. Why low dose of cyclophosphamide? If this patient was given right at the beginning full dose, probably he would have responded to.
Yojana, your point is absolutely taken. In these extra-articular manifestations, these are precious eyes, we lose eyesight, we have to be very aggressive. And if you have just uveitis, the patient is in a lot of pain. Patient is in a lot of pain because your osseous muscles which are getting attached, the point of attachment is also inflamed, which is extremely painful. So when the patient is in pain, you have to relieve the pain. We have to be very aggressive with treatment. Even if it means giving corticosteroids, pulse corticosteroids, adalimumab more frequently, as already mentioned. Correct? So we have to be aggressive. I think that's a very important point to
Actually,
yeah.
the pathology of uveitis is vasculitis. So treat it as vasculitis.
Yes.
The way you treat vasculitis, you treat.
Sir, just one comment shall I just make? Actually, uveitis in rheumatoid is rare. And actually, sclerouveitis, you can get it. And actually, this sclerouveitis is contiguous uveitis.
I'm sorry,
You have a
did I say
scleritis.
uveitis?
It's a contiguous.
Sorry. I wanted to say posterior scleritis. Sorry, if I said uveitis, I'm very
No. Actually, well, what I'm trying to say, uveitis can happen, but it's a contiguous uveitis, sclerouveitis, which happens together. So you treat scleritis well, that uveitis is taken care of. So,
Sir, one more, this thing is personal observation. One of my patients who is having to be a rheumatoid arthritis with uveitis, we started on adalimumab and he improved well. And at the same time, we sent to the ophthalmologist and they started on topical prednisolone, topical eye drops. Then without his knowledge, he continued. He's an educated man, but he continuously used that steroid for another 1.5 years. Again, he developed glaucoma and his vision was also gone down. Then there was no option. We continued adalimumab in a phased manner, like 15 days instead of 15 days, 1 month. Later, the vision has been improved after 1 year. They stopped the steroid and
just wanted
vision
to
was
make
improved.
a quick point that in patients who were refractory scleritis, one must look for vasculitis, like certain marker. Like 2 of our patients turned out to be having ANCA positive PR3 in high titers. And they were not responding to the usual management of scleritis. Another one turned out to be having ADA2 deficiency. So I think those things also to be kept in mind when we are evaluating refractory scleritis and any connective tissue disease.
Concludes the, thanks Mohit, thank you very much. That concludes the RA session. Molly. Now it's going to be Venkatesh. That's going to be Venkatesh who's going to brief us on the take-home points. Venkatesh, do you need any help from
us? Good morning. So we had 4 beautiful cases which were showing different manifestations of RA and the comorbid conditions which can happen in patients with rheumatoid arthritis. So first case was presented by Dr. Ramya from St. John's, Bangalore, which was RA with eosinophilia. So when you have eosinophils, if it is more than 15,000 on 2 occasions done 1 month apart, you would call it hypereosinophilia. And in these cases, you need to look for organ manifestations in the form of neurological involvement, cardiac involvement, thrombotic involvement, is there or not, any vasculitis kind of picture is there or not. So if these things are there, that requires immediate management. So that's very important to take home. So regarding the prevalence of eosinophilia in RA, so it was, there are different studies and the prevalence is between 7 to almost 20% in patients with rheumatoid arthritis in series. And it is related to disease activity, while hypereosinophilic syndrome is not that common in rheumatoid arthritis. Okay, when you have somebody with gangrene in rheumatoid arthritis, things to consider: 1 is rheumatoid vasculitis, 2nd, thromboembolic phenomena because of hypereosinophilic syndrome per se, hypercoagulable states, then hypereosinophilia. Sir has discussed the release of the eosinophilic granules, which can cause nitric oxide related vasospasm, and that can lead to gangrene. And then cryoglobulinemia. This is another important thing which we need to think of in patients with RA and gangrene. So whenever we have somebody having hypereosinophilic syndrome, we need to look at whether there's a clonal disorder, if it is there or not. So myeloid hypereosinophilic syndrome is associated with increased vitamin B12 levels. So this was an important take-home point. We need to evaluate the heart as well as the lungs thoroughly for manifestation of hypereosinophilic syndrome. And once you have diagnosed an idiopathic hypereosinophilic syndrome, the drugs which can be used are, one is methotrexate helps in hypereosinophilic syndrome to reduce the eosinophils. Second, we can try hydroxyurea, and then the tyrosine kinase inhibitors, jakinibs and imatinib. So that's about the important points from the first case. Coming to case 2, which was discussed by Dr. Ruby, which was on rheumatoid arthritis versus tuberculosis. So how to differentiate inflammatory versus infective arthritis? So points in favor of inflammation are that you have more than one joint involvement. You would have extra-articular manifestations of that particular autoimmune disorder which is there. In case you do a synovial aspiration, the fluid would be inflammatory and the tests for infection would be negative. And coming to infection, we have chronic monoarthritis. That would be the most common presentation of tuberculosis. Though in this case we had 2 joint involvement, which is not that common. You should look for risk factors for development of tuberculosis. So history of contact with tuberculosis patients or an immunosuppressed state needs to be looked at. MRI would pick up soft tissue enhancement, soft tissue involvement, abscess formation, presence of osteomyelitis and tenosynovitis, which can help us pick up infective tuberculosis-related arthritis, though it's not 100%, for which you need to do a histopathological examination. So synovial biopsy is important. Apart from this, a synovial aspiration can show features of infection, but in tuberculous arthritis, you get a lymphocytic kind of presentation in the synovial fluid. And Zeal-Nielsen, which was positive in this case, that's not common. CBNAT can be positive. Again, the sensitivity of that is almost only 90%. So there are 10% of patients who may not be positive by CBNAT also. And then we had discussed the newer biomarkers which are being tried to reduce the duration of tuberculosis therapy, anti-tuberculosis therapy. Then we had a discussion on how, if a patient with rheumatoid arthritis had a single joint which is persistently involved, please think of tuberculosis. Common sites of tuberculous arthritis, most common would be the port spine. Apart from that, in the peripheral joints, we have the hips and the knees which are involved. And then in other infections which can happen in joints and would be brucellosis. So in brucellosis, you have the lumbar spinal involvement, while in tuberculosis, the dorsal spinal involvement. History of exposure to cattle, history of use of unpasteurized milk or uncooked paneer would help pick up the diagnosis. ELISA with IgG and IgM, ELISA for IgG and IgM against brucellosis would be required for diagnosis. Okay, so that's about tuberculosis versus inflammatory arthritis. Next, coming to case 3, presented by Dr. Nandita from NIMS, which was a case of rheumatoid arthritis plus paroxysmal nocturnal hemoglobinemia. Okay, so here the most important thing which was discussed was when you have a triad of anemia, which could be iron deficiency anemia plus hemolytic anemia, when you have cytopenias and thrombosis. The differential diagnosis would be, 1, you would think of lupus, 2nd, you would think of antiphospholipid syndrome, and 3rd thing, PNH. So whenever you have hemolysis in PNH, it can be both extravascular and intravascular. So a urinary hemosiderin can help in chronically patients having chronic hemolysis, because that's present always in this in the urine, and that could be an easy test in patients having persistent iron deficiency anemia. And then urinary hemoglobin would be increased only in patients having active intravascular hemolysis. Differential diagnosis of anemia and RA, we have discussed. Drug-induced would be the most common. Apart from that, we have iron deficiency and anemia of chronic disease, hematological malignancies, amyloidosis. Whenever you have intravascular hemolysis, do a DCT. If it is positive and there is thrombosis also, you would think of lupus, while if it is negative, then you would think of PNH. So PNH can involve the renal system, and apart from that, there can be cardiac involvement, pulmonary involvement, Budd-Chiari, neurological involvement. Okay. And then the newer treatments for PNH were discussed. So we have the monoclonal antibodies against C5, which reduce the intravascular hemolysis. That could be eculizumab and ravulizumab. Apart from that, there is another molecule which is a C3 inhibitor, pegcetacoplan. Okay, so this is something new, and it inhibits both intravascular as well as extravascular hemolysis. Apart from this, we have the copans like the avacopan we have, which is iptacopan, which is a factor B inhibitor, and we have danicopan, which is a factor D inhibitor. And these two inhibitors decrease extravascular hemolysis, and this is given together with eculizumab or ravulizumab in patients having both extravascular and intravascular hemolysis. So that's about PNH. Then coming to the case 4 discussed by Dr. Mohit from KIMS, which was a patient of RA with scleritis. So scleritis in RA usually happens bilaterally and in elderly patients. So these patients have more of extraarticular manifestations and usually would be seropositive. So when we discussed about scleritis, you can have an anterior scleritis which is obvious, or it could be a posterior which cannot be picked up. So posterior scleritis means the scleritis which involves the part of the sclera which is behind the insertion of the lateral rectus or medial rectus muscle. So that is the posterior sclera. And this sclera extends into the optic nerve. And that is the reason why posterior scleritis usually is associated with visual involvement, decrease in visual acuity. And then both of these anterior and posterior scleritis can be divided into 3 spectrum. One is diffuse anterior or posterior scleritis. Then you have nodular scleritis, and then you have necrotizing scleritis. So necrotizing can be with inflammation or without inflammation. When it's without inflammation, you call it scleromalacia perforans. Apart from this, there can be associated keratitis, which can cause problems, which needs to be managed. Scleritis always presents with pain because the extraocular muscles are attached in the sclera, and eye movement causes pain. And this is an important feature. And as the severity of scleritis increases, the nerve destruction happens and pain reduces as you go into the severe spectrum of scleritis. Okay, so whenever you see a patient having extraarticular features of RA, what we look at for treatment is whether the disease disease per se is active or not. So if the disease is active, then you start the patient on methotrexate. That would be the first line. Followed by that, if the patient is not responding, then you can think of cyclophosphamide or rituximab or TNF-alpha inhibitors. And if the patient is in remission, then you would go for the latter drugs. Regarding refractory scleritis, drugs which are available would be anti-TNF inhibitors, rituximab, jakinibs. Though these are all case reports or case series, no studies are available. When you have a patient having glucocorticoids and having glaucoma, it's important to avoid glucocorticoids. Surgical treatment is required before starting the patient on glucocorticoids to reduce the intraocular pressure. How long to give adalimumab in scleritis? at least 3 months, most patients respond in this period. And then you go on for 1.5 years. And if the patient is asymptomatic for 1 year, then try to taper off the glucocorticoids first, followed by the anti-TNF agent, and then you continue with some other steroid-sparing oral agent. Okay. Ocular manifestations of rheumatoid arthritis, the most common would be secondary Sjogren's disease, causing Zika symptoms, and these patients are prone for infections, and infectious scleritis needs to be ruled out. I think I conclude with that. I would like to thank the organizers for giving me and all our panelists and chairpersons this opportunity to be part of this program. And I think we had a great discussion with great comments from the chairperson and the panelists. Thank you.
Time is the issue we had.
One quick.
Moving from the most common disease to the most exciting disease, that is lupus. And what we have planned is a little different. So we will have 8-minute presentation and then one question each to each panelist. They will finish in 1 minute each. So 2 minutes for panelists and then 8 minutes for the audience, because we feel audience interaction is more important. And then at the end, the panelists, each of them can have 1 minute to say something extra if they have. So that is a format our group is going to do. I hope it's agreeable to everybody. So we will start with the first case, which is being done by Vimal. So he is presenting a very interesting case.
Good morning, everyone. I'm Dr. Vimal, rheumatology resident at KIMS Hospital. So I'll be discussing on a case, a tear without warning, a case report of spontaneous coronary artery dissection in SLE. So she was a 42-year-old female with no comorbidities, presented with complaints of pain and swelling with significant early morning stiffness involving the small joints of the hands for the past 3 months. She also had intermittent low-grade fever for 1 month duration, and she was evaluated and treated by a physician elsewhere. So evaluation elsewhere showed leukopenia with the WBC count of 1800, thrombocytopenia with platelet count of 1.13 lakhs with mildly elevated ESR of 53. Workup for infective etiology was negative, including cultures. So the course of events, she was then admitted by the local physician and was given IV cefoperazone sulbactam and IV hydrocortisone for 5 days. Afterwards, she became afebrile and the leukopenia had improved from 1800 to 8104. Later on, she presented to our OPD for further evaluation. On history taking, it revealed that patient had photosensitivity, recurrent oral ulcers, and undue fatigue for the past 1 year. And on examination, patient had an ulcer over the hot palate, and there was synovitis involving bilateral PIP in the hands. So, considering inflammatory polyarthritis, recurrent oral ulcers, unexplained fever, photosensitivity, and leukopenia, SLE was considered, and we had sent for appropriate investigations. So, while we were waiting for blood workup, she developed sudden onset of chest pain with palpitation, sweating, giddiness, and breathlessness. She was admitted under a cardiologist at a nearby hospital. ECG was done, which showed ST elevation corresponding to the anterior leads. The troponin I was elevated, and 2D echo showed RWMA in the anterior wall with an EF of 45%. An acute anterior wall MI was diagnosed. She was then thrombolized with tenecteplase, and post-thrombolysis a CAG was done, which showed 50% long segment disease in the LAD and 50% diffuse disease in the left main, and LCX had 80% tubular stenosis. So this is the CAG which is showing the tubular stenosis. So actually, considering the morphology of the lesion being tubular, the treating cardiologist thought that it could be coronary vasospasm and he has given intracoronary NTG. But the patient did not respond to intracoronary NTG, and the cardiologist has started her on dual antiplatelets and statins and referred to us for further management. She was then readmitted at our institute for further management. So the investigation that was sent during OPD consultation had come back, in which ANA by IF was 3+ and dsDNA was negative. APLA panel showed beta-2-glycoprotein medium titer positive, IgG. So now considering inflammatory arthritis with unexplained fever, leukopenia, oral ulcer, photosensitivity, and an anterior wall MI with no other risk factors, and ANA IF showing 3+, and beta-2-glycoprotein IgG being positive, a diagnosis of SLE with probable secondary APS having ACS as a thrombotic complication was considered. Then we had initiated her on anticoagulation, after which the patient developed sudden onset of giddiness with tachycardia and hypotension. And now there is AF with fast ventricular rate with new significant ST depressions in V1 to V4. DC cardioversion was done and the patient was reverted back to sinus rhythm. Inotropic support with noradrenaline was initiated. Then the patient was taken up for PCI in view of hemodynamic instability. So this is the first CAG image, which is showing just trickling of contrast along the LAD, showing extensive tubular stenosis in the LAD. Here we can see the guide wire being passed for PCI. And this is post PCI where there is good flow being established. So this is the image of intravascular ultrasound, which is showing intramural hematoma in the vessel wall. So spontaneous versus iatrogenic coronary artery resection were considered. Then the points favoring spontaneous coronary artery resection were there was a long segment tubular stenosis on the first look in coronary angiogram, and the vascular lesion was corresponding to the infarct territory in the pre-procedure ECG itself. And there was significant discrepancy in the size of lesion in left main, LAD and LCX. And the catheter that was used was of a smaller French catheter, which is used for diagnostic purposes, whereas a guiding catheter is of a larger caliber, which is more likely to cause trauma. And the site involved was not traversed by the catheter tip either. And most commonly, during procedure, there will be intimal injury that is caused by manipulation of the guide wire. Here in our case, the guide wire was never passed. So considering weighing these details, spontaneous coronary artery dissection was considered. So the overall sequence of events were a spontaneous coronary artery dissection to begin with, which was thrombolized and was put on anticoagulation, causing a forward propagation of dissection, which led to worsening of stenosis and hemodynamic instability. So a diagnosis of spontaneous coronary artery dissection in SLE was diagnosed. Patient was put on PTCA was done to LAD, ostial LCX, and left main and LAD. Post PCI, patient was continued on dual antiplatelets, and she was initiated on hydroxychloroquine, azathioprine, and prednisolone. And she's been doing well on follow-up. So the overall incidence of spontaneous coronary artery dissection is estimated to be between 0.2 to 1.2%, out of which 80% of the cases are associated with pregnancy and postpartum period, fibromuscular dysplasia, rheumatic conditions like IBD, SLE, and sarcoidosis. And remaining 20% were found to be idiopathic. Though SLE is associated with more than 50-fold increased risk of atherosclerosis, we wanted to emphasize the association between SCAD and SLE because a high index of suspicion is required to correctly diagnose the condition, as a conventional ACS management strategy can be very detrimental and fatal, and it could be fatal also. Luckily, our patient has survived the thrombolysis. So, thank you.
Thank you, Vimal. Do you have any questions for the panelists, or should I ask those questions?
So, what is the likely pathogenesis of SCAD and SLE, and management of SCAD and SLE?
So, Chandrasekhar, do you have, what is the prevalence of?
I'm not really fully aware about that statistics with reference to the incidence. As you have already mentioned, it's relatively rare, but not uncommon. Regarding the pathogenesis, there are two probable suspicion of pathogenesis. One is it could be the increased atherogenesis, which in turn goes for thinning and fragmentations and subsequent dissections. Here, the query in this particular case, sometimes adding anticoagulations can also add on to the development of the SCAD. Whether hasty addition of oral anticoagulant, did it accelerated the process, is something which we need to ponder upon. The reason is the need to introduce oral anticoagulant is a little dicey in these kind of circumstances, because arterial thrombosis, even if you suspect, the drug of choice is not oral anticoagulant, we prefer antiplatelets. So probably whether the choosing oral anticoagulant led to the development of the disease or was it spontaneous is always a $1 billion question. But technically thinking in these kind of situations, because the only thing you had was one time APLA done, only one of the autoantibody was positive, yes, that anticardiolipin IgM, I think borderline 44. So that being the case, the justification to introduce is always something which we have to relook at this. And in any next case, we need to consider that should I really add the patient onto oral anticoagulant, should antiplatelet should do the job.
Thank you, Dr. Chandrasekhar. Any questions from the audience? Yes, Dr. Sapan.
I think she was only into 1 year of her disease, you said, or 2 years?
3 months, sir.
3 months, and she didn't have any comorbidities, right? So
no,
atherosclerosis, I think, becomes very unlikely in her case. It should be, you can have at 42 in India, but that becomes very unlikely. Is there any association reported between APLA and spontaneous dissection, or even RNP antibody and dissection? Did you review literature on that?
On literature review, there were case reports on isolated APS and spontaneous coronary artery dissection, sir.
So, Dr. Mishra.
I am not so comfortable in calling APLA for this.
Yes.
As Chandrasekhar said, our significant IgG antibodies has to be beyond 40 GPL, and this was just 44, and that was just one time done. To associate a major event like this with APLA, I think it probably we have to wait, get it assayed a second time and do the other panels of antiphospholipid antibodies. I think this has got nothing to do with the antiphospholipid antibodies.
Any questions from students first? Anybody at the back? Most of the students sitting on the last 4 rows. Anyone? Anybody of you have seen such a case ever? Okay. So if you look at statistics, because it's extremely rare, first, I am not convinced it's spontaneous, absolutely. Because there are 3 vessels involved. Very unusual in a spontaneous coronary artery dissection to have 3 vessels involved. Because she had 80%, 50% and 80% stenosis in 3 of the coronary arteries, number 1. Second, you have given her, one procedure has been done, fine, there was no guide wire used. But every procedure can cause an intimal injury. And that intimal injury can get aggravated by giving anticoagulants. And she develops an intramural hematoma in one of them. So I am absolutely not convinced. I mean, this is my own perception. The second thing is that there are only 8 cases reported so far of lupus with spontaneous coronary artery dissection till 21. I mean, I couldn't find anything beyond that. So it's an extremely rare. Saying that SCAD isn't rare, SCAD is rare in lupus, extremely rare in lupus. And it's the other statement which you said, it's rare to meet a survivor. Actually, it has a very low mortality. It's most of the patients survive. The mortality is only 1 to 2%. The recurrence in SCAD is seen in about 15 to 20%. I read it only after I saw this case. I read about this case. I had no idea about this disease at all. So it has 15 to 20% recurrence rate, occurs in young women, predominantly, as you said yourself, peripartum, or in patients who have fibromuscular dysplasia. And to decrease recurrence, you use beta blockers. That's the therapy of choice in those individuals. And as Dr. Mishra said, I'm absolutely not convinced she had APS. So my take on this case is it's probably iatrogenic because she has 3 vessels involved. The classical angiographic picture which is given for SCAD is beaded appearance. Here we had a concentric narrowing, which is a long segment narrowing, which is usually not, it can happen in SCAD also, but it's not the usual manifestation. So putting everything together, Agreed, we can call it SCAD, we can call it iatrogenic, doesn't matter. The end result is good, so we are all happy. Thank you, Vimal, for a wonderful case.
Thank you.
The cardiologist here felt that it could be SCAD.
Do we have anybody now?
Not here. I don't think we have any on. We have any cardiologist?
The typical finding of SCAD is double lumen,
Yeah.
which was not seen yet.
That's what I'm saying.
So it is, unlikely. It could be atherosclerotic.
Absolutely. Okay, thank you, Vimal, for a wonderful case. And your intravascular ultrasound basically shows there is an intramural hematoma, which can happen iatrogenic and can also happen in SCAD. Yeah. But it's a wonderful case for discussion. It opened our eyes and we all learnt. So that is the whole purpose of this meeting. So thank you. Thanks, sir. So we have saved 5 minutes for Molly. Molly has asked me to save more minutes for her. And we move on to the second case, which is going to be presented by Dr. Harsh Jain. And that's also a very interesting case of another organ involvement in lupus. So over to you, Harsh.
Thank you, ma'am. Good morning, everyone. My name is Dr. Harsh Jain and I am from Army Hospital, Delhi. Today I am going to discuss a case of a young male who had refractory lupus, and I would like to convey a story of repeated acute chest pain episodes. A 28-year-old male presented with clinical features of polyarthralgia, petechial rash in bilateral lower limbs, alopecia, and pedal edema of 2 months duration. On evaluation, we found that he was having 2.3 gram of 24-hour urine protein and had numerous WBCs and RBCs, but there were no cast on urine microscopy. His ANA was positive, it was nuclear homogeneous. LIA was positive for anti-DSD and anti-Rho, anti-La antibody, and both complements were very low, and IgG was elevated. His workup for APS was negative, and renal biopsy showed features of class 3 plus class 5 lupus nephritis with an activity index of 4/24 and a chronicity index of 2/12. We diagnosed him as SLE with lupus nephritis, and we started him with high-dose prednisolone followed by MMF. But his disease was quite aggressive, and he did respond to 2 grams of MMF and started developing vasculitic ulcers and also developed multifocal choroiditis in both the eyes. So his multifocal choroiditis was managed with intraocular glucocorticoids, to which he responded, and MMF was increased to 3 grams. Despite that, he continued to have proteinuria, and it was difficult to achieve remission. So we started him on cyclophosphamide monthly regimens following NIH protocol. Despite receiving 4 doses of cyclophosphamide, our patient continued to have cytopenias, arthralgias, and proteinuria was already there. So we thought of shifting him to a combination therapy of rituximab and MMF. Despite that, what we observed that patients started developing recurrent attacks of acute chest pain and breathlessness, and the last few episodes started having hypoxia as well. So if we compare the imaging of March 2021, the X-ray seems normal, but in August 2021, there is CP angle blunting on the right side, and we can see a linear opacity in the right lower zone. We went ahead with CT chest. CT chest showed features of right lower lobe consolidation with pleural effusion and minimal atelectasis. We did a bronchoscopy and we could not find any evidence of infection. Procal was negative, and we were giving him broad spectrum antibiotics, but despite that, our patient was not improving. So we thought that a patient might have underlying acute lupus pneumonitis, and we increased the dose of prednisolone from 5 to 20 milligram, and we continued MMF 1.5 gram BD. With that, our patient responded. But he developed a second episode and there was a flare of polyarthritis. So we thought of giving him pulse methyl prednisolone, and tacrolimus was added along with MMF, and we gave him 2 gram per kg of IVIG, to which he responded. But he developed a third episode in November 2021, and we managed him with IVIG, and tacrolimus dose was increased and it was optimized to 3 milligrams. And he developed a fourth episode, and fourth episode was also managed with monthly IVIG. But after the fourth episode, patients started having baseline dyspnea of grade 2 MMRC. And during these episodes, he continued to have features of cytopenia, low complements, proteinuria, and elevated anti-DSD and antibody titers. So if we compare the X-rays from March to November 2021, November 2021, the X-ray picture had improved with monthly IVIG, MMF, and tacrolimus, but he continued to have repeated episodes. In January 2022, he again had a fifth episode, and this time he was requiring oxygen support also. And here we can see that there is elevation of the right hemidiaphragm, right lower zone, linear opacity, and when we did a CT, what we found was that he had atelectatic fibrotic bands in lower zones, right more than left, and there was a decrease in lung volume, and FVC had shown severe restriction with reduced DLCO. So with these findings, we made a diagnosis of shrinking lung syndrome in our patient. So if we see the course of illness in this patient, his disease was never controlled. So this was not a run-of-the-mill case, and our back was already against the wall. We tried MMF, cyclophosphamide, rituximab, calcineurin inhibitors, as well as monthly IVIG. But with this also, we were not able to control his disease. So we were left with fewer options. First was obinutuzumab, second was daratumumab, followed by maintenance with belimumab. Third was HSCT, and the fourth was CAR T-cell therapy, but CAR T-cell therapy was not available, and HSCT is associated with very high peri-procedure mortality, and belimumab was also not available for maintenance, followed by daratumumab. So we did a literature research on obinutuzumab and how obinutuzumab differs from rituximab. So it is genetically bioengineered differently. It is a type 2 anti-CD monoclonal antibody. So it is a IgG1 monoclonal antibody, and it lacks fucosylation. So if there is no fucosylation, it will have a greater affinity to Fc receptors, and it will have a superior antibody-dependent cell cytotoxicity, and it has a less reliance on CDCC. So it is not forming any lipid drafts with CD20, and it is not requiring complement to cause apoptosis of the B cell, and has far more superior B cell depletion compared to rituximab. So if we see the data from the Nobility trial, significant reduction in BAF levels and memory B cells, naive B cells was seen in Nobility trial. And if we compare the Nobility trial and the Luna trial, here we can see that there was significant B cell depletion compared to rituximab, and both these trials have used MMF and prednisolone as their baseline ongoing treatment. So we went ahead with obinutuzumab. What we observed that there was significant improvement in the chest X-rays. His cytopenias were improving, and for the first time his HB had reached up to 13.2. Though his complements were low, he continued to have proteinuria, but albumin had increased, and FVC has also increased to 46% from 18.6%. By September 22, his FVC had increased to 50%. We had given him a repeat maintenance dose of obinutuzumab on 25th of June 2022, and we did a repeat renal biopsy for his persistent proteinuria, which showed that patient was having only class 5 lupus nephritis at that time, and there was no evidence of activity index or chronicity index. They both were 0. So when we followed him up in December 22 and January 23, he had a flare, and we again gave him obinutuzumab, but unfortunately, our patient succumbed to bronchopneumonia after a period of 1 month. So discussing lung involvement in SLE, it can involve the parenchyma, vasculature, pleura, and it can also cause airway involvement. But today I am going to discuss shrinking lung syndrome. It is quite rare. It is a restrictive lung disease. It is characterized by elevated hemidiaphragms and reduced lung volumes. There are various theories have been hypothesized. But in our patient, there was recurrent pleurisy, pleural fibrosis, which is causing chronic hyperinflammation and led to shrinking lung syndrome. So both these diseases are rare, but can have different diagnostic clues. As in lupus pneumonitis has fever, but shrinking lung syndrome will not have fever. And pleural effusion and consolidation, GGOs, can be seen with lupus pneumonitis. However, with shrinking lung syndrome, there is immediate elevation of diaphragm, atelectasis, or PFT. So mortality is quite high in lupus pneumonitis, and in shrinking lung syndrome, there is a good prognosis. Thank you.
So thank you, Harsh, for a wonderful case. You have rightly done on time. That's great. And you also don't have probably any questions?
Ma'am, I have a few questions.
You have a few questions. Okay. Short the first
question is that would anything else could have been done in this case? Second question is why male lupus is so severe? And third is how do we predict a greater B cell response if patient has already shown primary rituximab failure if you are giving obinutuzumab?
I'm going to keep it short, not for anything else. We'll take it offline afterwards because I want the audience to talk, right? We are very short of time.
Sir.
One of the things that was not done, and I'm sure you have your reasons for it, was the fact that if you knew your IVIG was failing,
Sir.
and you were going to go to something which is more in the experimental sphere,
Sir.
before that, why wouldn't you try plasmapheresis? Your IVIG was not working, you're trying monthly pulses, you've done it every month for 4 months, and you didn't get it. And you want to go into an extremely potent line of therapy, something that is used in lymphomas, in an immunosuppressed patient.
Sir.
Technically, you were justified because your back was against the wall.
Sir.
And so what you were trying to, your intention was correct, but you really are completely depleting the immune system here. And would you not like to go downwards and use the traditional line? So maybe cyclophosphamide, plasmapheresis, would you do the Wegener's line of treatment, so to speak? The traditional thing when we were short of treatment, what we used to do was plasmapheresis followed by cyclopulses. Plasmapheresis and cyclopulses. Ritux came later, and so we adapted it in bad life-threatening ones to say plasmapheresis, cyclo, and Ritux. Maybe you might want to think about that.
Yeah, I think the few. I'm a little not convinced about calling this as a shrinking lung because there was repeated episodes of pneumonitis, and also the changes that you are expecting in a shrinking, less of parenchymal other than atelectatic changes, and most of the time CTs are negative except for the shrinking volume. So that puts me to a thought process. Probably what the patient was going was for a refractory pneumonitis. I think you presented in the last but one slide, which very clearly shows that that is more refractory to the treatment than the shrinking lung syndrome. In my 30 years, I've seen only one patient for the shrinking lung syndrome. She is alive even now. She is now 70 with a lupus. So usually in a shrinking lung, we have a very good prognosis. You have presented it. So that's why I would like to call this particular scenario as a lupus-associated pneumonitis refractory to the treatment. There is one thing which we very often miss when we are using the immunosuppressives. I think I have seen it in practice, and I have also had a problem with that, and now we have realized that we need to work up for a possible secondary infection of few of the viruses which typically mimic your lupus. And that's where we go on pushing the immunosuppressives, and ultimately, finally, we lose the patient for an infection. See here, the same mimics which can happen are a cytomegalovirus can mimic your same pneumonitis. EB Epstein-Barr virus can mimic your same things. There are few more viruses which will be shortly added into the list which can typically mimic your things. See, to call a lupus or call an autoimmune disease refractory your disease, it becomes, and it's a necessity for us to look back. Did I miss any viral infection which mimics? Because to tell you, I think next time I'll share those cases, and I'm giving the whole series which we are going to start with. We had 2-3 patients where there was exhausting proteinurias, which we treated with cyclo, no response, looked for it, it was a CMV nephritis. The moment we give an anti-CMV regime, she is back to normal. It's the question that in this particular case I would like to bring it to the notice, and it's essential for us is it an infection which I am missing? And if it is so, the treatment line is going to be different because you have put almost all the drugs which are very effective in the drug with reference to this. And there is a partial response, but she relapsed before the effect of the drug went. You had a good response to IVIG partially, but it relapsed again because IVIG is something which can positively help you in the infections. So that's where the things are. Because you are given IVIG, simultaneously patient was also on immunosuppressives like mycophenolate and others along with IVIG. That might have frozen the effect or the benefit that IVIG would have done with reference to positive infections. I think that's where more often we miss and lose the patients, especially when we think it's a refractory. It could be a simple infections which could have been otherwise managed.
Sir, we need to take some analogies.
Okay. Patient had repeated breathlessness. Did you do dimer of the patient? So many times the patient had come.
Yes.
Ever the dimer was raised?
D-dimer was done. It was not raised, and
it was not mentioned.
Yes,
that's why I thought.
And we had also done a CTPA.
CTP.
There was no evidence of thrombosis.
But it was not mentioned both those things. So
Okay, Dr. Shanmugam.
I always call male lupus as angry lupus. And nowadays, because of better immunosuppression and early pickup, we are getting it. And Army Hospital had a lot of HSCT earlier in the early 2000s for actually not basically autologous, and there were some good results. So obinutuzumab, is it available in India and is it approved for lupus?
Yes. So it is available, sir. It has shown significant response in the nobility trial, and we had asked it from our oncology friends.
Okay. So when we are using first use drug, is there any legal thing we need to take, just for my knowledge, or we can use it as off-label or compassionate use? How do you use?
Okay, we will discuss that issue later. We are discussing academics at present. So Vignesh.
I think one another investigation which you could have considered is the whole exome sequencing.
Yes,
Because
sir.
we have tried multiple immunosuppression here. The exome, suppose if they pick up a specific monogenic cause for a lupus, you can target your immunosuppressive therapy. Say if it is a type 1 interferon, DNA's defect has a classical pulmonary manifestation along with your nephritis and other stuffs. So if you would have identified that, then the therapy you could have tailored to a JAK inhibitor or something like an interferon blockade.
Yes.
And monogenic SLE is not restricted to pediatrics.
Yes,
it is
sir.
more and more, the field is expanding.
Yes,
Even the adult patients can have a monogenic lupus.
Okay, we have one more.
Yes, so I'm Himanshu. So one more thing which I was just going through the cases, and I think you got a very good access to IVIG probably, but in real life scenario I was just wondering. So you gave 3 cyclos, then shifted to MF, then 1 cycle of rituximab, then IVIG. So isn't it like we are cycling this our armamentarium too quickly? That's what I'm wondering.
So we
because when you
waited
say
for a period of 3 months in each time, and the patient had not responded. So I think 12
because
to
that's the thing which is coming in my mind, that because all these therapies, they are strong therapies, they need some time to act. And sometimes keeping them on good dose of steroid and then probably repeating a rituximab 1 gram instead of going to, or completing the whole cycle of cyclophosphamide.
So already 4 months, 4 doses of high dose cyclophosphamide were given. So it is, I think, an enough duration of period to assess treatment response. And with rituximab also, we waited for 12 weeks, and IgG levels were not dropping. So we had to think of other line.
So
of
it's a
management.
difficult case. So we're just having thoughts from people. Yes, audience. Sorry, I don't know your name.
I am Dr. Starul, ma'am. I just wanted to know, in SLE, like we are using rituximab, and if we are not getting response, like in this case also that said the retux did not work, rather than using omnituzumab or a higher immunosuppression, should we give more frequent rituximab? This is in general for nephritis or for IHF. If we are giving by doing CD90 population and CD20 population, based on that 4 monthly retux, is there any indication for that?
So there is no data for anything. As Dr. Amin said in the previous session, all that is dependent on the physician. What you want to do, what you have access to, what the patient can afford, where are you working. So everything decides how you tailor the immunosuppression and how you try to get things under control. So there is no magic figures, there is no magic time. Somebody said 3 months, 4 months. So we have Sapan as the last comment. Dr. Mishra, next time.
You only said that I'm supposed to ask questions. So anyway, one simple thing is these patients complain of breathlessness when they lie down. So that tells you sometimes that, and we do dynamic ultrasounds. You do ultrasound and ask them to breathe. That's an easy way, to do it. But I agree with the CMV thing. That is sometimes missed in these cases. You have AIDP type presentations also in CMV. And also the rituximab thing. I think, yes, there was too frequent cycling, and you could have probably given rituximab, because there are case reports showing that these patients need either cyclophosphamide or rituximab, and there is
Sir, I think with the rituximab, we often see that there is increase in the BAF levels after we give rituximab, so it can also cause flare. And with obinutuzumab, it is observed that BAF levels don't, which obinutuzumab is causing to the B cells.
So Harsh, what people are saying is it's a balance between immunosuppression.
Yes,
finally, we lost the patient.
Yes,
succumbed to infection. So it's a balance between infection and immunosuppression. I mean, we all go wrong sometimes, and we try doing best for our patients. So it's a limit to what we can do and what we can guess in advance. But as what Dr. Chandrasekhar said, that generally shrinking lung syndrome has an excellent prognosis. Whatever we have seen, they have recovered very well. They have normal renal lung functions after that. So that is a little unusual in this patient, that the patient had multiple episodes. Very unusual, but can happen always. Thanks a lot for sharing your case with us. So we move on to the third case, which is by Dr. Gunashri. She is going to discuss another unusual organ involvement in a setting of lupus and APS.
Good morning, everyone. Myself, Dr. Gunashri, first year rheumatology resident at KIMS Hospital. My case is an adrenal insufficiency as initial manifestation of APS. Coming to case scenario, a 28-year-old female presented in 2018 with complaints of recurrent episodes of postural giddiness and syncope for 1 year duration. On evaluation by a cardiologist, she had postural hypotension, and on investigations, her TSH was normal, 8 AM cortisol levels was low, synactin test showed post-ACTH cortisol levels was 10, which was below the normal range. CT abdomen and pelvis showed decreased size of bilateral adrenal glands. So she was diagnosed as having primary adrenal insufficiency and treated with glucocorticoid and mineralocorticoid replacement. Later, in September 2023, she had sudden onset of left leg pain associated with swelling for 2 days. Venous Doppler showed DVT of left leg. Investigated by cardiologist, APLA panel was done. Anticardiolipin antibody IgM was 19, IgG was 42, and beta-2 glycoprotein 1 antibody IgM 42 and IgG 28. Lupus anticoagulant is 1.7. Diagnosed as having primary APS with triple positivity, treated with vitamin K antagonist warfarin. In October 2023, she had dyspnea on exertion and cough with hemoptysis for 3 days, evaluated by pulmonologist. CTPA suggestive of acute pulmonary embolism, and her INR was subtherapeutic, so she was treated with Dovax, rivaroxaban. Later, she developed menorrhagia when she was on anticoagulation. She was advised norethistedone 5 mg by her gynecologist. In December 2023, she had sudden onset of dyspnea and exertion with chest discomfort for 3 days with streaky hemoptysis, no history of fever. Again evaluated by pulmonologist, CTPA suggestive of pulmonary infarcts involving right upper and bilateral lower lobes. There is expansion of infarct territories compared to previous scan, and she was treated with IV heparin and followed by rivaroxaban. Presented to us at KIMS Hospital for second opinion. On examination, her vitals are normal. There is hyperpigmented macular rash with fine scales over the scalp. Rest of the general physical examination, it was unremarkable, and systemic examination was unremarkable. Investigations, CBP showing her HB was 10, WBC is 4,000, platelets are 77,000, and LFT, RFT are within normal limits. ANA, IF is 2+ speckled pattern, anti-dsDNA was negative, and DCT it was negative. ENA showing ribosomal P 2+, and anticardiolipin antibody IgM 19 and IgG 42, and anti-beta-2 glycoprotein antibody IgM 42, IgG 28. Lupus anticoagulant is 1.7, and C3 is normal 92, C4 is 20.4, which is low. Timeline of events. It was first started in 2018 with primary adrenal insufficiency. Later, in September 2023, she developed APS with DVT. Subsequently, in October 2023, she has acute pulmonary embolism. In November 2023, she had menorrhagia, and she discontinued anticoagulants. And later in December 2023, she had recurrence of pulmonary thromboembolism. Diagnosis, points favoring primary APS are adrenal insufficiency, DVT, recurrent pulmonary embolism, and thrombocytopenia, APLA triple positivity. Agonist features are discoid lupus rash, anti-ribosomal P2+ positivity. SLE with secondary APS, points favorable are discoid rash and ANA 2+, decreased C4, anti-ribosomal P positivity, thrombocytopenia. Against features are no systemic involvement. This is the ACR 2019 EULAR criteria for SLE. On scoring, she has 13 and so classified as having SLE. She was treated with therapeutic clomarin followed by warfarin and aspirin and hydroxychloroquine. Coming to discussion, patient with these are various guidelines on the treatment management. Patients with definite APS with arterial thrombotic events, according to ESC, EULAR, ASH and BSH, ISTH guidelines, they recommend the use of vitamin K antagonists. DOACs are not recommended, in particular rivaroxaban. In patients with triple positivity APS with both venous or arterial thrombotic events, preferable to use vitamin K antagonists only. In case of venous thrombotic events, in case of triple positivity, guidelines suggest the use of vitamin K antagonists. Whereas in case of single or double positivity, vitamin K antagonists as the first choice, but there are certain guidelines, EULAR and BSH and ISTH guidelines suggest the use of DOACs in these situations if the patients already on DOACs with stable anticoagulation, unwilling to undergo INR monitoring, and if they are low adherent to vitamin K antagonists, or contraindications to vitamin K antagonists if they have serious adverse events with vitamin K antagonists. Adrenal insufficiency in APS, it is one of the rarer complications of APS occurring in only 0.4% cases. Conversely, APS is diagnosed in less than 0.5% of all patients with adrenal insufficiency. There was a review literature study. Epsnosa et al. Found that 36 patients presented with adrenal insufficiency as the first clinical manifestations of APS. Coming to the pathophysiological mechanisms leading to adrenal insufficiency in APS, they are not clearly established. However, proposed theories exist. The adrenal glands have a rich arterial supply but are drained by a single adrenal vein. Thrombosis of this limited venous supply predisposes to hemorrhagic infarction, eventually causing hypoadrenalism. Key questions here: should APS be considered as a possible cause in patients presenting with adrenal insufficiency, particularly when there are no other thrombotic events, and role of rivaroxaban in APS?
Okay, Dr. Chandrasekhar, would you like to take the first question?
Now, I think you have to go case by case. See, if you don't have any other reason to explain, yes, it would be best to have a screen for APS because it's just going to add up your diagnosis. If your CT clearly shows it's a hemorrhagic or an infarct kind of things, then you have all the more a need to exclude APS. If you are not strongly suspecting it's just a shrunken adrenal cortex, no hemorrhages, nothing to suggest there was a bleed or an infarct, then you need to consider all other alternative diagnoses. Because problem with APS is, as all of us know, APS could be positive even in a normal individuals without having a definite evidence of antiphospholipid. So we may overdiagnose the APS and we put the patient on unnecessary anticoagulation, what happened as in the first case. So we need to be a little more careful when we are using an oral anticoagulants. The second question.
So whatever data we have as far as rivaroxaban is concerned, it's not really recommended. I'm not surprised if you actually looked at the case yourself and realized that the rivaroxaban was responsible for your menorrhagia in the first place. And then we landed up adding an estrogen preparation, which is anyway going to be prothrombotic. So this is a vicious cycle, isn't it? We turn around and treat fever with paracetamol, then the patient sweats, and then the patient gets dehydrated, so we give IV fluids. And that's exactly what we're doing even in this case. Let's stick to the guidelines till we have some more data. But one thing is very clear, DOACs in lupus, DOACs in APS currently are a very, very gray zone. And we leave it there.
Okay. Questions from audience. How many of you have seen a patient with adrenal insufficiency as man? Okay, so Dr. Molly's suggestion is that next patient is also APS. We will take the questions together. So thank you. Thanks a lot for sharing this question, your case. Very interesting. And we move on to the last one, which is by Dr. Hiren Kalyani. He is going to present you another manifestation of antiphospholipid syndrome, which is also a rare manifestation.
Good morning, everyone. My name is Hiren Kalyani, and I am going to present the case of a 7-year-old girl child who had presented to us with a quite unique presentation. So we know that people in medicine are fond of misnomers, but then lupus anticoagulant is a double misnomer. It is neither specific for lupus and nor is it is an anticoagulant. In fact, it is anticoagulant in vitro, but in vivo we know that it is known to cause thrombosis. So this is a 7-year-old girl child who was admitted in pediatric emergency with complaints of fever for 20 days. The fever was low grade and it was continuous and it was responding to antipyretics. And she also had bleeding from gums and nose for last 7 days. And those bleeding episodes were spontaneous, but over last few days it had worsened, so they had brought her to emergency. There was no history of similar complaints in past, and there was no localizing sign or symptom of fever. And she had normal birth history and normal vaccination history. Her family history was not significant. General examination revealed mild pallor and she was slightly febrile. Systemic examination was unremarkable except for mild non-tender hepatosplenomegaly. So given the short history, the first suspicion was infection. So her routine labs revealed microcytic hypochromic anemia, mild transaminitis, raised acute phase reactants in form of ESR and CRP, and coagulopathy in form of deranged APTT and INR both. So the pediatric team worked up for infections, and the infections were thoroughly ruled out, and so all of them were negative. And then the second possibility, given a 7-year-old girl child with pyrexia of unknown origin now, that the workup has already been done, and bleeding manifestation, hematological workup was also done. So peripheral smear suggested microcytic hypochromic anemia, and iron deficiency was obvious through iron panel, but there were no obvious signs for any hematological malignancy. So summarizing, a 7-year-old girl child with pyrexia of unknown origin, mild hepatosplenomegaly, coagulopathy, raised acute phase reactants, and mild transaminitis. So the differentials can be broadly divided into infections, malignancies, and lastly autoimmune diseases. Given the short history, autoimmune diseases is less likely, but then infections and malignancy are more or less ruled out. So to screen for an autoimmune disease, the pediatric team sent an screening investigation. So ANA was positive in high titer and high dilution in speckled fashion, and it was specific to Smith, Rho60, and Ku antigen. So they suspected it to be SLE, and probably the bleeding was due to anti-factor antibodies. So they also sent factor 7, factor 8, and factor 9. And to their surprise, factor 8 and factor 9 were low. So at this point, they sent us a referral that is it SLE with anti-factor antibodies. So when we looked at the case sheet, we were probably thinking that the work is done and the diagnosis is probably SLE with anti-factor antibodies. But then when we looked at the patient, so apart from the mild non-tender hepatosplenomegaly, there were certain other findings also. So as we can see that there are multiple tender nodules over the arms and legs. So with the greenish hue of the overlying skin. So we suspected it to be superficial thrombophlebitis, and it is unusual although, but then there were multiple foci, and we got the radiologist to confirm it through Doppler also. So it was superficial thrombophlebitis. So at this point we probably thought that this could be something else. This can be anti-factor antibodies, but this can also be associated antiphospholipid syndrome. And we know that when a patient of antiphospholipid syndrome bleeds, there can be 3 causes that I can think of. One is the severe immune thrombocytopenic purpura. Second is lupus anticoagulant can at times bind to prothrombin and cause hypoprothrombinemia. And the third cause is anti-factor antibodies when it is associated with SLE. So we thought LAHS needs to be ruled out at this point. So so we ordered further workup. To gather more serological evidence of SLE, we ordered DCT and complement SS. To screen for APS, we sent all 3 antibodies. And to work up for coagulopathy, we ordered a mixing test. So for mixing test, we know, the principle we know that we mix a normal sera, that is a control sera, to the patient sera. And whenever there is factor deficiency, the coagulation time is corrected. And whenever there is factor inhibitor, the coagulation time is not corrected. So here are the results for our patient. So PT got corrected. So which suggested that there is a deficiency of either extrinsic or common pathway factor, that is 7, 2, 5 or 10. But then APTT was not corrected, which suggested that there is an inhibitor to a factor involved in the intrinsic pathway. So here also there are 2 different results, and we are still not sure what we are dealing with. So to determine whether which factor is deficient, we ordered factor SS. And the principle of factor SS, I'd just like to highlight that For APTT-based factors, for example, when we are assaying factor 8, we need to add phospholipids. So in a patient who has antiphospholipid antibodies, if we are assaying factor 8 or let's say factor 9, due to antiphospholipid antibodies, the factor assay will be erroneous, and factor 8 or factor 9 will be actually low. So these are the results of our patient. So factor 8 and 9 were already low, that is known, but then factor 2 was also low. So this confirmed, but then PT got corrected on mixing. So this probably is due to deficiency of prothrombin, which explains the prolongation of PT and correction of prothrombin time on mixing studies. And inhibitor to factor 8 and 9, which explains the non-correction of prolonged APTT on mixing studies and low factor 8 and factor 9 activity. Now these inhibitors to factor 8 and factor 9 are these anti-factor antibodies? That is the question to be answered. So to answer that question, there are dilution studies. So dilution studies will help us in differentiating a specific inhibitor from a non-specific inhibitor. So the principle is that on serial dilution, if the inhibitor is specific, it will not get corrected, and if the inhibitor is non-specific, it will get corrected. So for our patient, there was normalization of factor 8 and factor 9 activity. So that indicates that there was a non-specific inhibitor, that is lupus anticoagulant. So I know it is a complex this thing, so let's just summarize. So 7-year-old girl child with fever and bleeding manifestations, PT and APTT were prolonged. And on mixing studies, PT got corrected, which suggested a deficiency of either 2, 5, 7, 10 or a combination. APTT did not correct, that suggested an inhibitor to 12, 11, 8 or 9. So we did factor assays to know which factor was deficient and which factor had antibodies to. So factor 8 and 9 were low and factor 2 was low. So dilution studies revealed that there was a non-specific inhibitor, that is lupus anticoagulant. So lupus anticoagulant plus hypoprothrombinemia. So are we dealing with LAHS? So probably yes, but then to demonstrate lupus anticoagulant, you need to do a ISTH approved method, that is DRVVT or APTT sensitive lupus anticoagulant. So lag by DRVVT was also positive and cardiolipin antibodies were also positive. And the diagnosis of SLE with LAHS was made. And the patient was treated with IV steroids initially, and then later hydroxychloroquine and MMF were added. And these are our lab values. So we can see that INR had improved and complement assays have also started to improve. So I'd like to summarize my case that LHS is, as in our case, it was on the background of autoimmunity, but sometimes it can also follow a viral infection. In pediatric population, usually it follows a viral infection. In that case, it is known as LHS-VI. So I'd like to highlight that sometimes viral infections can also trigger lupus anticoagulant hypoprothrombinemia syndrome. And whenever we see a patient of APS with prolonged PT, screen for LHS.
So, thank you, Hiren. You can leave the last slide on. You wanted to read it, we will read it. You can leave that slide on if they allow you to leave it on. Okay, so you have any questions for the panelists?
Yes,
one each.
Ma'am, as we have seen in our patient, she had some foci of superficial thrombophlebitis also, and at the same time she had bleeding manifestations also. So how common is it for a patient of APS to have both the manifestations together, like bleeding episodes and thrombotic episodes as well?
I mean, it's not really uncommon because I think in the first session we had a discussion. So if you remember that there are a few conditions where you can have thrombosis, bleeding, and a thrombocytopenia. I think one of them is an APLA syndrome. So you can have, but percentage, I don't know how much is the literature, but we do see in our clinical practice at least 1 or 2 cases in a year who presents these kind of scenarios.
Right, sir. Yes, sir, and secondly, I would like to ask, how should we go about the anticoagulation? Because in case reports, there are few case reports where they have shown that when LHS patient is treated, when prothrombin level starts to become normal and INR starts to become normal, then those patients are more susceptible to thrombotic events. So what should we do given that she had strong...
See, it's basically your clinical judgment and based on what is the one which is dominating. Right. Suppose if the INR is quite prolonged, even sometimes if the INR is quite prolonged, if thrombosis is quite dominating in your clinical presentation, then you need to put the patient on oral anticoagulation. So that's why in a patient with APLA, your INR may not be a better guide when you are trying to monitor it. The very base PT INR, when you see in some of the patients, could be 2 to 2.5 because of these anti-clotting factors, antibodies. So you need to keep that as your base value, and from there you need to see how much it is enhanced. So monitoring is also need to be a little careful in those group of patients, and you have to go by the clinical scene. So that's where AI fails. That's where you still continue to work there.
Right, sir. Thank you.
We have lots of hands. So Dr. Satish first, and then Dr. Suma.
So what we do is in SLE, if anybody has got bleeding, so we know that lupus anticoagulant does not bleed. They cause thrombosis.
Right.
So this child typically has got ecchymotic patch. With the platelets normal, if somebody has got ecchymotic patch, even if lupus anticoagulant is positive, we always consider this syndrome.
Right.
Lupus anticoagulant, hypoprothromia, LAPHS, you missed the H, LAPHS.
Right.
Okay, and we in our cohort of almost 600 SLE patients, we have 8 children. We have published 5 with the lupus. Immediately they accepted because it's a very rare disease.
Right.
So any child with SLE who has got bleeding with normal platelets, you think of this syndrome. Don't worry about lupus anticoagulant. Then again, for treatment part, we always do the coagulation profile straight away. We do the prothrombin levels will be low. It is like anti-ITP. So you have antibodies against prothrombin 2. You just give steroids. If you only want to treat this, we don't worry about anticoagulation unless they have, as Sir said, significant thrombosis is there. So we don't anticoagulate them for this lupus anticoagulant syndrome. We give only steroids. You give steroids for 3 months, 6 months. You repeat your PT will become normal. If you want 100% sure, you do the prothrombin time again, prothrombin level again to make sure it's normal. That's why we treat. And it's mostly commonly associated with the lupus. So every time when you have a patient, virus, yes, we will think of, but rule out lupus before you labeling as viral induced.
Right. Okay. Suma, short comments from everybody.
I think Satish has explained very nicely about the lupus anticoagulant and hyperproteinemia. But what I wanted to say is when you see children with this kind of prolonged APTT and PT and in a young child without obvious focus, the commonest infection is mycoplasma. It's very common to get these antiphospholipid antibody positivity with mycoplasma, which can be symptomatic or asymptomatic. Very common.
Okay, Ruchika. Suma, you can pass it on behind you.
I just wanted to add, like nowadays we are seeing it in adults as well, quite common. But our only worry is, like we had a patient very recently, wherein they presented with LAPHS, but then on follow-up, they present with thrombotic manifestation. And then when you look back, you realize that the gap score was very high. So they need a very regular, and that was in a span of 2 months, in fact. So in those patients, I am wondering whether, once you follow up and their coagulation parameters have improved and the bleeding has stopped, whether there is a role of giving aspirin to these kind of patients who are presenting with very high gaps. This patient presented with complete blindness after that.
So as what Dr. Chandrasekhar said, that these are decisions made on individual patients. Like if thrombosis is predominant, you would definitely give anticoagulation. So that depends. So Sapan.
I had one case where there was this acquired wound in adult, as she said. And I think you have to involve a hematologist here because these assays are very difficult to do. And they gave factor VIII, replace of factor VIII because she was bleeding continuously and the platelets are normal. So that is why I saw one case and immunosuppression we gave for the antibody to that. In the previous case, you asked the question about DOACs. As we all know that the trials are not officially. But in this very hall, I think Dr. Khamasa, when he came 2 years back, he said that if you have to use, you should, at least in arterial, you double the dose and try them in those patients.
Any comments from students? Any observations on APS? We have 2 interesting cases for you. So is it hypoglycemia setting in?
Here.
Yes, please.
So is the low prothrombin always antibody mediated, or is there can there be another mechanism for it? So I have a patient who doesn't have any typical lupus autoantibodies. She has APLA antibodies and low PT, and she had a bleeding and she never had a clotting manifestation. So is there any non-autoantibody directed mechanism for a low prothrombin?
Yes. Congenital deficiency.
Maybe congenital hypoproteinemia may need a replacement than anticoagulation.
So I don't see any more hands. Kaushik, you want to have one comment? Any comments? Chandrasekhar, any comments? So I just had one correction on the presentation, this third presentation. what she said, what she meant actually was that what she had written, that 36% of patients with APS present as adrenal involvement as the first presentation. That's not the correct thing. That all the patients of APS who had adrenal insufficiency, among them, when Espinoza has published this 86 cases, what they found was in 36% of them, adrenal insufficiency was the first manifestation, like in this lady. She first presented with adrenal insufficiency and then went on to have multiple episodes of vascular thrombosis. So thank you all. Oh, we have one hand, finally. Yes, tell us.
The anticoagulation, like can we try something else apart from the routine or something?
Okay,
like
Dr. Kaushik, the question is APS with platelet count of 30,000 with thrombosis?
Yes, ma'am, with
With
thrombosis.
thrombosis. What will you do? Would you give anticoagulation at that stage, or would you do something different?
So it also depends on what your clinical disease activity is. So, you take a page out of every chapter that was quoted right now. So one of the things is, are you talking about secondary APS in the first place? So if you're talking about secondary APS, the primary disease is triggering the APS, and so you're going to have a problem there. If you're going to use the steroids and immunosuppression, your platelets are likely to improve.
No, so I meant like we had seen patients of catastrophic APS.
Just let me finish for a minute. Just a second. I just finish my sentence because then I will be able to take on what you're saying. On the other hand, if you're talking about an ongoing thrombosis where you don't have an active disease or your primary disease seems to be well controlled, but you have an active thrombotic episode which is going on with low platelets. Now, are your platelets being consumed because of active ongoing thrombosis, or whether the thrombosis and the APS are going parallel? So that's the second judgment you'll take, in which case you will start the low molecular weight heparin or whatever, but not at a therapeutic dose. You will start at a lower dose and then build up as you're treating the thrombosis. And thereafter, the last point being, the caveat being, the fact that if you have an ongoing thrombosis, if you do not have an ongoing thrombosis, well-clotted thrombus, and you have low platelets, and you have nothing else in terms of disease activity, then you would use full dose while watching the platelets. Now I take.
Yes, sir. So we had this patient of catastrophic APS. She had it was secondary APS SLA with secondary APS. She had lupus nephritis. She had a DVT, and she had a platelet of around 20-25. And she had severe thrombocytopenia. So we were trying to maintain it between 30 to 50, and we had given her like IV heparin and with every 6 hourly APTT like that. So I just wanted to know your approach. Thank you.
No, I think he made those scenes clear. So you need to make what is the pathogenic process which is quite active. Right. If it's a platelet consumption, then yes, you need to actively coagulate, anticoagulate. So if it is a secondary reason for thrombocytopenia, so if you look at it that, then you need to work it towards that. So it's a sort of a balanced act. So if the rise in platelet can promote the thrombosis, that's a concern we have some time. But you need to look into the scene and work on that.
Thank you, sir.
And heparin is the safest anticoagulant. You can always revert. If there is a bleeding, you can just use protamine. So it's a very, very safe anticoagulant. Yeah. So thanks a lot, everybody, for your participation, and 4 participants who presented wonderful cases. And we still have the rapporteur, Gayatri. And Gayatri is going to give us the capsule, which hopefully we will remember by the end of this session.
First of all, thank you organizers for giving me this opportunity, and presenters, you presented really well. I actually learnt a lot. Thank you, ma'am. Thank you both sirs. So we had wonderful cases. 2 cases were of difficult APS, and we had initial 2 cases of difficult SLE. So first, our first patient was a patient who was presented with PEO, later had manifestations of lupus, later developed symptoms the symptoms were suggestive of ACS. So literally there was intramural hematoma as told by presenter. It was on the basis of angio and IVUS, but our house quite didn't agree for the diagnosis of SCAD. but still, if at all we have to consider spontaneous coronary artery dissection, it's very, very unusual, and it ranges from 0.1 to 1%. This is the latest statement by American Heart Association. This statement was given in 2018, and there is actually an intramural hematoma which leads to a false lumen, and the true lumen is obstructed, which leads to the obstruction of the blood flow. So in our patient, in first case, the patient quite didn't improve with anticoagulation and thrombolysis. Rather, patient worsened with that, but did improve with PCI, etc. So I think we need to think about the diagnosis of SCAD in patients with high-risk features like lupus, Takayasu, FMD, etc. The second case was quite difficult, quite interesting, and quite unfortunate because they did everything possible. So coming to the second case, patient had class 3, class 4, 5 lupus nephritis and also had lupus anticoagulation, LAC positivity. Patient had quite an aggressive disease, didn't respond to steroids, mycophenolate, tacrolimus, then IVIG, etc. Patient was also given cyclophosphamide. Then patient was repeatedly given IVIG, was tried on rituximab MMF combination also. Then came our key player, which was obinutuzumab, and patient had initially a good response to this type 2 anti-CD20 antibody, but unfortunately we lost the patient, and the key point here was to look for the infection. Unfortunately, as ma'am said, we always try our best and nobody can predict the future of difficult lupus cases. So there were few questions. So shrinking lung syndrome, as sir said, or as he pointed out, it actually has a good prognosis. It's a quite rare manifestation. It was first diagnosed in 1965. The entity was first discovered in 1965. The estimated prevalence is very low. It is less than 1%. So all the patients with SLS or shrinking lung syndrome in SLE will have some complicated respiratory features. And most of the times it's a diagnosis of exclusion because all our other respiratory illness also will have the same similar features. The most important thing is FVC deterioration. So coming to the key player in this case was obinutuzumab. So the Nobility trial has shown that obinutuzumab appears to be really effective as compared to placebo in reducing the renal flares. Also, it is quite effective in preserving renal functions. So I think we need, this is just a post-hoc analysis and we need more global data on this newer antibody. Coming to our last two cases of difficult APS. So as ma'am said, primary APS is, primary adrenal insufficiency in APS again is very, very rare, but if at all, if APS has any endocrine manifestation, then probably primary adrenal insufficiency is the most common amongst them, and that could be dreadful, and that's because it can have hemorrhage as well as thrombosis, and it can suddenly have catastrophic features, and that has to do with adrenal vasculature. As she said, it just has one adrenal draining vein. So mortality rate is not very high in adrenal insufficiency with APS, and patients respond quite well to your usual anticoagulation, mineralocorticoid, glucocorticoids, etc. So the last case, which was quite complicated, and it was a learning case. We learned a lot because it is extremely rare. So it was a lupus anticoagulant with hypoprothrombemia. LAPGS it has association of acquired factor 2 deficiency with LAC positivity, which itself is a very rare condition. As we all know that factor 2 deficiency will obviously lead to hypoprothrombemia and bleeding manifestations because of delayed fibrin production and decrease in platelet aggregation, etc. So most commonly it occurs in SLE patients, young adults, and more specifically in children. The commoner causes of LAC with hypoprothrombemia obviously include your lupus, but you have to again look for other causes like lymphoma or certain infection. Sometimes it can be precipitated just by previous surgery or trauma. So bleeding is quite frequent. As we all discussed, bleeding is not very common in primary APS, but here particularly bleeding is quite frequent. The most common treatment modality is steroids, and sometimes we have to pulse, or many a times we have to pulse the patient, followed by immunosuppression of choice, of your choice. Then we can use certain products like prothrombin, then vitamin K, FFP, PCV, etc. But their utility is not quite demonstrated because we don't know which is acting faster, whether it is immunosuppression or our factors. So as ma'am also pointed out, our pediatric colleagues, pediatric rheumatologists quite pointed out that in children we have to look at mycoplasma infection when they have APLA positivity. And then there was a consensus regarding use of anticoagulation in APLA. So direct oral anticoagulations are not recommended by many guidelines unless they are contraindicated, or if patient doesn't want the frequent monitoring. But I feel in our day-to-day practice, we are also using acetrom or warfarin more frequently. And as ma'am said, heparin is the safest. When in doubt, probably we can go for heparin. So thank you so much. Thank you.
Thank you, Gayatri, for a very crisp summary of the 40 minutes. Thanks a lot.
Thank you, madam, for quickly finishing on time. And we'll have a short break. Originally meant 15 minutes, now only 10 minutes. Okay. I request all the delegates on your left and the faculty and senior people on your right side for a quick tea break. We'll assemble back at 12 past 10. Thank you.
इलेक्शन पीरियड है, ऊपर से सब कोटी पहनेंगे। हैदराबाद में गर्मी का दिन है, इसलिए ब्लेजर नहीं पहन सकते, सिंपल है। आज बारिश भी गिरेगा। मैं बोलता रहा हूँ पीछे जाना।
These are the images, all images we are showing. 96 images.
Okay. So, which have been selected for this?
Yeah, 96 submit, all the 96 submit, all are there. In the brain.
And these are not.
That's nice. Nice discussion.
We have to start the next session, so I request everyone to please come into the auditorium. So we'll move on to the next session, pediatric rheumatic diseases. I request Dr. Suma, Dr. Satish, Dr. Vignesh and Dr. Anjani to please come onto the dais.
A few points I would like to mention. Some of the posters are not kept. I think I request you all, the people who have got posters, please stick them in the poster area now, because the poster judgment will happen during the lunchtime. Because of the time constraints, we don't have much time for the poster viewing at judgment. So I request Dr. Suma to save a bit of time here also. So technically, I think we are 1 hour late. Yeah. So soon after this session, we'll have 45 minutes break. So 3 things happen during this break. You have to cooperate with us. First thing is we will have a group photo where everyone has to come to the middle of the conference hall. Probably take less than 5 minutes. We'll have a quick photograph. By today evening, you'll have a photo with frame in your hands. This is number one. Number 2, I request all the poster judges have a quick lunch soon after it's announced in 10 minutes. Then next 30 minutes you can spend in the poster area for the poster judgment. Thank you all to you, Dr. Suma.
Welcome to the pediatric moment for the meeting. I invite the first presenter. Who's it? I haven't it. Dr. Sumana, the first presenter to come. We're going to try and save time, so no, I think the presentation will. Okay, Dr. Israrul Haq.
Yes, ma'am.
The first case, very interesting case.
Shall I start? Good afternoon to all respected teachers. So I am Dr. Israrul and I shall be discussing a case of monogenic lupus. So directly going to the case. So we had a patient named AM, 13 years old male, a 5th class student, resident of Medinipur, West Bengal, and born out of a 2nd degree consanguineous marriage with an uneventful normal vaginal delivery at term, with normal development and vaccination history of appropriate for age, and without any prior history of comorbidity. So he presented to us with a 7 years history, that is age of onset of symptoms were 6 years of age. The main symptoms were photosensitive rash for last 7 years that involved almost all the body parts, and he also had non-scarring alopecia. He also complained of fever off and on for low-grade fever for last 2 years without any localizing symptoms. In addition to that, he had inflammatory polyarthritis that was symmetrical, additive, and involved both small and large joints of all 4 limbs. He also complained of oral ulceration, but what is more important and the indication for admission for him was a proximal muscle weakness that was for last 6 months, and he was bedridden for last 3 months. So coming to the patient directly at presentation, this was the patient we had. To be precise, he had ACLE rash, DLE rash, vasculitic rash, active palatal ulcers, alopecia, and a tender joint count of 4 without any sole joint count, and fixed flexion deformity of 45 degree involving both the knee joints. Coming to the knee negative history, he had no history of any Raynaud phenomena, chilblain, dysphagia, nasal intonation or nasal regurgitation, dyspnea, cough, seizure, frothy urine, decreased urine output, or pedal edema. Now, interestingly, that patient also had headache for last 2 years, that is holocranial mild to moderate headache, for which he was evaluated in neurosurgery, and in November 22, he was diagnosed to have chronic subdural hemorrhage involving the right frontoparietal region, that is depicted by the arrow. But what was more interesting is that was an incidental finding of tiny foci of calcifications in bilateral basal ganglia, thalamus, and cerebral cortex. So, from neurosurgery, he was started on levetiracetam, topical steroids, and calcium, and was referred to our department. So, with a finding of ACLE, DLE, vasculitic rash, inflammatory polyarthritis, possible myositis, and constitutional features in the form of low-grade fever, definitely SLE was our first consideration. But what is that? He had an early age of onset, predominant mucocutaneous feature, clinically no evidence of nephritis, and a possible NPLE. So a possibility of monogenic lupus was also kept from our side. But what was against that? That since till as age of 13 years, he has no hospitalization for severe infection. Now another thing that we got, he had intracerebral calcification. When we take this factor into count, it can be due to congenital infections, it can be due to parathyroid disorders or carbonic anhydrate deficiency, but it can be also seen in other interferonopathies like AGS, which it can be seen. SLE, it is a rare manifestation. Case reports are there, Candle and DADA2. So coming to the workup directly, so we found that he had mild anemia, ESR, CRP, ferritin were normal, urea creatinine was normal, SGPT and SGOT were raised, 2 times of upper normal limit, CPK was marginally raised, and there was no evidence of nephritis on workup. And immunological workup showed ANA 3+ coarse speckled, anti-DS DNA mildly elevated, complements were normal, RNP Smith was 2+, Smith single positive, and Coos single positive. Coming to the imaging findings, X-ray knee joint, the joint space was normal, indicating that it was not due to contraction and not due to a primary arthritic process. MRI thighs showed patchy edema in adductor muscles bilaterally, and EMG was suggestive of myopathic pattern. Calcium phosphate, parathyroid, and DSH were normal, ABG was normal. So, since we had mind of that patient may be having a monogenic SLE, we sent the whole exome sequencing, and it suggested a C1q mutation that involved the exon 2, and it was reported as likely pathogenic. So now, when we apply this ACR EULAR, although this is a classification criteria, but our patient had 16 points out of this, he satisfied the mandatory criteria, and we diagnosed him as a case of C1q monogenic SLE with components of mucocutaneous, inflammatory polyarthritis, myositis, and constitutional features with a baseline SLEDAI score of 16, and he was started on hydroxychloroquine 5 mg, prednisolone 0.5 mg for myositis, and methotrexate 10 mg weekly, and levetiracetam was continued. But we had no answers for chronic subdural hemorrhage and intracerebral calcification. We assumed that it could be related to disease process, the intracerebral calcification in particular. But what was more alarming is that till the age of 13 years, he had no admissions for severe infection. Just 1 month after we started him treatment, he was again readmitted to us with a prepatellar abscess, and that was secondary to Staphylococcus aureus, and during hospitalization, he developed macrophage activation syndrome that was managed with IVIG, 2 grams per kg, fresh frozen plasma, and antibiotics as per the culture sensitivity report.
So at follow-up at 8 months, this is our patient. We can see his SLEDAI score is 0. He walks with support with more than 90% improvement in rash, alopecia and weakness, and no serious infection after we discharge the patient of admission. And currently he is on prednisolone 5 mg, hydroxychloroquine and methotrexate. So he is in DORIS remission on therapy as well as lupus low disease activity state. Now, just a quick review. So, monogenic SLE, I just highlighted two things. The TREX1 mutation and AGS5 mutations, we can have intracerebral calcification. What is more important is this review of paper. That was done by Van Sarenberg in 2015. So, he reviewed 45 patients of C1q deficiency that were seen worldwide. And what he found that age and sex ratio in this category of patients of SLE were almost equal. That is in contrast to what we know. And during follow-up, 80% of these patients develop features of SLE. But when we come to presenting features, only 44% of the patients had features suggestive of SLE when they had presented first with the health faculty. And 36% patients have both features of SLE as well as infection when they had presented first. And only 13% had patients had presented with only infection, while no symptoms, 7%. These were mostly relatives of the affected population. And now this is very important slide. So when to derive some meaning, so when we compare C1q deficient SLE patient and pediatric juvenile patient from INSPIRE cohort, that is the largest cohort from India that was presented in the ACR 22, and CARA cohort, which is a Western cohort. What we observe is that the mean age of presentation is 5 years in juvenile C1q, while it is 14 years in the INSPIRE cohort, and CARA cohort it was 13 years. So age is significantly less. The male and female ratio is 1:1. And apart from that, this squared rash is very common in this population. CNS involvement is slightly more common. Serositis, hematological and anti-DSN is less common in these patients. And only 2 patients had intracerebral calcification out of these 55 patients. So when we ask what kind of patients should be suspected of having C1q deficiency, so young patients with severe infection, cutaneous manifestation dsDNA negative, and absence of CQ in renal biopsy, we should suspect them. What additional we can do to them? We can treat with FFP, additional vaccination and BMT. Thank you.
Wow, fantastic timing. Congratulations on a very nice presentation. Did you have questions for the presenters?
Yes, so my question is that do we have any explanation of SDH in this patient, and do we have any other case reports? Like I did not find any association of SDH with monogenic C1q SLE patient. Do we have any additional information in that? My first question. Second is that when we consider infection as a cause of mortality in this subset of population, because I said infection was a predominant presentation in this population, so what is the risk of infection causing mortality in this subgroup versus juvenile subgroup versus adult patient? That is one question. And any data, any experience on features of renal biopsy in this particular subset? Because I could find, we have actually 2 patients here. We have 3 patients in our institution. 2 had renal involvement, both had class 5 without C1q in the renal biopsy. So what is your experience regarding that, sir?
So Vignesh, will you take the first question about this subdural hematoma?
Yeah, Israel, a very nice presentation. So once you have confirmed it's a C1q defect, I think it is important we keep this child on prophylaxis. We usually start these children on prophylactic cotrimoxazole so that they don't develop infection in future, and also they need immunization.
Yes.
Because their antibody responses are intact, and giving immunization would prevent further infection. That is point number 1. Number 2, I would rather treat it as a major organ involvement. And do you have any hypothesis for the intracerebral calcification why this patient had?
Sir, I don't have. I could find only 2 case reports of this intracerebral, but I could not. But one thing is that when we encounter calcification in SLE patient, it is mostly secondary to vascular involvement. So if vasculitis, cerebral vasculitis is there, and due to if parenchymal damage is there, cerebral parenchymal damage is there, then secondary to damage patients can develop. And when acutely they develop, that is mostly associated with active vasculitis, cerebral vasculitis, sir.
Yeah. So C1q deficiency is actually an interferonopathy.
Yes.
Your C1q is necessary for type 1 interferon release from your monocytes actually.
Yes.
So the deficiency can manifest as sometimes the features of type 1 interferonopathy can be seen in C1q deficiency also.
So nice presentation. So what you suspect is like even though they say monogenic lupus is due to three things. One is interferonopathies, one is C1 early complement deficiency, third one is fast ligand issues. Sometimes, as Vignesh said, if you have C1q deficiency, they can have interferonopathies also. That may be the reason for your calcification, because calcification is very particularly told in acardic gluteus syndrome due to TREX1 gene mutation. When they will present like cerebral palsy. Because we have some patients of cerebral palsy, like managed like cerebral palsy, with development delay, hypertonia, brisk reflexes, finally develop some autoimmune manifestation like chilblains, gangrene. Then we finally return back and saw it's all interferonopathy. They do very well with baricitinib. Because that's a drug which is going to work. There's no point in giving steroids and all the immunosuppression if it is going to be interferonopathy. Otherwise, if it's complement deficiency, what is a major manifestation? Your child has got more of autoimmune manifestation. You treat the autoimmune manifestation. If they have infections, then you give antibiotics, prophylactic IVIG, all those things, you go in that side. That's why usually we treat. So as you said, suspect monogenic lupus. If anybody less than 6 years develop lupus like manifestations, male child, consanguinity, very, very important, because most of these patients are autosomal recessive.
Yes, sir. That's why they did. Out of 45, 20 patients have history of consanguinity. That is very important.
Previous sibling child died or similar illness in the family, you always suspect monogenic lupus, and you do have to do the whole exome sequencing to confirm the diagnosis.
Satish had one more question, and that was to do with mortality due to infection at different kinds of lupus. So he wanted to know about the monogenic lupus compared to young children and older adolescents.
See, this monogenic lupus, we all know that it's starting less than 6 years of age, very early presentation. Obviously, their morbidity and mortality is going to be high due to various manifestations, especially I have one child, a 3-year-old child with monogenic lupus, severe lupus nephritis. Now the question is, what drug I will give? This child will not swallow mycophenolate. So it's always going to be difficult to manage this type of children when they present very early with significant organ involvement. Okay, definitely is going to be high.
Sir, any opinion on BMT as a therapy when in treating such refractory patients? We have 3 case reports of BMT being used. One of the patient died and 2 are surviving.
So before answering, so why do you think BMT would be useful in C1q deficiency?
Sir, BMT should, I think, because of it can be deficiency, either it can be due to the complete lack of protein, or it can be a dysfunctional protein. What we see is that majority of the patient have complete deficiency from the serum. So BMT is likely to correct that deficiency. And what was seen in the BMT patients, that C1q serum C1q level normalized after BMT. So that although one patient succumbed due to complication of bone marrow transplantation, but they achieved their primary motive. They wanted to correct the primary deficiency which was causing the autoimmune phenomena as well as the infection. So that can be achieved.
Yeah, so amongst all the complements, C1q is the only complement which is produced by your monocytes.
Yes.
The rest other complements are produced by your liver actually. So that is the reason why a hematopoietic stem cell transplantation would be indicated if you have a refractory autoimmune or infection complications in C1q deficiency. The other therapeutic option which you can consider in refractory autoimmune complications in C1q deficiency is a fresh frozen plasma infusion. Because fresh frozen plasma also has quantities of C1q in that.
Yes, sir.
So people have used FFP and they have demonstrated normal C1q levels in the patient.
So there are 2 problems that I saw in the literature. One is that FFP has to be given weekly if you are actually trying to give it effectively. Second problem is that few patients were developing antibodies. In that cases, FFP even not able to normalize the C1q level. So
it is very onerous, yeah. Any questions from the audience?
Rheumatologists we don't see, but the neurologists see plenty and they don't bother too much about that.
Neurologists are well averse with this acardic gluteus syndrome. Most of the patients with the acardic gluteus syndrome follow with neurology. When they develop autoimmune manifestation, usually land up with the rheumatologist. The another one test is, suppose I do like yesterday like thing, I'm waiting for the mutation to come. Another one is a total complement, CH50. Because in this patient, CH50 will be low, C3, C4 can be normal. So that's again one clue saying that it is not C3, C4 deficiency, it is due to other complement deficiencies.
Sir, regarding the pattern of calcification, I just wanted to tell, in the FAR disease, it is mostly a periventricular. It less commonly involves the substance of the brain, that is parenchyma, cortex, and more commonly is typically a periventricular location. In contrast to what we had in this patient, there was no periventricular calcification, it was only a substance matter that was involved. And basal ganglia is the most commonly involved part in this monogenic.
So we had a very nice discussion. Thank you, Dr. Israrul. In the interest of saving time, let's call the next presenter, and that would be Dr. Vishnu Koneru, who's going to present a case of Blau syndrome.
Good afternoon, respected faculty members and colleagues. I'm Dr. Vishnu, a second year resident at JIPMER Pondicherry. At the outset, I would like to thank all the organizers for giving me this opportunity to present my case. So this is the story of a 2-year-old girl born of a non-consanguineous marriage with an unremarkable birth history with normal developmental and vaccination history. Through her growth monitoring, she always was noticed to have poor growth parameters, and there was no prior hospitalization stay. So she presented to us at the age of 2 years with a 2-month history of on and off fever episodes, productive cough, boggy fullness of the joints involving knees, ankles and wrists with no pain, warmth or stiffness or other inflammatory features. There was family history of TB noted in the uncle 1 year back. In the context of this clinical profile, the differentials considered were tuberculosis, juvenile idiopathic arthritis, protracted viral illness in the setting of subacute duration fever and respiratory syndrome, and acute rheumatic fever with lower limb large joint predominance, the age group and also the preceding respiratory features. Incidentally, the patient was also seen to have asymptomatic skin colored scaly papules on the trunk, face and the extremities, the differential for which were considered to be cutaneous TB and atopic or autoinflammatory dermatitis. The patient was worked up for, she was seen to have positive findings of leukocytosis, elevated HSCRP. She was worked up for JIA where RF and HLA-B27 were seen to be negative. Slit lamp for uveitis was seen to be normal at that time. Fundus was seen to be normal. There were no choroid tubercles. However, bowel fluid analysis showed Zeal-Nielsen positive for acid-fast bacilli, although the culture came out to be negative later. The skin lesions were parallelly punch biopsied and the report was awaited and was planned to be collected at follow-up. Provisionally, the patient was diagnosed as TB with a possible associated ponsets or a parallel juvenile idiopathic arthritis and was started on anti-tubercular therapy and advised for follow-up evaluation in the rheumatology clinic. The fever and cough resolved fairly quickly, and however, the patient did not follow up to collect the biopsy report or for rheumatological evaluation. She then presented at her second visit at the age of 6 years with a 6-month history of diminished vision and floaters. On examination, there was exotropia and synechiae. As we can see in the diffuse illumination of the right eye, the pupillary margin is ragged, and there is an inflammatory membrane which was most likely covering the lens, which eventually might have led to the complicated cataract in the right eye, which was confirmed on slit lamp examination, and bilateral uveitis with right eye complicated cataract was diagnosed. The patient was also at the time still seen to be underweight and of short stature. The patient was then referred to rheumatology from ophthalmology, and she was seen to have persistent, gradually progressed, non-inflamed, boggy joints with camptodactyly, as we can see in the left fifth PIP joint. X-rays characteristically showed lack of erosions. However, there were kind of dysplastic changes with poor carpal bone formation, and also as we can see there is a fifth PIP joint space narrowing signifying camptodactyly. Skin biopsy report, the skin biopsy which was done in the first visit was collected now, and non-caseating granulomas were seen to be reported along with perivascular lymphocytic infiltrate. Zeal-Nielsen staining was negative. So in summary, we have a child who presented first at 2 years with height and weight less than 3rd centile for age throughout the hospital visits. She presented at 2 years with a family history of TB with fever and cough, and also she was noticed to have recently noticed to have boggy swellings of joints and asymptomatic skin colored scaly papules. Investigations showed raised TLC and CRP, and bronchoalveolar lavage ZN staining showed acid-fast bacilli positive, which in skin was biopsied. Report was planned to be collected later. Diagnosis was TB with a possible Ponsett/GIA, and ATT was started at 6 months. The fever and cough resolved quickly, and even the skin colored papules also diminished. The patient then defaulted follow-up, presented later at 6 years with the complaints of bilateral uveitis and complicated cataract. Boggy swelling of joints was seen to be the joints were seen to be in a similar shape, both literally and figuratively. And the skin papules, although resolved, the biopsy now showed non-caseating granulomas. So in summary, we have a patient with a symptom complex of eye involvement with granulomatous, with uveitis, joint involvement with boggy synovitis, and skin involvement with granulomatous dermatitis with a possible preceding early infective trigger. Clinically, the patient was diagnosed as Blau syndrome and genotyping was done. So this is the report of whole exome sequencing, which showed heterozygous variant with missense mutation, and this was seen to be pathogenic on computational evidence, and also it was previously reported. The gene involved was, as expected, NOT2 gene. The treatment plan was made for this patient targeting all domains involved, although the skin was not involved at the time. The uveitis was first cared for. She was started on ocular steroids and cycloplegics, followed by peripheral iridectomy, which was done, and a plan for complicated cataract management was made. Arthritis and uveitis both were targeted. Initially, the patient was started on methotrexate with a plan for close follow-up of uveitis response. However, at 1 month of follow-up, she was seen to have persistent anterior chamber flare, and hence the decision was made to add on adalimumab. And also the patient was given an option for antenatal counseling and preconceptional testing at the next visit. So this is my summary, where Blau syndrome is a rare monogenic autoinflammatory disease with gain of function mutation in the CARD15 or NOT2 gene with autosomal dominant inheritance. The classic triad of rash, arthritis and uveitis is seen in around 55% patients. Non-caseating epithelioid and giant cell granulomas in affected tissues serve as a hallmark. Fever is particularly significant, especially in young age. Boggy swelling, camptodactyly and bilaterally symmetrical arthritis of wrist and hand joints are fairly specific, the most consistent clinical clues to diagnosis. And R334W is the most common mutation observed in the Indian population. So the questions to panelists and the house are: the setting of a recurrent phenotype of uveitis, what should be the timing of initiation of TNF-alpha inhibitors? With the possibility of systemic and visceral involvement in the form of granulomatous hepatitis or interstitial nephritis, is screening recommended for patients? Are there any known differential etiologies for classical boggy synovitis as we saw in this patient? And has there been any notice of a of an association of Blau syndrome and Crohn's disease? And are there any avenues for screening guidelines or prospective research studies? Thank you.
Thank you. Very, very, presented in perfect timing. Thank you very much for that. Your questions are very relevant, but I think before that, Satish, would you just give a clinical summary, and then we'll go to the questions.
Sure. So before going to Blau syndrome, which is a rare disease, I think all the residents should know some basics about juvenile idiopathic arthritis. It's a diagnosis of exclusion. This child has presented 2 years with 6 joints. That's what he told: wrist, elbows, and knees. Okay, when somebody presents at 2 years, definitely it is not rheumatoid, it's not polyarticular JA. So you should not do rheumatoid factor for a 2 years old child who comes with arthritis. Second thing, again, HLA-B27, classically described in males more than 6 years of age, presenting with sacroiliitis or hip involvement with enthesitis. So that's the time you should do HLA-B27. You should not do this. And one of the differential you are given is acute rheumatic fever. Don't diagnose acute rheumatic fever in a 2 years old child. It is more than 5 years. We have very classical, large joint, excruciating, painful, usually happens 2 to 3 weeks after the sore throat. With the 1 dose of naproxen or aspirin, it resolves completely, no residual deformity. This is a classical rheumatic fever arthritis. So this child doesn't believe. So I don't put differential diagnosis of those things. The one thing is TB, you said, again 2 years, presenting with 3 joints. Morning we had a very big discussion. So TB goes down. When you have the classical boggy swelling, my first diagnosis, one and only diagnosis is it Blau syndrome? I will evaluate for that. I will do the eye checkup. Okay, we'll do sarcoidosis workup, calcium, phosphorus, hypercalcemia, ADA levels. We'll do all those things. If not coming positive, we have again whole exome sequencing. Otherwise, you go for the biopsy to show there is granulomas. If there is a skin lesion, do a skin biopsy to show it's granulomatous. Then you can start treatment. Okay, and Blau syndrome runs in the families. Recently, I have one child treated for, mother was treated for rheumatoid arthritis with severe deformities of the hand. with methotrexate and all. He brought the child with typical boggy swelling. So child has come as positive. Now we are doing the parental validation for the mother. Most probably mother also would have got Blau syndrome. Okay, yeah, thank you.
Yeah, I think Mahesh has an image published in Lancet or something which shows 3 generations came to his OPD with Blau syndrome, and you just look at the fingers of the people accompanying or ask them if they've had eye screening and eye checks done, or do it and see what is there. So now we go on to the other questions. I mean, Vignesh, do you want to take up all the ones with regard to the genetic testing?
Yeah, so first regarding manifestations of Blau syndrome, there is no doubt, I think we should screen for the systemic and visceral involvement. Liver and kidney involvement is very common in Blau syndrome. We should screen for that. Number 2, uveitis in Blau syndrome is rather serious. It is very, it has a poor prognosis compared to the uveitis what you see in juvenile idiopathic arthritis. And it is usually a pan-uveitis with predominant anterior segment involvement. So the therapy has to be a little more aggressive as compared to the routine just anterior uveitis which you see in juvenile idiopathic arthritis. Point number 3, the differential diagnosis for classic boggy synovitis. I think Dr. Satish has already highlighted. If you happen to do an ultrasound, you can see a florid tenosynovitis and not a prominent synovial swelling with effusion. You may get synovial proliferation, but the predominant involvement is in the tenosynovium actually. So that is one another point. In the radiology, you have missed one important finding actually. The short and the long second metacarpal. That is a classical deformity which you see in Blau syndrome actually. And number 4, the Blau syndrome and Crohn's disease association, it depends on where your mutation is. Can you go back to your mutation? So this exon 4 mutation, it is in the NOD binding domain, NBD domain. So the mutations in Blau syndrome, it is in the NOD or the NACHT domain. Whereas the mutations in your N-terminal, that predisposes to your Crohn's disease. It also depends upon where the mutation is and what downstream function it leads on to. Crohn's disease, people generally feel it is due to a loss of function, whereas this is due to a gain of function of NOD2 signaling.
Okay, now we'd like to ask the audience for any questions. There should be plenty, I would imagine, no?
What are the usual manifestations? Do they just come with some liver granulomas in the kidney, and are they mostly asymptomatic or do they have any symptoms?
Very good question. Vignesh.
We do their urine routine and ultrasound abdomen. So if there are granulomas, you can pick it in the routine ultrasound abdomen, or if they can develop interstitial nephritis and renal granulomas as well. So you can pick it up in the routine ultrasound abdomen. So we just do a routine ultrasound abdomen for screening. But yes, so we had a patient who progressed to end-stage renal disease because of the granulomatous interstitial nephritis due to Blau syndrome.
But the classical triad is a classical uveitis, dermatitis, and boggy arthritis. So that's a classical, campodactyly also.
In fact, I think in the very first slide he had mentioned that the child had a granular rash over the skin of which the biopsy was done. Actually, that rash itself should have highlighted you to this being Blau syndrome. That rash is very classic in accompaniment with this boggy swelling. And the other thing is lung involvement. I mean, I think one of the worst Blau syndrome patients I've seen as a child who came to me blind at the age of 13. She was operated in a famous eye hospital for bilateral uveitis without actually anti-inflammatory treatment being given to her in adequate amounts. And she became blind in both eyes. And she came because she was having dyspnea. And she had very significant pulmonary sarcoidosis, I mean, Blau-related lung disease, and following that she also developed kidney disease, after which we don't have follow-up because I have a feeling she's probably no more. Anyway, I think, yeah, Vignesh.
Since there is time, can you elaborate the differences between a classical sarcoid versus a Blau sarcoid?
As ma'am said, the lung involvement is frontline manifestation, but in Blau, although it may be severe, it's not the frontline manifestation. Boggy synovitis is again very classical of Blau syndrome, the age group, definitely. And the uveitis again, it may be more like lesser severe in sarcoidosis, while here it is more refractory pan-uveitis picture will be there. And the family history will be very, very prominent.
Yeah, so I can just summarize. You have summarized most of the points. So pulmonary involvement is very rare. The children don't come with hilar lymph node and ankle arthritis. That is not Blau syndrome. It is the boggy synovitis and your camptodactyly. So that is the classic manifestation. Number two, the histopathologist can give you a clue actually. The granulomas with a thick lymphocytic core, and there is a classical histopathological feature for Blau syndrome actually.
Exuberant granulomas.
The lymphocytic emperipolis in your multinucleated giant cell. So that is one another thing which the histopathology can give you a clue. Number three is the classical dysplasias of the carpal and the metacarpal bones, which happens in Blau syndrome.
Sir, sir, I have a doubt.
Yes.
Here, yeah, this side. Yeah.
Yeah.
How can we see that the BAL AFB positivity? So, why not TB? AFB is positivity. Yeah. In the summary slide, I think
it's only smear is positive. Culture is negative.
So, can we consider it to be as a TB or should not be considered?
Which one?
AFB positivity, sir.
It doesn't look like TB because only smear. So TB again we are talking in the morning. The bogey swelling is classical.
No, I got the
rash also again. TB doesn't cause rash in children and causing uveitis.
So this AFB positivity should we
I don't think you should take it significant. No. Yeah.
So actually, up to 4% of the smears will be false positive, and you know that by the culture is negative, because it's all dedicated labs, where you have mycobacteria in the system. So 4% will be positive.
Suma?
Dr. Amita has a comment. The other thing I just wanted to say was that the Blau joints are often asymptomatic. They are very large, they are there to see, but they are often asymptomatic.
So in this boy, it could be that he had TB because he had a recent contact, he had fever, he had cough, you had sputum AFP positive, you treated him with antitubercular treatment, he became well. His fever disappeared, his symptoms disappeared, that is why he didn't come to you for 4 years. So he could have, in addition, in children, tuberculosis, not uncommon. So before we say it's a lab, lab errors do happen, but in this patient, the constellation of symptoms and signs, what you have presented, seems that he had an tuberculosis which got resolved.
Yeah, he could have had both. Yes.
Can I have
yes.
Go ahead with your answer.
Dharmand, ask your question.
No, thank you. Great case, great discussion. And what adult physicians learn from this case? What would be pediatric rheumatologist's advice for us? In which kind of situations we should suspect an adult Blau?
Dharma, if the mother is having rheumatoid arthritis, if the child is having boggy swelling, think of reversing your diagnosis.
Closing comment.
Sir, in the treatment of Blau with, madam here, ma'am,
Yeah.
this side, right side, right side.
Okay.
Right side, right side.
Oh, there. Yes.
Yeah,
Hi.
Dr. Hari Krishnan.
Hari Krishnan, yes.
When you see a anterior uveitis with Blau syndrome, like do you give a trial of methotrexate and then go for a TNF inhibitor, or are there cases where you go straight, where you go upfront for a TNF inhibitor?
With such severe uveitis, you would have a very low threshold to go upfront for very aggressive treatment. However, they've not waited very long. They've done it in a month, just fine.
It is not related to the timing alone. It is severity and vision threatening. So you may use it upfront if it is vision threatening.
Definitely.
And if it is not, like suppose somebody has 6/18, then you try methotrexate, this, that. But if somebody has fingercounting to start with, MPS and why wait and waste patients?
And we would recommend subcutaneous methotrexate for these patients. Yes. Okay. Thank you very much. I think we had a good discussion. Thank you, Dr. Vishnu. Let's move to the third presenter, and that is Dr. K. Purnima, A Story of Two Tiny Hearts.
Good afternoon, everyone. Today I am going to narrate a story of two tiny hearts. So, our story started when a 33-year-old lady who conceived after 5 years of marriage So our story dates back to when. It's going.
Don't just keep pressing on this one button when you have to go next.
So a 33-year-old lady who conceived.
Don't go to the slideshow mode, you just go to the slide.
Okay. But sir, it won't get reflected.
I think, shall we call the last presenter while her presentation is getting sorted out, Dr. Sumana B. While we sort out her presentation, then Dr. Purnima can come last. So Dr. Sumana B is presenting a cryptic case of anemia.
Thank you, ma'am. A very good afternoon to one and all present here. Thank you for the opportunity. I'm Dr. Sumana from St. John's Medical College Hospital, Bangalore. So here we have a case of 16-year-old girl with no significant past history and normal development for her age, who presented to the Department of Pediatric Nephrology with the chief complaints of rash over legs since 1 month. It was in the form of red raised papules over both the legs. And she also had joint pain since 1 month, involving both knees and ankles, with early morning stiffness, however, with no history of any swelling. She also complains of 1 week history of facial puffiness and exertional breathlessness, which progressed over 1 week from MMRC grade 2 to grade 3. She also complains of decreased urine output and frothy urine. On examination, her vitals showed that she was tachypnic and tachycardic with a blood pressure of 180 over 100 mmHg. And she also had severe pallor, bilateral pitting pedal edema of both lower limbs, facial puffiness and palpable purpura on both legs. Musculoskeletal examination showed bilateral knee and ankles were tender and no swollen joints, and the rest of the systemic examination was normal. So with the possibility of severe anemia and renal failure, we kept our differentials as infection, malignancy, crescentic IgA nephropathy, juvenile ANCA vasculitis, and cryoglobulinic vasculitis. On further investigations, her hemoglobin was 2.5, peripheral smear showed normocytic hypochromic RBCs. Total counts was mildly elevated and with a normal platelet count. Her urea was 135 and she had an elevated serum creatinine of 4.48 milligram per deciliter. Her liver function test was normal. ESR and CRP, both the inflammatory markers were elevated, and her urine albumin showed albumin of 3+ and active urinary sediments in the form of RBCs and WBC and no casts. 24-hour urine protein quantification showed a proteinuria of 2.4 gram per 24 hours, and her cultures were negative, and her viral markers HIV, HBsAg and HCV were negative. Her radiological investigation showed a normal chest X-ray, and we went ahead with a skin biopsy, which was suggestive of small vessel vasculitis, and her renal biopsy was initially suggestive of chronic IgA nephropathy with severe IFTA around 75%. And her DIF was positive, mesangial positivity was there for IgG, IgA and C3. Her autoimmune workup showed a normal complement levels, DCT was negative, ANA was negative, immunoblot was negative, her ANCA by indirect immunofluorescence was negative. As the anemia was disproportionate to the CKD, further workup for anemia was done. Her peripheral smear I've already highlighted. Iron study showed a low transferrin saturation. Her stool for occult blood was negative. In view of iron deficiency anemia, PNH was considered, and the flow for PNH was negative, and TTG IgA was negative, and enteric scintigraphy showed no enteral occult blood loss. So she was diagnosed as a case of IgA nephropathy with subnephrotic range proteinuria and volume overload state, and she was in CKD stage 5. So in view of chronicity, no further immunosuppression was initiated, and she was initiated on thrice a week maintenance hemodialysis, and anemia correction was done with PRBC transfusion, adequate hematinic replacement and darbepoetin injections. So along the course of her history, there were a few red flag signs. Despite adequate treatment of anemia, she was having recurrent drop in hemoglobin requiring PRBC transfusions, and also during the hemodialysis sessions, she had recurrent episodes of breathlessness. 6 months into the illness, the child was seen as a rheumatology consult. She presented with fever and breathlessness since 10 days, and she was tachypnic, tachycardic with a room air saturation of 78%, and she was requiring ICU care with mechanical ventilation. Her ET aspirate was bloodstained, and BAL showed hemosiderin-laden macrophages. And her further imaging showed non-homogeneous opacities in bilateral mid and lower zone, and CT chest showed consolidations with the surrounding GGO. Adequate infective workup was done. All the cultures, BAL cultures, multiplex PCR was negative. We sent an MPO and PR3 ELISA, which showed high MPO titer positivity. So finally, she was diagnosed as a case of juvenile ANCA vasculitis, microscopic polyangiitis with diffuse alveolar hemorrhage with rapidly progressive renal failure. She was managed with IV methylprednisolone pulse followed by 1 mg per kg steroids. Because of the acute presentation, IVIG 2 gram per kg was given, and she was started on IV cyclophosphamide according to the US protocol. Her journey so far, at 6 months follow-up, she's in clinical remission with no further episodes of hemoptysis, and she's being continued on 3-weekly hemodialysis and is being planned for renal transplantation, and her hemoglobin is stable at 12. And her radiologically, X-ray showed significant improvement. So these are my questions. I wanted to know, her initial presentation, how common is IgA nephropathy presenting as a rapidly progressive renal failure? And is there any smoldering or chronic DH reported in juvenile ANCA vasculitis? And percentage of ANCA negative vasculitis, and importance for the methodology of ANCA testing, ELISA versus IIF, because initially her ANCA was negative. And importance of suspecting DAH in refractory anemia in a setting of RPRF. Thank you, ma'am.
Thank you, Dr. Sumana. Again, finished beautifully with time to spare. I think we should congratulate you for that. I think we'll start taking up the questions. I'll first ask Satish to give his views on the case.
So this is really a complicated case, and when you put a differential diagnosis, can you go to the slide? When some child comes with the vasculitic rash and the lower limbs with renal failure.
Yes, sir.
Okay, so we usually consider lupus, we consider ANCA-associated vasculitis. Cryoglobulinemic vasculitis is not common in children. I have not seen anybody with cryoglobulinemic vasculitis presenting like this. So another thing is HSP. Like typically when you present only the lower limbs you said.
Yes,
that's
sir.
another one. Again, IgA vasculitis. Okay. And the investigation is they're done very beautifully initially. Only that biopsy, renal biopsy.
Yes, sir.
Okay, that's, I think, that has got a full house, correct? He's got IgG.
Actually, because it was in an advanced stage of renal failure and they were sclerosed, so probably we couldn't get.
Was the IF done on skin also?
IF on the skin was not done at that.
Okay, so again it will say whether it will give a clue. Second thing, when somebody has got this amount of renal failure, 2.5 for a renal failure to go, hemoglobin is very low. You have done a lot of tests. Apart from CT chest, you have done enterographin to look for the loss, where it's going.
Yes, sir.
And whether the CT scan done during that time or PFT with the DLC or something is done during that time would have picked up that bleed. Then our diagnosis would have changed.
Yes, yes.
Another thing is anti-GBM disease. Again, which is rare in children, can present with the pulmonary renal syndrome.
Yes, sir.
That's another one point I want to make. The other thing is this biopsy. I know this patient was not receiving any treatment because they thought it is chronic renal failure.
Yes.
It's all gone case.
Yeah.
And again, the child came very sick after 6 months. I'm not sure why was no immunosuppression was initiated. Somebody has got full house on the renal biopsy. Whatever the cause, vasculitis. Definitely there is evidence of vasculitis with IF positivity. I'm not sure why there is no immunosuppression was initiated. Because they managed it like a chronic renal failure.
Yes, they managed it as a CKD. Yes, sir.
Okay, so these are my comments. And you asked about one question about why ANCA came as negative initially by IF and then MPO came by PR.
Yes, sir.
Correct. No, we know ANCA by IF has got very good sensitivity. LS has got very good specificity. And that depends on the person who is doing also.
Yes.
Okay. Yeah, thank you.
And today our recommendation actually is to do the ELISAs first. Instead of the this thing actually. Yeah. So I think, Vignesh, would you like to take up any of these questions?
I think Dr. Satish has covered most of the points, but I just like to mention here that both the diagnoses are not completely clear in this case. Both the diagnosis of IgA nephropathy as well as MPO positive vasculitis, because we have a full house in the renal biopsy. So in this situation, especially if you have immune complex mediated nephritis and diffuse alveolar hemorrhage, and if you have multiple autoantibody positivity, type 1 interferonopathies should also come in the differential.
Okay,
And the important type 1 interferonopathy which can present as pulmonary renal syndrome is COPA syndrome. Yeah, and also some forms of DNase defects.
That's true. Yes.
Kidney size, I think you not mentioned anywhere.
At the first presentation, it was normal sized.
So kidney size was normal. So it was rapidly progressive glomerular nephritis.
Yes, sir.
Right? So that time, what treatment was given to the patient for RPGN with such a creatinine?
Actually, immunosuppression was not initiated.
That's a big question.
Straight away, the patient should have got methylprednisolone and endoxan. I mean, if the child then you, but still, I mean, RPGN you have to save kidney, and you can't label somebody with normal size kidney as CRF.
Rheumatologists were not involved in that admission. That is the problem. Yes, Sapan.
So we had a good discussion, Dr. Manish Rathi from PGI Chandigarh, and he said that IgA nephropathy we are increasingly finding. In 2 patients of lupus, we found only IgA nephropathy, and we've actually shown that, presented that somewhere. And in the Rajasthan conference, he said that it's a range of manifestations. IgA nephropathy can range from microscopic hematuria to RPGN. So you can have those kind of manifestations. IgA nephropathy, nephrologists don't treat with very aggressive immunosuppression. That must be the reason. Although this was RP, they should have treated that because the duration was not very long. But that is why maybe they don't. But the MPO, I'm not sure. In lupus, we have at least 2 cases where we've seen IgA nephropathy. But with MPO, I'm not sure if there are any. But there must be reports. But that is happening. So it's a range of manifestation that IgA nephropathy can have.
I mean, you have IgA nephritis and IgA nephropathy, two separate terms to actually address this situation. So, I would call this IgA nephritis more than nephropathy, which means that you treat. That would be the difference there. Yes, Amita.
Ma'am, just the fact that she has got two pathologies, like one immune complex mediated nephritis in the kidney and diffuse cellular hemorrhages probably mediated by the anti-MPO. So usually in anti-MPO we expect post-immune glomerular nephritis. So much of immune complex deposition should not be there. So because she has got something like two pathologies, do you think like upfront, some genetic testing should have been done?
Ma'am, I want to say something. Madam, what has happened, like IgA nephropathy is basically seen in the younger age group. But now IgA nephropathy, 20% to 30% of develop CKD. So the adult nephrologists are changing their thought process in the management. So now what they are doing, because I'm involved in one of the ethics committees, so that's why I said, let me tell the people here, though it's not in the paper yet. So what these nephrologists are thinking, is all over India, nephrologists, they're thinking that the way we treat lupus nephritis, why not treat these young children so that they don't develop CKD? So they are using all over the world and in India, they're using etanercept, the new drug what we use for lupus, like something like belimumab. So that drug trial is going on.
Thank you, ma'am. Yes, Amita.
Yes. Three things in this patient. Yes. One, that this child looks to have IgA vasculitis rather than IgA nephropathy. The child is
because of the rash.
palpable purpura.
Yes.
The child presented with palpable purpura with renal failure. You won't diagnose as IgA nephropathy in this patient. IgA nephropathy is a very different cup of tea. There you don't see vasculitis. If you see across the world, the number of renal transplants, 20% of renal transplants are because of IgA nephropathy, predominantly seen in adults. They don't have vasculitis feature at all. Second thing in this child, somebody said about immunofluorescence versus ELISA. ELISA is first line only if you are using third generation ELISA for anti-PR3 antibodies. Unfortunately, most of our labs don't use that. If you are not using third generation ELISA, it's best to do both together. You should do both immunofluorescence and ELISA before you say the patient is negative.
Yes.
So in this child, it could have happened that the patient actually had ANCA vasculitis. The only odd thing for ANCA vasculitis in this child is that immunofluorescence report.
Yes, ma'am.
That's all.
That's the only
Nothing
thing.
else is against
Nothing
the
else. Right.
diagnosis of ANCA vasculitis. A chest X-ray can be perfectly normal and the patient can have extensive diffuse alveolar hemorrhage. The third point I want to ask Vignesh, I may be very naive in that doing COPA, I thought COPA syndrome has interstitial lung disease, not has diffuse How common is diffuse alveolar hemorrhage in COPA syndrome? Is it very common? Or
It is known, ma'am. It is reported.
Known.
Well reported, actually.
Okay.
Yeah.
Okay.
Excuse me.
And pulmonary hemorrhage in those patients.
Yeah,
yes, one more question.
About this MPO, ANCA and IgA associated nephropathy. I have two patients actually, and another one we recently saw in Max as well. So we have three patients of MPO associated, who had MPO associated vasculitis, and I never wanted to do a biopsy, but the nephrologist did a biopsy, and two of them came out to be IgA nephropathy. So three of MPO who have an IgA associated nephropathy, and then Sapan has two lupus patients. I mean, this is coming now very frequently, I suppose.
But I think in children we tend to see the vasculitic kind of presentation far more. And especially like Amita said, when the child already has a skin vasculitis, is very likely to have been something that could have partially at least responded to treatment at that stage. But immunosuppression, in retrospect, it looks like immunosuppression was indicated in the first presentation with the rapidly progressive renal failure. Yes. I think there's another question. Yes, please come on.
Most of techniques, what we screen for ANCA, it is like IgG. So can it be IgA related proteinase 3 antibodies related with?
I just want to slightly differ with most of the comments. I think we need to review the kidney biopsy again, because IgG and IgA both are 1+. So that can very well be happening with ANCA-associated vasculitis. So just IgA being 1+, we are labeling it as IgA nephropathy, but it might have been an ANCA vasculitis from the beginning, and MPO obviously
Yes.
can be negative by IF and can be positive by ELISA. So
Very true.
otherwise, most of the clinical picture is fitting into ANCA vasculitis from the beginning. The skin rash, the renal involvement, and the lung involvement.
I think, thank you very much. We had a very good discussion. We'll move to the final case now. Thank you very much, Dr. Sumana. Dr. Purnima will come now and present her patient.
Good afternoon, everyone. Today I am going to narrate a story of two tiny hearts. Our story started when a 33-year-old lady who conceived after 5 years of marriage through assisted reproductive technology, reason being tubal block, with a dichorionic diamniotic trend pregnancy, and her first 3 antenatal scans done at 6, 9, and 12 weeks were normal. Anomaly scan done on October 2023, that is at 20 weeks of gestation, showed fetal bradycardia of 105 beats per minute in twin A, and there was a prolongation of PR interval, and other features found were atrioventricular valvular regurgitation, cardiomegaly, and ascites, features suggesting an early hydrops in twin A, and their echogenic myocardium with poor contractility. However, the twin B has normal heart rate, normal PR interval, and there was no similar features. So here the twin A was affected with second degree heart block with probable myocarditis and LV dysfunction. And she was worked up for the causes of fetal bradycardia and myocarditis by the gynecologist, and where they have reasonably excluded fetal sepsis and chromosomal anomalies, fetal hypoxia, and maternal drug intake. The left out were conduction defects and structural heart disease. And there they found the answer with autoimmune workup showing Rho52 positivity, and hence referred to us for further management. So we have confirmed the Rho52 positivity. However, there was no features of connective tissue disease in the mother, and her Schirmer's was also negative. So it was immune mediated with Rho and La strong positivity. So now how to manage this case, where we had a precious twin pregnancy in the second trimester, of which twin A was affected with fetal bradycardia secondary to immune mediated heart block, and there was associated myocarditis with LV dysfunction, and twin B was normal with autoimmune etiology. So we have gone ahead and treated her with IV immunoglobulins and hydroxychloroquine along with dexamethasone 4 mg per day, and in view of high risk pregnancy, aspirin was also given with a careful fetal heart monitoring. And during this period, the twin A heart rate was between 100 to 140 beats per minute, and twin B was normal. We have planned another dose of IVIG 1 month later, and her follow-up scans done 2 weeks and 4 weeks later showed improvement in the heart rate to 136 beats per minute. However, there was prolonged PR interval and multiple intracardiac echogenic foci. And over the next 2 weeks, the PR interval is still prolonged. Heart rate was 140 beats per minute, and the ventricular function has also improved, and there was no evidence of hydrops. However, there was IUGR in both the fetus, and twin B remains unaffected in terms of the conduction block or bradycardia. Regarding the further management, as there was improvement in heart rate and LV function with immunosuppression, we decided to continue dexamethasone along with hydroxychloroquine. And 10 weeks later, that is at 35 weeks, 3 days of gestation, patient was in labor, and she has undergone emergency LSCS and delivered twins, one twin of 0.7 kg and twin B of 1.5 kg. And the postpartum ECG, there was no bradycardia, and 2D echo was done of both the twins, and there was no evidence of structural heart disease, and conduction was also normal. So coming to the discussion, Sjogren syndrome is associated with risk of neonatal lupus and congenital heart block, and the risk of this heart block varies between 0.2 to 2% in nulliparous women to 15 to 20% in pregnancies with previously affected fetus or a neonate. And complete congenital heart block is associated with a mortality of 20%. Coming to the management of anti-Rho and anti-La positive pregnancy, first, the risk of heart block is mainly between 16 to 18 weeks. So we have to screen the patients who are antibody positive from 16 to 18 weeks to 26 weeks. And if it was normal, even though there was a risk of postnatal involvement, postnatal ECG and echo at first month and 1 year of age. If the PR interval is prolonged, that is more than 2 standard deviation, the normal being around 120 milliseconds, and valvular regurgitation, recommendations were to repeat the fetal echo in 24 to 48 hours and assess the PR interval. If the PR interval is more than 150 milliseconds, to try dexamethasone 4 mg per day for 1 week and then review the echo again. If there is evidence of second degree block or alternating second degree and third degree AV block, we have to give the patient dexamethasone. And if there are signs of endocardial fibroelastosis, myocarditis, or congestive heart failure and or high drops, immunosuppression is recommended. Coming to the complete AV block, we have to see whether there are features of high drops or extranodal disease, and if there is evidence for severe high drops or extranodal disease, then comes the role of IVIG along with dexamethasone and to follow up the case with review echoes. So my key questions are, why the twin B was unaffected in this case, and how long to give dexamethasone if the patient had improvement, and whether there is any role of repeat IVIG dosing.
Again, congratulations on finishing beautifully in time and very nicely presented case. Now, with regard, there's something very special I want to announce about this case, and that is that we are all pediatric rheumatologists here. Pregnant women do not come to our clinics. So most of the time, it's our adult colleagues who manage these patients. So I'm actually going to ask the experts in the audience to give the expert answers. Before that, however, I'll request Satish to talk a little about neonatal lupus. We get the babies, yes.
Very short. So neonatal lupus itself, it's a misnomer. Nothing to do with lupus. It's because it's not the culprit is not the ANA, it is the Rho and La antibody. Sometimes U and RNP also can cross. Okay, so when we see a child as a pediatric rheumatologist, most of the time, as you said, heart block is less than 2%, 0.2 to 2%. Most of the times we see babies with a rash. That's the one which usually we come to us. Usually rash comes on 3rd week, 4th week when the child is exposed to sun. Sometimes we give some topical steroids, they settle. Rarely we have seen children presenting with thrombocytopenia and liver dysfunction, for which we are given steroids for 3 to 6 weeks and taper and stop. They do very well. We follow them. Whenever the patient comes to us first time, we do ECG, we do echo, we do the antibodies. And the antibodies will be positive because from the maternal antibodies. We repeat the antibodies after 6 months to 9 months, make sure the antibodies are gone. And we follow them every year for the growth and monitoring, because sometimes they can develop acquired microcephaly later. So we follow the head circumference. That's what pediatric rheumatologists do. If this child has, like this, your child, the first twin has got LV dysfunction. If the child is born with LV dysfunction, having failure, high drops, we will use steroids, we will give IVIG during that time. Otherwise, we don't do any treatment. Anything to add?
Yeah, I think you have covered most of the point. I'll just take point number 1 because why you have asked the question why twin B was unaffected. So there are fetal factors also that determine the development of neonatal lupus. There are HLA predisposition, metal microchimerism. So there are so many hypotheses and studies based on that. So that could be the reason why that not all babies who are exposed to anti-Rho and anti-La, they develop the neonatal lupus. I think rest we can open it for discussion.
Now, I would really like the experts in our audience to answer the rest of the questions. How long do you give dexamethasone, and role of repeat dosing of IVIG, and any other comments that... 10 weeks.
Since there is time, I think you can elaborate why dexamethasone instead of other steroids, why it is preferred here, and
Because
what is the
it's
role
a-
of what is the premise of giving IVIG and dexamethasone?
Because it is a fluorinated glucocorticoid which can't be metabolized by the placental enzyme and can reach the fetus. And
IVIG.
Role of immunoglobulin, the motive is to prevent the inflammation which is occurring in the cardiac myocardium, which is probably related to the antibodies. So we want to block the antibodies before they cause the inflammation in the myocardium.
One question here, ma'am. Okay, in this case, both of the twins are doing currently, they are doing good?
Yes, ma'am. Second twin has recently been discharged from the NICU.
The one option could have been like, if personally I was like treating this case, maybe we can go for fetal reduction of the first kid and allow the second kid could have a normal lifespan instead of putting the second kid also at the risk of dexamethasone unnecessarily. Isn't it that an option?
Like one doubt, like we had a doubt at that point at 20 weeks whether it will involve the other fetus also.
The transformation happens at 16 weeks to 20 weeks. Maybe an IVIG of 400 mg per kg body weight, that is what, once in 3 weeks is the usual protocol which we start. In that case, instead of having a 700 grams baby and a 1.5 kg baby, wouldn't it have been a better option?
Actually, that you raise a very important point. What is the effect on giving dexamethasone to the mother? How does it affect the baby?
See, let's say sometimes when you don't have a place to do fetal echocardiogram monitors, I heard sometimes you use empirically dexamethasone was given to the mother when they have become 16 weeks to 18 weeks, till you continue till 21 to 22 weeks. That's a time, crucial time when this antibody crosses. So the dexamethasone, if you give without the evidence of heart block, it will affect the child in a lot of ways. The mother will develop hypertension, mother will develop gestational diabetes, and the child's growth will be affected. And it can cause long-term complications in the developing fetus. So empirical, I don't think at this age we should not give empirical dexamethasone because I cannot do a fetal echocardiogram from 16 weeks to 22 weeks.
It can also affect the brain growth of the newborn baby. Yes, Dr. Dharmanand?
Yeah, I'm here. Great discussion. And as an adult physician, if a patient comes to us, this patient, as Kavita was telling, I would probably advise them to reduce the sick child. That might help the other child to grow normally without much medications. And recently we had a patient who came to us with complete heart block and signs of hydrops. So we reduced the baby and allowed the other pregnancy to continue. She had a full-term normal delivery and worked wonderfully. And I also agree with Satish that empirically we should not. And also monitoring for fetal heart block is very tricky. And it can flip in a week's time. So we need monitoring every week, and first degree to second degree, if there is a change, immediate institution of dexamethasone might prevent. Otherwise, our usual frequency of 2 to 3 weeks time, we will not be able to detect and do anything many times.
Dharma, you want to say something about the patch trial and HCQ in the subsequent pregnancy?
Hydroxychloroquine is routinely recommended for anybody who has SSA, SSB antibodies, because we know that presence of these antibodies will result in neonatal lupus in 2 to 3% of the people who have this antibody. And if they already have one, the risk is higher in the second pregnancy. So hydroxychloroquine ideally should be started pre-pregnancy, pre-conception, at least 2-3 months before, for it to be really effective. That's what I would suggest.
Yes, I think we'll close with this question. So
Ma'am, just for my knowledge, I want to know, is there any way of monitoring the fetal heart rate continuously?
Cardiotocograms, but that will involve having the
just
child
like we
admitted.
have this Holter where we can put this one 24 hours. Is there any way to, there should be some easy technological...
There is no easy technology. I mean, when in labor, they do cardiotocograms which do that.
So can we have a mobile device?
Wearable device, I'm not sure. Is somebody here familiar with something like that?
The patient can carry it with them and they can monitor it on their own and
devices.
report it to, and they can be transmitted to the physician.
Okay. Is there Okay. So I think while the last person is giving their question, Anjani will get ready
Hello,
for the
I'm Dr.
reporter's report.
Abhilasha. Sorry.
Yes, quickly.
Regarding that heart monitoring, ma'am, recently in ANR, one trial was published in which that stop block trial is there, where they are using at home, they are giving one devices where pregnant ladies are monitoring their heart rate by that ultrasound thing, and that sound is coming and that sound is recorded through some radiologist, and if there is abnormal sound is there, they are referring to echo. It's there in ANR. It just recently last month came. So in that trial, they showed that it's efficient. It's very efficient. That and the weekly echo monitoring is there. Lot of payment, a lot of money is there financially. Is not affordable for everybody for weekly monitoring. Regarding IVIG, there are retrospective studies with 20 patients. It's not showing IVIG is beneficial, and one multicentric study is also not showing IVIG is beneficial. But still, we are if there is fetal heart drops is there, then we are using that IVIG. But repeat dose, I don't think so.
Thank you very much. Now, Anjani.
Good afternoon, everyone. I thank the organizers for giving me this opportunity to be a part of the unique conference. All the 4 cases were beautifully depicted. They actually represent the varied spectrum of cases we see in pediatric rheumatology. So coming to the first case, which a child who presented with polyarthritis, rash, early onset myositis, mass, CNS calcifications, and some infection later on, which turned out to be C1q deficiency. So coming to the key point from this case is when to suspect monogenic SLE. All children who have SLE with onset less than 5 years of age, male child having SLE, children with SLE and frequent infections, child born to a consanguineously married couple, or children who have a family history of SLE, and on investigation if we see ANA positivity and normal complements dsDNA negativity, we need to suspect monogenic SLE. One important thing we need to see is if there's ongoing SLE activity in the presence of normal C3 and C4, estimating CH50 can help us in identifying these children with C1q deficiency. Coming to the management of C1q deficiency, apart from the immunosuppression we use for the autoimmune manifestations, there are some important things we need to manage in C1q deficiency children, that is putting them on antibiotic prophylaxis and vaccinating them with meningococcal, pneumococcal and H influenza vaccines. And the treatment in C1q deficiency is either FFP or BMT. Definitive treatment would be BMT, but we have very less literature with that. And coming to the calcifications which were present in this case, there is a possibility that a coexisting interferonopathy could also be here, which could explain these manifestations. Coming to the next case, which was a child who presented with arthritis and turned out to be Blau syndrome. So Blau syndrome is an autosomal dominantly inherited disease which has a classical triad of symmetrical polyarthritis, which is non-erosive and non-painful and sometimes asymptomatic, along with granulomatous dermatitis and severe uveitis. So the important point we need to note here, which was highlighted by Dr. Satish sir, is that children with arthritis are much different from adult with arthritis. We do not see rheumatoid factor positive arthritis in children, especially JIA. That is the least common one. And upfront, we do not work up with rheumatoid factor assay in these children. The other important question was the differential diagnosis for boggy swelling. In such a case, when we see boggy swelling, sarcoidosis followed by Blau would be the important differentials. The next pointer was how to differentiate the usual sarcoidosis from Blau syndrome. So if the pulmonary manifestations, hilar lymphadenopathy would not be present usually in the Blau syndrome. However, the boggy swellings are the predominant manifestations. Uveitis would be aggressive. Histopathological examination would give us some pointers towards the Blau syndrome. Also on X-ray, which Dr. Vignesh sir highlighted, that there would be dysplasia of the carpal and metacarpal bones in Blau syndrome, which could be a pointer, and we could go ahead and do genetics in such cases. The uveitis in Blau syndrome is usually pan-uveitis and is very severe, so aggressive management is needed upfront. When it is severe, associated with poor prognostic markers, as this case where there was some delay, there was already setting of complications in the form of cataract and synechiae. TNF blockers might be used upfront also, because it would be vision threatening in this case, because untreated Blaus can lead to complete vision loss. So the next question is whom to screen for Blau as asked by our adult counterparts. So any arthritis running in the family, if the mother is or the father is being treated with rheumatoid arthritis and the child comes to us with a boggy swelling, definitely we need to think about Blau and do a not to screening. Coming to the third case, which was a cryptic case of anemia, which turned out to be ANCA vasculitis. So the child presented with some vasculitic rash, renal involvement, and febrile illness. In such cases, the differentials would be SLE, ANCA vasculitis, with the rash, IgA vasculitis. And when the pulmonary renal syndrome sets in, anti-GBM should also be considered as a part of differential. However, we do not see much of cryoglobinic vasculitis in children. So the next important key point here was the presence of severe anemia. So in a child who has severe anemia where all the causes have been ruled out, and when there's a rapidly progressive RF, we also need to suspect DAH, especially in the setting of breathlessness and no overt pulmonary edema. So we have to see if the losses are happening from the lung. Coming to the testing guidelines, whether ELISA or immunofluorescence, the consensus statements which support internationally is that they advise us to use a high quality immunoassays first. But in our setting where we do not have much of third generation ELISA as suggested by Amita ma'am, the best way is to do a simultaneously immunofluorescence and ELISA together. As highlighted by Dr. Vignesh, even this case, we are not sure exactly whether it is only simple ANCA vasculitis or there's associated interferonopathy like COPA syndrome, because COPA also has settings for pulmonary hemorrhage in the presence of rheumatoid factor positivity. The last case was case of neonatal lupus erythematosus, I would say, which we don't see much often as pediatric rheumatologists, predominantly managed by our adult rheumatologists. But the take-home points are neonatal lupus erythematosus is a misnomer. It is because of the passively acquired autoimmunity with anti-Rho, anti-La, and sometimes UNRNP antibodies. So when we see children in the newborn period, the usual manifestations are they come with rash, which is classically on the face with a raccoon eye appearance. Some develop cytopenias, transaminitis. We treat them with IVIG and steroids in the setting of severe LV dysfunction. Coming to the antenatal treatment, we know that the risk of recurrence in if a previous child is affected is very high, that is up to 15 to 20%. So the mother should be started with HCQ pre-pregnancy itself. In the treatment for screening these children or the mothers with fetal echoes need to be done every weekly from 16 weeks onwards to at least 26 to 28 weeks, and immunomodulation can be done accordingly. To conclude, I would like to say that these cases represent a varied spectrum, and they affect all age groups from fetus to adolescent age group. And in children, when the diseases are evolving, we need to keep the differentials open. So like all our cases, the first case was initially TB, then turned out to be Blaus. SLE turned out to be C1Q. There's a possibility of associated interferonopathy in the third case too. So in children, when the onset is early, refractory to usual treatment, we need to think about monogenic causes, and they might need genetic evaluation. Thank you.
Anjani for very succinctly worded rapporteur. I think we will close this session and I will leave it to the organizer to make announcements pre-lunch.
Thank you, Dr. Suma and the team. Wonderfully managed the time and the discussion. Excellent learning. Now it's lunch break, but I need a lot of your promise that we maintain the time. 45 minutes slot we have for the lunch break. So in the 45 minutes we have to do three things. One is, the first thing is photo. Please assemble everyone to the center. Please. We'll have a lovely picture when you go home. A sweet memory for you all. And soon after the photo session, I request you to go for all the judges. Have a quick lunch for 10 minutes, then go to the post area for the judgment. So after that, have your lunch, all of you, and assemble in 45 minutes.
Cameramans, stand కూడా తీసేసేయండి అక్కడ నుంచి. ఇది కొంచెం ఇటాను ఇది అన్నబెట్టు అన్నబెట్టు
ఇది పైకి పెట్టు
వస్తుందా పై వస్తుంది
పైకి వస్తుందా
వైర్
పైకి వస్తే పైకి రా కరెక్ట్ కరెక్ట్ తీసుకో
అదే చెప్దాం అనుకున్నాను నేను మన కెమెరా మన ఫోటో
सर जहाँ बीच में जहाँ जा सर तो और तो अंदर आ जाइए सब लोग कैमरे में स्टैंड हटाओ बोलो ना आप लोगों को आओ क्या स्टैंड हट ఉందా తీసేసారు స్టాండ్స్ తీసేసేయండి అక్కడ నుంచి అక్కడ గ్యాప్ ఉంది చాలా మందికి కవర్ కండి అక్కడ सर ये यहाँ तक ही आएगा सर, यहाँ तक ही आएगा, इससे अंदर ही आना पड़ेगा, जैसे बाहर मत जाइए आप लोग। वहाँ पे गैप बहुत ज़्यादा है सर, पीछे भी गैप ज़्यादा है वहाँ पे। मैम आप अंदर आ जाए। और क्या है वहाँ पे? सर वहाँ पीछे और तो डोर के ऊपर जा सकते सर वहाँ पे। और इधर सर सर और तो अंदर आइए सर। सर और मैम आप अंदर आ जाइए। और वहाँ पे कुछ बैग्स है वहाँ पे और बेटी बैग लाड़ा మీరు
కెమెరా బ్యాగులు ఉన్నాయి
తీయమని చెప్పినా అది కెమెరా ఎందుకు చెప్పినా కదా ఆల్రెడీ ఫస్ట్ టైం మీకు చెప్పినా
బ్యాగ్ సైడ్ కి ఉన్నది అది
మళ్ళీ వాళ్ళు జరుగుతలేరు ఆడ
నిలబడవచ్చు మనిషి నిలబడవచ్చు బ్రదర్ మీకు తెలుస్తుంది నేను మనిషి వెనకాల నిలబడవచ్చు ఇష్ట అయిపోతుంది కదా తీసి ఎక్కడ పెట్టుకోవాలి ఇక్కడే పెట్టమంటే చెప్పు 2 నిమిషాలు ఇక్కడ పెట్టుకుంటే మేము ఫోటో యూజ్ చేస్తాం నా పర్సన్ మాది నీ కూడా స్టాండ్ పెట్టి
So which one is the one who's going to take one more? No, please go, everyone please go. Let him go. Madam, first me after.
Okay, yes. Yes, yes, yes. Yes. Thank you.
So again, I request all the faculty and senior people on your right side and the rest of the delegates on your left.
Poster viewing. Poster viewing.
I announce, yeah.
For how long, sir? Because the timing is.
Again, a reminder, posture judgment will happen for the next 45 minutes. You can have a quick lunch in 10 minutes and come to the posture area. We'll assemble back exactly at 2:30 p.m. Thank you.
First have some food and get some energy and then go and sleep.
डायलिसिस की जरूरत तो नहीं लगती अभी मेडिकल मेडिसिन की तो मैंने करना फोन भी ठीक है ना हाँ ठीक है ना मैं देख लूँगी हाँ बिल्कुल बढ़िया होगा आने को ताज़ी సార్ అక్కడ ఉన్నారు
సార్ మీరు లంచ్ ఇస్తాను
మేడం వాళ్ళు ఉన్నారు
మళ్ళీ
ఇక్కడ ప్లీజ్ ఒకటి అక్క అక్క
నాకు దించవా నాకు దించి
మంచిగా రాలేదు
ఓకే
కాదు అది రియల్మీ అయ్యో సార్ తీయండి తీయండి
नहीं मालूम है तो ड्राइवर उनका तो उधर को डाल दिया उसको मालूम है बट इसे इंस्ट्रूमेंटल फुल याद कर दूं सर तो इतना बड़ा हॉस्पिटल है ना उनको मालूम पता है 300 रुपए में था
प्रेगनेंसी चार्ट है वो हमारी वाइफ उधर के और क्या क्या वो लैब
Good afternoon, everyone. Attention, please. So we are going to start the post-lunch session. I can't see Dr. Mauli Taba here. I'm doing her job now. I think few of the doctors are in the poster viewing room. But I think in the interest of time, we will start the conference. Now I invite faculty for the next session, that is inflammatory myositis. I request Professor Ramnath Mishra sir to come onto the dais, and Dr. Vinita Shobha and Dr. Paul T. Anthony as panelists, and rapporteur Dr. Pooja Srivastava. What to say? Thank you.
Good afternoon. I see the hall half empty. or it is half full. It's such a pity that when we have done so much of hard work to bring to you, I can tell you that 1 out of 100 patients of rheumatoid arthritis, 1 out of 100 patients of rheumatoid arthritis is exciting. 1 out of 50 lupus patient is exciting, but 1 out of 10 myositis patient will make you really excited. And two technologies have somehow, for the younger trainees, I believe that. One is MRI and one is autoantibodies. That have, it is supposed to help you with your clinical diagnosis. And we saw that in the morning. A rheumatoid factor positive, an antibody to antihistone positive, that led to SLE thing. And what dreadful consequences. And with that, there are a combination of very powerful and targeted immunosuppressive therapy. And finally, our impatience. It is our impatience sometimes when you expect that things should be miracle, it is not happening. Don't take it lightly. After 4 doses of cyclophosphamide, people, the case that we saw, the course, the next level of treatment came in. Cyclophosphamide is well known to act after 12 months, the good response. And after 4 months, you change things. I would beg to you that these technologies are good, the drugs are good, but have some patience, and nothing is going to be dramatized. If the patient has, for a patient who had a relapsed polyarthritis to be given IVIG, is literally you are going too much overboard. Well, it has been a great learning experience, when to do, when not to do. Probably when not to do by a rheumatologist would be good for both the patients and the rheumatologist. Here we have the selection committee have chosen 4 cases of inflammatory myositis, and 3 are driven by antibodies. Anti-Me2, anti-NXP5, and anti-Jo1. These 3 have just come probably max 10 years or so. And they are also called a newer generation, the NXP5. So a lot of these information are still very limited. Their association is good for asking question in the DM exam. They are very good. What does a MDA5? You would have to tell it is rapidly progressive respiratory weakness. And all these, you know that these antibodies are based on line blot assays which are now freely available. They are still not the gold standard of assays. The gold standard of assays is immunoprecipitation, which is not available easily. So without going further, the way we have devised, like Amita said that we have devised our own way, not following the rules. So we divide that these cases, 2 of them will be taken by Benita and 2 of them by Anthony. And Pooja would, she is very good summarizer. And the summary has to have only 2 bullet points for the case, because I saw a summary, I was getting fed up. The summary cannot be a very extended, the rapporteur is not going to be given credit for a 5-minute monologue or what does that the end of the day you take? So, Pooja, if you be brief, you will be witty. So, can I call upon the first one, the mystery of the anti-Joe one? Can you introduce yourself? You are like my grandson.
Hello, good afternoon to one and all present here. I'm Dr. Vaibhav SB. I'm a DM resident at Bharati Vidyapit Medical College, Pune. I'll be presenting my case titled The Joan Mystery. We shall see why. As we all know, the Joan antibody is an anti-histidyl tRNA synthetase antibody, which is specific to the idiopathic inflammatory myositis, particularly the polymyositis and dermatomyositis spectrum of these. And the incidence of Joan antibodies is around 20 to 30% seen in the idiopathic inflammatory myopathies, and it is the most common, making it the most common myocyte-specific antibody. So here I'll be presenting the case of this idiopathic inflammatory myositis with Joan positivity, which was refractory to treatment. We had a 51-year-old male patient who presented to us with history of high-grade fever since 8 days, associated with bilateral thigh pain, and also he also complains of joint pains all over the body, of all the joint pains in the body associated with minimal swelling. History-wise, he gave history of receiving a COVID vaccine, which the first dose, which was 10 days prior to the presentation. On examination, we just found there was tenderness of the bilateral thighs, and there was no weakness per se, and also there was a small patch of right lower limb folliculitis. On investigations, the routine dengue, chikungunya and malarial parasites were negative, and the CBC showed a leukopenia, and the platelets were also on the lower side with elevated ESR of 98, and CRP was also elevated with uncontrolled sugars. There was hyperkalemia also noted for this patient. Thyroid workup, vitamin D3, B12 were all negative, and since cultures are also negative, a provisional diagnosis of myositis, either query post-viral or post-vaccination, was made, and he had high sugars, so he was treated conservatively with antibiotics, hydrated adequately, insulin was given, and for his pain, we had started on the NSAID naproxen. There was not much relief in the pain, but fever subsided. But due to this persistent pain, we just started him on a prednisolone of 0.5 mg per kg body weight, and for which he responded, and we tapered it accordingly, and he was discharged after a week. His next presentation was a month later, where he came to us with severe thigh and leg pain on stopping of the steroids, and he had developed proximal muscle weakness in the lower limbs bilaterally with a manual muscle testing score of 60 out of 80 with on and off fever, and this time he had now developed a maculopapular rash over the chest and back. Investigations done revealed ANA by IF was positive, which was showing cytoplasmic fine speckle type, and blot was only positive for anti-Joan antibody. His CBC done this time revealed a pancytopenia picture. We had also conducted nerve conduction for this patient, which showed axonal sensory polyneuropathy, but he was not willing for a biopsy or an MRI of his thighs. We also got a myositis profile, and which was also positive only for Joan antibody, and the rest of the antibodies were negative. As per the neurologist's advice, we got an acetylcholine receptor antibody, which was negative. This time, but he had no complaints of dyspnea, and his so this time we diagnosed him with polymyositis with this above investigations and clinical picture, and we started him on an IV methylprednisolone pulse for 5 days, after which he got complete relief of pain. So he took discharge, and he was discharged with 1 mg per kg body weight of oral prednisolone and mycophenolate mofetil. With this, his muscle pain disappeared with improvement of his MMT score from 60 out of 80 to 70 out of 80, And during the course of this illness, we had also investigated him for his X-ray, ECG, and 2D echo, which are all found to be normal. His smear was also done this time because of the pancytopenia, which also was normal. His third visit was another month later, and this time he presented to us with severe exertional dyspnea, pallor, and fever again, and his pancytopenia had worsened. Again, he refused for a bone marrow aspiration and biopsy this time. So we got a direct Coombs test, which was positive. Again, we were forced to treat him symptomatically, given him a blood. We have transfused him with PCV. His pain in the thighs and legs reduced, but the weakness had increased this time, despite of steroid therapy and mycophenolate mofetil. And his manual muscle testing score had dropped to 54 again, although he had no dysphagia. So we were forced to continue him on steroids and MMF. He was also counseled regarding IVIG and rituximab, but due to financial constraints, we couldn't. So he left against medical advice this time. And his next visit, which was the last visit, was 15 days later, which was an emergency visit. He came in the night with severe pain abdomen, fever, and he was hemodynamically unstable this time with hypotension. His CBC this time showed a total counts of 35,000, which had risen from the past report of around 2,000. With neutrophilic leukocytosis, ESR was again 94. To rule out sepsis, we got a procal, which was also elevated with CRP of 235. And CT abdomen was done due to his severe pain abdomen and hypotension, which was suggestive of a misty mesentery pattern, which indicates a mesenteric panniculitis with lymphadenopathy. His peripheral blood smear this time showed us blast cells, and so we then conducted a bone marrow examination, which was suggestive of an acute myeloid leukemia, the M4 subtype. Patient was planned for a chemotherapy and stem cell as per the hematologist advice, but he succumbed within the next 24 hours. So this was his CT. Here we can see that the pattern described typically as misty mesentery, and classically there was sparing of the blood vessels seen. They were not involved in this patient. And the bone marrow examination, which revealed more than 20% of blast cells, and both myeloblasts and monoblasts were seen, and the percentage of blasts were 54% in this patient's smear. So summarizing the history, 51-year-old male with the first visit, he only presented with fever, myalgia, arthralgia, lab showing leukopenia and raised inflammatory markers, diagnosed with viral myositis, managed with 0.5 mg per kg body weight of steroids, presented again a month later with increasing weakness and fever with a rash this time and only Jo1 positive. So we diagnosed him as polymyositis. We pulsed him with methylprednisolone and initiated him on oral steroids and mycophenolate mofetil, to which there was a response initially, but then he worsened again. So he came to us again after a month with dyspnea on exertion, pallor and fever. So this time our diagnosis, we were uncertain because of the worsening picture in spite of the treatment. And so we continued mycophenolate mofetil with steroid. And the fourth visit was the last one, where he was diagnosed with AML, where he succumbed. So the learning points here, we can see that there should always be a high index of suspicion for occult malignancies in case of refractory inflammatory myopathies. And the evidence of mesenteric panniculitis also, although rare, it points out towards multiple possibilities, particularly lymphomas, carcinoids, malignancies of the kidney, colon, prostate, melanoma, and line blood tests should be interpreted with caution and be correlated with ELISA tests to confirm. And as sir already mentioned, that RNA immunoprecipitation test is the gold standard, but it is not easily available for us. So in conclusion, this case serves as a poignant reminder of the intricate interplay between the autoimmune disease and malignancies. And a literature review of the association of Jo1 antibody with malignancy was conducted, and there has not been a single case of leukemia reported till date. Thank you.
Thank you. I will now ask Paul. You don't have any questions for us? All the questions were answered? Okay.
Yes, sir.
So, Paul, could you comment on this case? There were plenty of oddities for this patient, as you would have gone through the leukopenia in the first place, the absolute lack of response to any immunosuppressive therapy, though the malignancy that he came up with is not one of the recognized malignancies that is associated with myositis. They are usually the lungs, the breast, the cervix, or the stomach, or the colon. But I would ask Paul to tell us what is this relevance of the JO1, or JO1 has got nothing to do with it, as most of the autoantibodies in our clinical description has got nothing to do with it. It is just that they are there, and we have to learn to ignore, if not anything. I mean,
Thank you, sir. First thing is, my query is to start with, the patient had uncontrolled diabetes presenting with fever, arthritis, and myositis.
Yes, sir.
Relatively an acute presentation, following a vaccination also. So why would you think of inflammatory myositis as the first possibility? Could it be a possible bacterial infection?
Yes, sir. We did. The first impression was myositis secondary to a viral infection itself. We didn't straight off treat it as an inflammatory myositis. So we had only initiated the antibiotic therapy with hydration and management of sugars. When he presented with the rash the second time, we thought of in any inflammatory myositis with raised CPK levels as well.
And nowhere you have mentioned the differential count, and the peripheral smear was only done at the end.
Yes,
probably
sir.
In between, you should have probably.
Sir, when he
proceeded
developed
with
the pancytopenia, on the second visit, the smear did not reveal any blasts. So that was our query. On the last admission only, we got blasts in the smear.
Okay, and
there was neutrophilic leukocytosis in this third presentation. I mentioned it, sir. So it was.
But the initial three presentations, you have not mentioned how much the neutrophils and lymphocytes.
Yes, sir. The first presentation we did not, because we just thought it was a simple case of myositis, sir. Because he had an acute presentation with history of fever of just 5 to 6 days, and
probably that should have been evaluated a little bit earlier.
Yes, sir.
Before giving steroids, especially once you give steroids, many times difficult to
ascertain
the marrow response.
Yes,
and the marrow changes a lot. And regarding the JO1 antibody, there has been a Chinese study where they looked into the JO1 antibody, and they found at least 5% of cases had malignancy.
Yes, sir.
And even if you look into it, sometimes it may be a part of a malignancy, like in this particular case. And it was too much emphasis should not be given on the JO1 antibody,
yes,
as was done in this particular patient. I think that's.
Can I say something, sir? So, should we be calling it polymyositis is something which we need to discuss, and because this patient had some cutaneous findings and the JO1 antibody is positive, so probably polymyositis is not the right diagnosis to make in this patient, and one could have chosen either antisynthetase syndrome or dermatomyositis here. He didn't have, this patient didn't have classical cutaneous findings, and nor did the patient have classical findings in antisynthetase syndrome.
Yes, ma'am.
So I understand that there was a dilemma in your mind, but I think polymyositis is something, a diagnosis which probably we should not be considering in this case.
But is it can we consider it as a paraneoplastic manifestation of the AML itself, ma'am? Because clinically, patient had developed. Yeah, so that was the dilemma actually.
Yeah. Sir, JO1 usually, as ma'am said, always comes with dermatomyositis. We have the fever, arthritis, myositis, and ILD. That is a singularly rare disease, okay? And the AML is more common. So there is a saying, one swallow does not make a spring cometh. So that is the thing we have to remember. Do not channel your diagnosis with a particular lab value, because the disease does not read the ANA blot.
Sir.
Can I ask
Yes.
those who once are seated in the back to have any question? Is the Pandit are asking questions, and they are.
I think this is a
That is
time,
very
sir, you
casteist.
should ask questions.
Very casteist.
Encourage your own students to come up and ask questions. Dr. Ruby, please come.
So
Yes, Sapan. I mean,
You carry on.
you are.
So I was just saying that
Just
wisdom
to
in
encourage.
retrospect is easy. So it's the viral is okay, but I think the clue here was anemia. How often do you see? एक तो male है, more than 50 age है. How often do you see 5 grams hemoglobin in myositis? You don't see that. So unless
Yes,
there is macrophage activation which happens in MDA5 rarely, again
Yes.
that's a rare thing, not very common. So I think that's where you, 1 month later, first is fine, you keep viral if there is an epidemic or endemic going
Yes,
on in
sir.
that area. But second time when the hemoglobin was 5, in one of my cases of stills also, where the patient required PCV, I made
Yes,
the
sir.
same mistake.
Yes, sir.
I started steroids, 1 month के बाद उसका hemoglobin down गया, but the clue was that the patient required PCV. So
Right, sir.
if you have so much of anemia, I think you should look it up.
That's when we got it, sir, the bone marrow.
I had a
patient. was in
Amita,
the-
you can wait. Sonak is itching to ask.
Even if we take away the fact that the malignancy was diagnosed, which can explain any feature as a paraneoplastic one, Coombs positive pancytopenia, ferritin going up to almost 4,000, why would you not consider it as lupus, for example, after ruling out infection? It could have been sepsis, but why go to myositis as all just because CPK is elevated, which might happen in a case of SLE also.
Yes, sir.
Pancytopenia would favor that. Direct Coombs test comes out to be positive, only based on Jo1, which is the only thing we have.
The ANA, I mean, there was no nuclear pattern, sir, actually. You got a cytoplasmic fine speckled pattern.
Could happen in lupus, I mean.
Yes, sir. Overlap was also.
I'm not saying it will be dsDNA homogeneous always,
Yes,
but.
sir. Overlap was also considered, sir, but there was no response to steroid as well. So,
Now we know that it's neither lupus nor myositis. Amita, just one more. Can there is a one hand, one resident, one trainee ask question?
I think the presence of muscle pain without such a high CPK level was the first red flag in this case that it's not just pure myositis. Second was the pancytopenia, third was the neuropathy also. So the neurologist must have felt that there was some distal weakness also. So I don't think myositis does not even come close to explaining any of the symptoms of the patient.
yeah, there were certain hints like.
There were oddities, yes. Yes, Amita, that is perhaps the last one.
Yes, ma'am.
Number of red flags in this. The NCV, if you have neuropathy with myopathy, you must rule out malignancy.
Yes,
or you rule out vasculitis. These are the two things you always think of. I mean, we didn't think. Same way, severe anemia with leukopenia, we just kept putting it under the carpet. So
Right.
we all do it. I
Yes,
have done 100 mistakes. Not that I don't do mistakes. But it is just that we missed all the red flags. And we keep on giving immunosuppression.
Yes, ma'am.
What Dr. Mishra started with. Don't give immunosuppression. Look at the case. If a patient is not responding, go back to the file, see what are the red flags. Then you will come to a diagnosis.
Ma'am, the few hurdles were there were financial constraints and he was not willing for a biopsy as well as a bone marrow aspiration.
No. Even this patient had D
There
dimer and
there was
and
another
smear.
marker. The B12 level was very high. And hyperkalemia. That shows that there is increased
Yes, sir.
cell proliferation.
That is what, sir. The severe drop in HB, the raised potassium, the CT abdomen showing.
So there were plenty of clues.
Yes, sir. Retrospectively, we.
No,
So, so we will be, you and we will be careful.
Yes, sir.
Next time. That was Sundaram, was it? So Sundaram is not a trainee exactly. I mean, therefore his question was little. So we go over to the next if you are all satisfied. So the
thank
next
you.
one is Dr. Sri Harsha.
Yes, sir.
Yes, Dr. Harsha, is all yours for 8 minutes.
Good afternoon, one and all. I am Dr. Sriharsha from the Department of Rheumatology, KIMS Hospital, Secunderabad. Today, I am going to present a case of puzzling case of myopathy. This is about a 45-year-old farmer who presented with history of fever for 1 week, myalgias for 1 week without any localizing symptoms. He was evaluated by a physician elsewhere. His initial labs showed leukothrombocitopenia with a total leukocyte count of 3,200 and mild thrombocytopenia. Dengue serology and smear for malarial parasite were negative. He was treated symptomatically as a case of viral pyrexia. The fever improved, but the myalgias persisted. Now, after 1 month, he presented to this hospital, to the Department of General Medicine, with persistent myalgias and progressive muscle weakness for 4 weeks involving the proximal muscles more than the distal groups. He also complained of a periorbital swelling. There was no reported history of use of statins in the past, nor there were any symptoms suggestive of neck flexor involvement or laryngeal or pharyngeal musculature involvement. The physical examination showed a faint periorbital erythematous rash along with prominent periorbital edema. There was apparent muscle weakness involving the proximal group more than the distal groups, but in presence of severe muscle pains, it was not accurately ascertained. The initial evaluation in this hospital showed leukothrombocytopenia on the CBP, transaminitis with SGOT elevated more than the SGPT, low serum albumin, raised muscle enzymes with CPK over 11,000 and LDH over 700. The infective workup was again negative, though the inflammatory markers were raised. Treatment was started by the physician with hydroxychloroquine, IV methylprednisolone pulse dose for 5 days, with which the muscle weakness initially improved, only to worsen later. At this point of time, the rheumatology consultation was taken. And to summarize, we are dealing with a subacute onset disease process with myalgias, muscle weakness involving proximal more than distal muscle groups, periorbital rash, periorbital edema, a preceding viral prodrome in the form of an acute febrile illness, elevated muscle enzymes, hypoalbuminemia, with which we were thinking of post-viral myositis. But one thing was against the post-viral etiology, that was persisting leukothrombocytopenia, which was continuing even after conclusion of the febrile episode, extending into the second month of illness. So the initial evaluation from our side included ANA, which was negative, ANA blot was negative, serum complements were normal, EMG showed a myopathic pattern. As he was complaining of persisting muscle pains and weakness, EMG was ordered and it was showing a myopathic pattern. Though he complained of mild hoarseness of voice, the respiratory muscle involvement was not apparent, with his single breath count relatively preserved. So as a next step, human IVIG was given for 5 days, by the end of which the myositis panel returned as negative, and so were the tumor markers in view of antibody negativity. The muscle weakness continued to worsen. By this time, the proximal muscles were distal muscle walls were equally involved, as were the proximal group of muscles with progressive muscle swellings. The muscle enzymes continue to worsen, with SGOT and SGPT reaching more than 900 and 550. Hypoalbuminemia. Potassium started to raise. The CPK went up to 48,000. LDH was more than 2,000, though the creatinine was stable. By which time we are almost sure that we are dealing with a complication of severe muscle damage. And so we sent a urine sample for myoglobin, which was negative, and this was the second sample. As he started passing concentrated urine, forced alkaline diuresis was given with soda bicarb, IV hydration, and diuretics. A PET CT was ordered, which showed generalized but patchy uptake in all the skeletal muscle groups, girdle muscles, and also the neck muscles. It is to be noted that the facial muscles are also involved, explaining the periorbital edema. A muscle biopsy has been ordered. While we were waiting for the muscle biopsy report, he developed hoarseness of voice with breath equality. Local examination showed adductor weakness of the vocal cords. He was selectively intubated for airway protection, later became oligoric with acute tubular necrosis. By this time, CPK was raised more than 1 lakh, and the third sample for urine myoglobin was positive. By this time, the muscle biopsy returned, and it was showing extensive prominent muscle fiber necrosis without any inflammation or perifascicular atrophy. There are no regenerating muscle fibers seen, indicating that there was no time left for the muscle tissue to regenerate, suggesting that it could be an acute process because of drugs or toxins. The urine toxicology screen was negative. After the muscle biopsy report has come, we stopped the immunosuppression. Plasma exchange was given for 5 sessions with an intention to clear the myoglobin from the serum. Regular hemodialysis was done on alternate days. Tracheostomy was done in view of a prolonged intubated state. He was on ambient room air. The anti-HMG-CR antibody was also negative. From the oliguric phase, he went into the polyuric phase and then reached a steady volume of urine output later, after which the hemodialysis was stopped. After the tracheostomy was decannulated, he developed an aspiration pneumonia, and again a recannulation was done. By this time, muscle swellings have subsided, but there was significant muscle loss, and so he received regular limb and chest physiotherapy. He was transferred to a rehabilitative center. Later on, with the supportive care, adduction palsy of vocal cords improved, gradually changed from ride chew feeds and oral feeds. Over the next 2 months, he was progressively able to walk with support, and 2 months later, he was in normal shape. Review of the history, after the muscle biopsy report, we reviewed the history, and he admitted to having used unprotected pesticides, which were cypermethrin, a synthetic pyrethroid, and diaphantheron, a thiourea compound, without any personal protective gear. So the final diagnosis was necrotizing myopathy, toxic myopathy as the etiology, involving the appendicular, bulbar, and truncal musculature, complicated by rhabdomyolysis and acute tubular necrosis. So the key questions are, what are the clinical features differentiating immune-mediated necrotizing myopathy from toxic myopathy? Second question is, how do we evaluate inflammatory myositis which is automatically negative? And the third one, could it still have been a necrotizing myopathy with a post-viral etiology? Thank you, sir.
Thank God it was MSN negative. And it would be kind to God that he improved, because these patients genuinely, if they are immune mediated, they don't respond very well. So Paul, are you ready to answer his questions?
I think the timeline of the onset of symptoms probably suggests that it's unlikely to be a toxic myopathy. Toxic myopathy is relatively more acute. I think here in this particular patient it was subacute. But you didn't mention about the alcohol intake, whether he was regularly consuming alcohol or
it was a
the
teetotaler.
toxins. What about the endocrine evaluation, thyroid functions?
Thyroid function was normal, sir. Because of myopathy, we have asked for TSH, which was normal.
Because they say that in rhabdomyolysis, usually immune-mediated necrotic myositis is not very common to cause rhabdomyolysis. I mean, it's not absolute, but relatively less likely to rule out other causes like antidepressants and all those drugs. And the other query is, why did you initiate hydroxychloroquine when the patient was having active myositis? You didn't have any antibodies, so...
No, that was before the reports came back. With the suspicion of dermatomyositis, we started hydroxychloroquine.
It was before the patients came. And they are not here to answer that.
And again, what was the evidence for dermatomyositis? The patient had subcutaneous edema, which could be explained because of the hypoalbuminemia.
Dermatomyositis was low on the cards, sir, because the pains were more prominent than, pains and swellings were more prominent than the weakness.
And regarding your MSA negative inflammatory myositis, I think at least 40% for the time being are MSA negative. Probably we need to discover the antibodies. I think some of the epitopes are still missing from some of the known antibodies also. And again, the method of testing, as was already discussed, we don't have a good method of testing. We have the worst method of testing at the moment. So I think that may change later on.
Sir, can I make a quick comment as a treating physician? We had a very stormy course. 3 months he was in ICU. And the reason why he was saved is because of Professor Amita. Because when we were in ACR in 2022, Philadelphia, I discussed the case with her. Because we were losing the case. I didn't know what to do. Because if you look at the history, it started as viral, viral illness and cytopenias. But the behavior was quite odd. At the end, it's a multi-system involvement. And what is it? The CPK went up to 1 lakh. And it was a confusing picture. Is it viral or dermatomyositis? Because he had rash. He had myositis, muscle weakness, but both distal and proximal. We couldn't fit anything else. So, like what he said, Professor Mishra, immunomodulation, we tried to, but when to stop? I'm glad, we didn't give rituximab in this case. So, because, in viral also, the Solimadol would work. So we give initially, Solimadol didn't work. Then what to do? We didn't want to lose the patient. Then we tried IVIG. Then at that point of time, as in ACR, I spoke to madam. Madam said, I told her it's 1 lakh. She said, don't do anything. Don't do anything. Whatever you do, patient is lucky, survive, otherwise, pray the God. Immediately, from Philadelphia, I called my team, stop everything. That's what we did. Just supportive care. And thanks to our ICU team, so good. They managed so well. Because he was in ICU for 3 months, managing our case in ICU, that itself is a big risk for sepsis. Now he is off medication, he's a farmer back to work. So I think, good. Sir, when you started, you said when to do, when not to do. This case told us, that kind of teaching we had, and luckily patient completely recovered off medication, doing well.
Thank you, Sarath. There is...
No treatment to plasma exchange or to dialysis, which removed.
No, it's also he responded to supportive care.
By God's grace.
Only supportive care. No. We gave good supportive care. Only. Always believe that body may try to put into homeostatic stage. Then body will take care. So that's what we did. We didn't do over. We could do whatever, and beyond that was don't do anything. Then slowly with supportive care, he improved.
You wanted to ask a question?
Yes, sir.
Can you identify yourself?
Sir, I'm Dr. Akash, final year DM from PGI. I had 3 specific questions. One is how do you explain the leukothrombocytopenia? Second, was there any history of use of statins in the past? And third, what was the rationale behind giving IVIG? Because even if you quote the PRODUM trial, if you read between the lines, it's they have actually excluded patients of necrotizing myositis, polymyositis, and a few other things. So I just wanted to know what was the thought process. Thank you.
Can you ask your first question? Because if you ask 3 questions,
Sir, cause of
he
leukothrombus.
told your answer to the second question is negative because he told that there is no history of statin.
Okay, sir.
And
how do you explain the leukothrombocytopenia?
Thrombocytopenia. And why did you give what you said?
IVIG, sir.
IVIG.
Thinking necrotizing myositis, because that was excluded from the trial.
I was about to ask, sir, that was my last question. Could it still be necrotizing myopathy with a post-viral etiology? Because there are some case reports where IVH has been tried in severe necrotizing myopathy secondary to a post-viral etiology. It doesn't have enough evidence.
So I feel that this was viral myositis, and that is why whatever we did didn't work, and it was just the supportive measures which actually sealed him through this patient. There is one study going on for IVIG in myositis. It's called Time is Muscle. And in that, they're trying to give upfront steroids plus IVIG, and the other arm is getting only steroids without IVIG. That study is going on, and we'll know maybe in next couple of years whether we should change from giving steroids upfront, or would there be a chance that we could switch to IVIG upfront along with steroids, and that might probably also help to bring down the burden of steroids. So before this study was planned, they've said that there is a data of some 10 patients in Netherlands, which was called as an immediate study, in which they used predominantly IVIG and they showed good response. So based on that, I think this current clinical trial is being planned. So I think there is enough, even if it is immune-mediated necrotizing myopathy, patient was not responding to steroids. So I think that was a good choice to make.
I also believe that probably it's all viral, retrospectively speaking. We thought of pesticide, but I think still, first possibility viral, I do agree. Recently, I had another patient, where the patient present with like viral etiology, myositis, severe muscle weakness, and interestingly, GB syndrome simultaneously. But slowly, patient recovered. And recently I discussed with Professor Lisa. She also started coming across these kind of patients. Initial viral episode followed by severe myositis.
So this case appears to be clearly a case of rhabdomyolysis. Yes. I think one clue is like CPK. So yes. CPK, if it is rising more than 30,000, so it indicates rhabdomyolysis, because in myositis you don't get so much high CPK. Yes. So there is one feature which suggests of rhabdomyolysis, maybe due to post-viral.
Yeah.
I just wanted to add on to what Vinita ma'am was saying, that even in IMNM, even the SRP subset, there is some evidence to suggest that addition of monthly IVIG for first 2 to 3 months may improve outcomes. So there is evidence, although low quality, but even in IMNM, SRP positive, that IVIG may be beneficial.
Yeah, I saw one of the differential diagnoses you considered initially was a dermatomyositis. Yes. So at least we are in a tertiary care institute. The one investigation which we found it very helpful is a nail fold capillaroscopy, because in dermatomyositis you always see the capillary dropouts, and even this can be seen with a handheld capillaroscopy, which is much cheaper compared to a video capillaroscopy. Yes. So that is one investigation which would help you and which can clinch whether this is a dermatomyositis or it is myositis due to other. Yes.
I'm sure the resident or the trainee would know that the term immune-mediated necrotizing myositis is associated with two antibodies. One is the anti-HMG co-reductase, that is they did, and the second is antibody to SRP. They had not done the immunoblot at the beginning. SRP doesn't pick up immunofluorescence stain on ANA, so ANA would be negative. And some of them at least are triggered by statins. So this Siddharth answer was that some patients, they've tried IVIG in antibody to SRP associated immune-mediated necrotizing myositis, which prognosis is very grave. So, Sarath, thank you for not doing much for the patient. And I just wondered, everything was fine. Why did you have to do a PET CT? I mean, when the patient is having so much of obvious muscle necrosis and CPK in range of 1 lakh.
Yes, sir. Because and
you are trying to pick up a malignancy. Or because the ANA was negative, or okay, then someone tells us that we have to move to the next case. Thank you, thank you. Dr. Nidhi Ramesh Prabhu, where are you from?
I'm from Chennai, SRMC, sir, Sri Ramchandra Medical College.
Okay. So you know your time limit, 8 minutes.
Good afternoon, everyone. I'm Nidhi Ramesh Prabhu from Sri Ramchandra Medical College. This case is classical presentation of MI2 myositis with a non-classical prognosis. MI2 antibodies are seen in 15 to 20% dermatomyositis patients with predominant cutaneous features, good prognosis, mild muscle weakness, no lung involvement. A 61-year-old male, resident of Chennai with no comorbidities, presented with high-grade intermittent fever associated with chills for past 2.5 months, left lower limb pain and swelling for 2 months, progressive symmetrical proximal upper and lower limb weakness for 1 month. Initially presented to surgery department to rule out cellulitis, but later referred to rheumatology department in view of muscle weakness from medicine department. On examination, general examination normal except fever, 101 degree Fahrenheit, pulse rate 110 beats per minute, edema of leg up to mid-thigh, left more than right, systemic examination normal, except CNS muscle weakness, MMT-8 showing 82 by 150. Cutaneous features showed heliotrope rash, malar rash involving the nasolabial fold, hyperpigmentation, nail fold infarcts, ragged cuticles, shawl sign. Baseline investigation done showed complete blood count, renal function test normal, SGOT 145 units per liter, SGPT 189 units per liter, CPK 3206 units per liter, LDH 1500 units per liter. Myositis profile done showed Mi2 alpha 1 plus, Mi2 beta 3 plus. ANEIF nucleus speckle 3 plus 1:100, LIA NT-SSA borderline positive, APLA LAC borderline LAC positive. Fever workup done showed H1N1 positive. Doppler of bilateral lower limb done to rule out in view of swelling showed no evidence of thrombosis. The clinical course, patient was diagnosed as a case of dermatomyositis, age-appropriate screening for malignancy done, and methotrexate was started. But patient was diagnosed H1N1. Oseltamivir was started for 5 days, but on day 5, patient started complaining of abdominal pain, constipation, distension. CT abdomen done showed pseudo-obstruction secondary to fecal infection. Surgery opinion was taken and manual removal was done. Next day, patient started giving history of hemoptysis and breathlessness. This was evident with serial drop in hemoglobin and elevated LDH level. CT thorax and BAL done showed features suggestive of diffuse alveolar hemorrhage. Patient was started with pulse methylprednisolone. Hemoglobin started improving and no further episodes of hemoptysis. But day 3, patient had a sudden rise in BP along with breathlessness. So 2D echo done, baseline was normal. So there was a sudden drop in EF to 25% along with features suggestive of stress cardiomyopathy. Cardio opinion was obtained and failure management was done. Breathlessness started improving. But day 4, patient had new onset of dysphagia along with worsening of muscle enzymes. IVIG was started, but with this dysphagia, patient had aspirated and had to be intubated. Day 3 of IVIG, patient developed acute kidney injury. At this point of time, our differentials were IVIG-induced AKI, rhabdomyolysis, sepsis-induced AKI, thrombotic microangiopathy, probable CAPS. With elevated muscle enzyme, high-colored urine, urine myoglobin positive, diagnosis of rhabdomyolysis was made. With low platelets and low hemoglobin, peripheral smear was sent, schistocytes were more than 5%, plasmic score more than 4, TMA diagnosis was made. In the background of low platelets, LAC positive, AKI, possibility of probable CAPS was thought of. In the background of fever with elevated ferritin levels, borderline triglyceride elevation, mass was also thought. Patient was hydrated, dialyzed, appropriate antibiotics, antifungals were given. Nephro opinion was taken, IVIG renal adjusted dose was given, and remaining pulse methylprednisolone was continued. Platelets started improving, no schistocytes, urine output started improving, and efforts of swallowing were seen. But unfortunately, patient succumbed to sepsis. These are the imagings of MRI left thigh showing edema of adductor group of muscles, effusion of hip joint, BAL showing hemorrhagic fluid, and CT thorax showing round glass opacities, features suggestive of DAH. 2D echo showing apical ballooning and suggestive of stress cardiomyopathy and high-colored urine of rhabdomyolysis. These were the serial investigations with drop in hemoglobin, which was corresponding to the rise in LDH level. At this point, patient had developed diffuse alveolar hemorrhage. These were the rising trends of CPK and SGOT, SGPT levels, which corresponded to dysphagia, serial rise in creatinine levels. This table shows the evidence of sepsis with cultures showing Enterococcus faecium, Candida auris, Klebsiella. Mass workup showed ferritin levels of 38,370, triglycerides 183. This case emphasizes the rare association of Mi2 with dysphagia and mortality secondary to DH, TMA, rhabdomyolysis, and infection. Dysphagia is prominent manifestation in NT-SRP, NT-SAE, NXP2, TIF1 gamma, but rarely seen with Mi2. Mortality in MI2 alpha is rarely seen. Influenza-induced rhabdomyolysis is seen with higher total CPK levels, but few case reports are there with DM-induced rhabdomyolysis. TMA with dermatomyositis, polymyositis is refractory to treat, but higher number of cases are seen with influenza. DH is associated with anti-synthetase antibodies and anti-SRP, rarely seen with MI2 alpha. Influenza, DH is a known complication of influenza. Conclusion, MI2 antibodies positive myositis has unfavorable outcome, late referral, delay in the diagnosis, increased age, infections, dysphagia led to adverse prognosis. Key questions. Is MI2 myositis as benign as it seems? Was MI2 myositis itself a cause of these complications or the associated factors? Should myositis antibodies be strictly used as an aid to decide treatment plan? These are my references. Thank you. So this discussion part.
MI2 is a benign disease. I mean, they are classically associated with, I'm not sure what are the list of references for what. Or those are the references which say that Me2 is associated with an adverse outcome.
No, sir.
Vinita, you can answer these questions if you know.
So I think in this case, unfortunately, terminally he did not have as good luck probably as the earlier patient, and I would dissociate the clinical course into two components. One is that he had dermatomyositis, some of the classical cutaneous manifestations, and Me2 fits in very well. And probably he was hit by another infection, probably a viral infection, and then subsequently went on to develop polymicrobial sepsis, and majority of the complications, whatever you said, TMA, DH, were all part of the infection rather than part of the Me2 myositis itself. Me2 for long we believe that is associated with good prognosis, but there are data which is telling us that Me2 does not always have a good prognosis, and there are even reports of necrotizing myositis in patients with Me2. So I guess we have to titrate our immunosuppressive therapy with the degree of the severity of the manifestations rather than going by the autoantibodies. And, yeah.
So definitely the question, the answer to the myositis antibodies be strictly be used as an aid to decide treatment plan, the answer is definitely no. No antibodies as such can make you decide a treatment plan. You have to take the patient's overall organ involvement, the response to treatment, and I don't know the biological significance of antibody to Me2. The Me2 alpha you said is 1 plus positive. Now you have to read this between the lines. A 1 plus positive, the company itself tells is a borderline thing. It is the Me2 beta which was 3 plus, and it is a semi-quantitative test. It's based on the scanner reading. And I don't think except for the anti-Jo one, the other autoantibodies have been documented to have a pathological consequences. So, where true sense they are surrogate. It's just that association studies have shown that these antibodies, generally the patients behave this way. So, now it is open for questions. Sapan?
Yes. Yeah, MI2, though textbooks mention it as benign, at least in pediatric myositis, we see the muscle damage tends to be more compared to the skin disease. It is one type of dermatomyositis where we see the children going in wheelchairs for a longer period of time. But their skin disease is very benign. It's not like in TIF gamma and NXP2 where you see relapsing or persistent skin disease activity which is going on for a longer time.
Thank you, sir.
Yeah.
Yeah, I would echo the same thing actually. With I think here many of the problems you faced are because of late referral, delay in diagnosis, and obviously very severe disease at the same time. Uh, it's very tragic when you have. I feel at least when I see an MI2 patient whom I lose because of these reasons, because they come early, the likelihood of them actually completely improving and going to a monocyclic phase is higher than the other patients we see.
Influenza of Ma'am, actually, when he got referred to us, there was weakness, muscle weakness, and cutaneous findings were there. He was doing well with methotrexate, but day 6 or 7, he started having H1N1 was diagnosed. After that, everything started worsening. But after H1N1, he developed DH. After DH, he was improving, and there was obstruction also prior to that. After DH also, he developed one more thing, which was new onset of dysphagia. So the influenza-induced dysphagia, there are cases secondary to SRP and all antibodies, but per se influenza causing dysphagia cases are not there. In MI2, there are 60% reported cases almost of dysphagia involvement, ma'am. So from there was involvement, and then hematological component also came, and AKI also developed. So we don't know the cause of AKI, ma'am.
We have seen influenza-induced DH in
Yes,
normal
ma'am. There
children.
are a lot of cases of DH, and influenza-induced DH, TME also, and rhabdomyolysis also, ma'am.
No, the learning points here are the age-related problems, the acute onset of all the myositis-associated complications or manifestations like dysphagia, like one of the greatest poor prognostic factors in him. And then naturally the aspiration will follow. And DH also has a complication of infection, acute kidney injury. All that is 1 + 1 + 1 + 1 + 1 serial involvement. I thought all of you will ask a question about rituximab, why people have not given rituximab. There was never a chance for us to give rituximab in this patient. And I thought you'll ask about the dexamethasone also. I myself will tell. Dexamethasone, we had no other choice initially because he would not swallow, and before pulsing him, it was given initially. The history was very short in him. And it was a very rapid deterioration. We just couldn't do anything. The problem came with the thrombotic microangiopathy and the persistent low platelet count and the pancytopenia with an ANA, all these autoantibodies confusing the issue. But the LAC was positive as again, and so many things were there. Finally, we left it, we treated the sepsis, and he succumbed. That was the end of him. But it was terrible treating him, really. He was let me tell you, we see younger patients who develop dysphagia with manifestations, acute onset manifestations like this, with these clinical manifestations of dermatomyositis with dysphagia, who respond beautifully to IVIG. And maybe later on pulse therapy and rituximab also. This man had great willpower, but unfortunately he succumbed.
There are certain predictors for a poor outcome of a patient with myositis, inflammatory myositis, and it is worth recounting every time. Much like what a lupus nephritis, what are the predictors so that the physician can take stock of the situation by what are you dealing with. Elderly male, a pharyngeal muscle or a respiratory muscle weakness at presentation. That means the patient of myositis who is on a Ryle's tube. You can predict the patient would be having aspiration pneumonia, and the fourth is a fulminating course, and in cancer-associated myositis, dermatomyositis, there is a very aggressive skin lesions. The skin lesion initially seem to be responsible, but if there is widespread erythematous in a female, you be cautious. But if I were to say two things, which patient you can send it to your friend to manage is the myositis patient who have a pharyngeal muscle weakness or a respiratory muscle weakness. The prognosis in general, and of course, as someone pointed out, or delay in diagnosis is bad for any disease, that be it lupus or myositis. So if we have learnt enough, then we go over to the next. He is?
Considering the age and slightly atypical manifestation, the skin rash, we screen for malignancy also.
Right.
That's another pointer. For the pancytopenia, it's already discussed in the previous cases. I won't repeat it.
No question from that side? Ramesh? You're storing your energy for tomorrow. Okay then.
Thank you.
If that satisfies you, then we move on to the last presentation. Molly, you are happy?
Yes, sir, yes.
Yes. Anup C, a complex presentation of anti-NXP2 antibody positive inflammatory myositis. So we have heard of Jo1, we have heard of Me2 alpha, and now come to terms with antibody to NXP.
Thank you, sir. Good afternoon, everyone. I'm Dr. Anup, coming from Madras Medical College. I'm here presenting a complex presentation of anti-NXP2 antibody-positive inflammatory myositis with peripheral neuropathy. The patient was a 54-year-old female, presented with symmetrical progressive weakness of upper limb and lower limb for 45 days, with erythematous photosensitive skin rash for 1 month, followed by generalized edema for the past 7 days and difficulty in swallowing for 7 days, followed by breathing difficulty for 1 day. In the casualty, patient was pale, patient had generalized edema, there was malar rash, hyperpigmentation of the forehead. There was a heliotrope rash and Gottron sign, which are specific manifestations of dermatomyositis. Patient was tachypnic with single breath count of 8, with saturation of 90% on room air. She was febrile, with tachycardic, with blood pressure of 110/70. Patient had severe muscle weakness with upper limb and lower limb, more on the proximal as well as also distal muscle weakness was also present. There was neck muscle weakness also. The deep tendon reflexes were absent in the lower limb and depressed in the upper limb. The plantar was also absent. Cardiac examination was normal except for the tachycardia. Patient also had crepitations in the right infraaxillary area in respiratory examination. The baseline investigation showed a leukocytosis along with anemia and high ESR. SGOT was 172 international unit per liter, and creatinine kinase was 8,072 international unit per liter with LDH of 678 international unit per liter. Before coming to us, patient had a CT NUC done from outside, which showed an inflammatory collection of subcutaneous plain and inflammation of the digastric muscle. Patient also had a HRCT thorax done, which showed features of aspiration pneumonia. Because of the depressed reflexes and some distal muscle weakness, done NCS also, which showed sensory motor axonal neuropathy in both upper limb and lower limb. And needle EMG in deltoid showed myogenic pattern also. And the muscle MRI was done, which showed features suggestive of inflammatory myositis. And ANA HEP2 showed speckled 4+ positivity, and ANA profile showed Pro52 positivity, which is one of the myositis associated antibody. And myositis profile was done, which showed anti-NXP2 positivity, which could explain the severe myositis and typical cutaneous manifestation and also the edematous myositis. And it's also pointed towards an underlying malignancy. We've done PET-CT to rule out an underlying malignancy, which was normal. And echo was also normal. There was no monoclonal gammopathy. This is the image of muscle biopsy and nerve biopsy we've done. In the image B, we can see the regenerating muscle fibers, and in the C, there is focal muscle necrosis, you can see, which showed active myopathic pattern. And in the image A, you can see the perivesicular atrophy, and in the image D, you can see the perivascular infiltrates of lymphocytes in the endomysium, which very well suggests features of dermatomyositis. And patient also had a some features of neuropathic atrophy, which also having a clumping of nucleoli, but we couldn't confirm it with ATPase staining. And in the nerve biopsy, there is loss of nerve fibers along with few regenerating clusters were seen. Before coming to us, the patient was already started on oral steroid from outside. And the day 45, she was admitted with severe muscle weakness, bulbar weakness, and respiratory involvement, and features suggestive of aspiration pneumonitis. And patient was initially given supportive treatment with a mechanical ventilation and broad spectrum antibiotic. And patient was initially admitted in neurology. They were started with IV methylprednisolone pulse, 1 gram for 3 days. And even with the weakness were persisting, and then we have started on intravenous immunoglobulin 2 gram per kilogram over 5 days. Then the respiratory weakness improved with improvement of the respiratory infection, and we could wean of her from mechanical ventilator. Even in the 3rd month of the illness, the patient had persistent bulbar and limb weakness, and we have started on rituximab 1 gram 2 weeks apart. And there was slowly improvement in the bulbar weakness, and patient was able to walk with support in the 6th month of her illness. Then we continued her on MMF and oral steroid. And at the 1 year of the illness, patient was able to walk with support, and patient was continued on MMF and low dose steroids. Here we had a patient with dermatomyositis with neuropathy. The things we could see that it could be a malignancy, or there could be a connective tissue disorder overlap, or associated diseases like diabetes or critical illness neuropathy, which could explain his neuropathy. The previous, in the literature, in the previous studies, there was one study which showed the NCS abnormalities of 32% in myositis. But even in this, majority of these cases fall into these three baskets. These are the previously reported cases of neuropathy with myositis in literature. And the first case in 1983, which showed, they called it as neuromyositis and treated accordingly. Then the next, the most of the cases were dermatomyositis, and some cases had axonal neuropathy, some have demyelinating neuropathy, some have features of vasculitis also. Most of the cases had severe presentation, and some have responded to IVIG and cyclophosphamide. In some case report, they have tried to look for whether there is a common pathogenic mechanism in neuropathy as well as in myositis. And in VEGF staining and membrane attack complex staining was positive in both muscle and nerve in some cases. And interferon signature is one of the important thing in dermatomyositis. Now it has been postulated in immune-mediated neuropathy as well as in neuromuscular disorders in the recent years. Even this case, when we look retrospectively, it is easy to say that, but we had a patient with severely ill patient with a tug of war between a muscle and nerve from the diagnosis till the treatment. And our key questions were, how do we frequently see myositis and neuropathy co-occurring? Is it possible to have a common pathogenic mechanism, and does neuromyositis exist? And how to approach these patients with fulminant myositis, role of IVIG and rituximab? And how important is the malignancy screening in these patients presenting with inflammatory myositis and neuropathy? And what is the clinical significance of NXP2 antibodies in inflammatory myositis? Thank you. Thank you for the opportunity to present.
So I think we need to see this, the NCS findings in the context of the severe muscle disease. So here the muscle weakness was very severe, right?
Yes.
You said 16/80.
Yes.
So how accurate is the interpretation of nerve conduction studies in that situation is something which we should keep in mind. And you have rightly said that in such situations we have to rule out malignancy and we have to look at critical illness neuropathies. And The role of IVIG, I think we've already discussed in the cases of severe myositis. NXP2, the clinical significance, we all know that we have to, we search for calcinosis and we search for malignancy, which you people have already done. And the only thing is that your patient is doing very well right now at the end of 1 year, but in NXP2 positive patients, one has to be always on a watch out, because these people can have repeated recurrences of their illness. They can have ups and downs in their illness.
When neuropathy and myopathy go together, I think one new differential would be immune checkpoint inhibitors.
Yes.
So that is one thing we have to, a new thing. And I think primary eosinophilic disorders also can present with
Yes.
both neuropathy and myopathy together. Again, malignancy, as ma'am mentioned.
So the histology of the nerves were only demyelination.
There was loss of nerve fibers with regenerating fibers.
You gave IVIG on day 50. I mean, did you give initially also and then on day 50, or?
Sir, ma'am, the patient came at around day 45. Initially, it got,
Achha, the patient came to you late.
Late.
Yeah. Even right from a student days, if you go through the old, I don't know about the latest edition of Kelly, but Kelly itself will say, when you take up the chapter of idiopathic inflammatory myositis, they will say, when you do all the tests, at the end they will say, do the NCS, nerve conduction study. Now, the neuropathy can be very silent in patients with myositis, many a time. So many a time we never bother, unless a patient himself or herself complains of it, we never bother to ask for the NCS. It is mandatory. Only today all these antibodies, as sir said, all these antibodies have come. Those were the days when we never had any autoantibodies. So it's ideal to screen for neuropathy, and then of course all these complications can occur, but it can be part and parcel of a pre-existing or existing myopathy itself. And of course, IVIG is going to do wonderful things to the patient, and now we have rituximab. They are going to respond very well.
I have a small comment. So when you have a significant muscle edema, when the patient has generalized edema secondary to the myositis, subcutaneous edema, you can get a false positive neuropathic findings. That is what my neurologist had. When we had a discussion recently, one of my patients also had a slight neuropathic findings. So they call it a pseudo-neuropathic pattern. When there is so much of facial edema, subcutaneous edema, your nerve conduction study may not be accurate. Just one explanation.
Yes, Sapan.
I think there should be a biopsy also, the nerve biopsy.
Yes,
which
nerve
shows,
biopsy
that
was also.
Yeah. My question was, yeah, but madam, it was not the NCV alone. The biopsy also which showed. That's what I'm saying. My question was, where does methotrexate come in? Because we are discussing MMF and rituximab and IV gamma. I know this had a nerve involvement, so probably that's the reason why. But I think most of us have been using methotrexate as the first line steroid-sparing drug in patients with myositis. So any comments there?
Yes, Sanjay.
No, I was just wondering and requesting Vinita, if you can brief all the people here on the work that Mega Upin is doing at the Nizams on the correlation between the muscle pathology, because that will be relevant to all the cases, right from that viral myositis which got better to the second and even this one. So the correlation at the cell level by immunochemistry staining. Can you just brief us what the whole...
Sir, I don't remember all the details about it, but it's not my work. So, Dr. Megha Opin at NIMS Department of Pathology, she has been trying to correlate the autoantibodies, the clinical profile, and the muscle biopsy findings, including doing stainings for interferon using MXA2. And from what I understood from her paper is that there is, to some extent, in some subsets, there is a good correlation between the autoantibody findings and the histopathology, what we are finally getting. But in some patients, there is not a very good correlation. So I think this is still a work in progress, and I don't think we have seen end of the road yet. Our neuropathologist at NIMHANS says that the The treatment which these patients receive, especially in the context of steroids and other immunosuppressants, before the muscle biopsy is done, changes the lymphocytes and the other immune cells which infiltrate into the muscles. So she says that the prior treatment changes the histopathology to quite an extent, especially in the context of infiltration by various cells. With respect to methotrexate, you want to say something? Sir?
No, you said that methotrexate is usually used.
Yes, we still use methotrexate as a first line unless there is a very severe disease.
Let me tell you that in myositis, there has been no randomized controlled trial. It is how you speak loudly or I speak loudly. As a steroid sparing agent, everything can be given and no one can question you. Much like actually those drugs which have been tried in randomized controlled trial, both in lupus and in myositis, have not shown a great promise, like the drugs which were before this term came to come. I mean, steroid had never undergone a randomized controlled trial in myositis. I mean, except for Sanjeev. It is very difficult to get the ethics committee passed through any drug without steroid. They can say that you can use this drug, but you have to use the standard of care. So I think methotrexate, you're right, it's good. I mean, you start with mycophenolate, 3 months down the lane, the patient doesn't take it. I mean, he cannot afford it. I mean, we have to realize that we are dealing with not Sanjeev I'm inclined. I mean, you have to deal with. Oh, Dr. Vignesh?
Sir, at least in juvenile myositis, there is a randomized control trial between methotrexate and cyclosporin, and they have shown methotrexate as superior drug compared to.
Is there one?
Not non-inferior. Yeah.
It's a non-inferior.
Subcutaneous methotrexate. Yeah.
Because nerve is such an important specimen. So we have to ask them to take the feeding vessel also, along with the muscle. Just like how we do for polyarteritis nodosa, no? PAN.
Yes.
So that will show us, because basically this is a dermatomyositis, the case you presented. And immune histochemistry also might have helped.
Yes,
these are future learning points.
Last thing, this NXP2, another important thing is vasculitis, sir. They are associated with a lot of vasculitis.
That is why I said for that.
So regarding this methotrexate, nowadays in pediatric juvenile dermatomyositis, if they have MDA5 antibody positivity, because they have high association with the ILD, we usually start on mycophenolate as a first line, then methotrexate only in MDA5 dermatomyositis.
That is what you think.
So that's the literature says and the recommendation says, sir.
Sir, I just like to endorse what Dr. Sapan said, that at our place also we had been using methotrexate as the first line steroid sparing agent, and it works good, and lots of our patients, they remain in remission.
Yeah. So you don't have to use IVIG, plasma exchange?
Not commonly, no. Not even MMF.
We are discussing amongst ourselves that people have used IVIG and plasma exchange. Means they've given the IVIG, they're taken away by the plasma exchange. When your hands are up in the air, you just do anything. And there is a Chinese study which said that you can still do it. You give 300 milligram IVIG, the plasma exchange will take 200 mg away, and 100 mg is still there, and you give back 200 mg. So I mean, don't laugh, I mean, I'm serious about it. Okay, so 53 seconds. Kaushik, which question? Okay, so you want to say something? Oh, Pooja. No, you. No, Pooja, you can take 2 minutes, 3 minutes too. Sorry, Pooja.
Thank you, organizing committee, for providing me chance to summarize. I'll be brief as sir has advised. Yeah, funny also. So I think all four cases have shown us a good spectrum what to do and what not to do. The first one reiterates what we have been taught from the first year, and at entering into rheumatology, what we are taught that we are minority people. All our diseases are also minority. So it has to be diagnosis of exclusion. Before starting steroid or any immunosuppression, we should at least think 1, 2, 3, if we are missing something, could it be something else? That is the most important test we need to do. Could it be something else? Despite if like ANA is positive, what we had in first one was Jo1 positive, NXP2 positive. So diagnosis of exclusion is important, and if there are red flags like our first case had, a 51-year-old uncontrolled diabetic patient with myalgias, only lower limb weakness, a CPKs of around 340, that is just 1.5 times the upper limit of normal, and a typical weakness, and with steroids also developed more complications like anemia. So those were red flags, and it was ultimately succumbed. Probably that patient itself had a bad prognosis. So moving on to second patient, like in surgery we say, a good surgeon is one who knows when not to do surgery. Similarly, a good rheumatologist is one who knows when not to give immunosuppression. So that was our second case, which was a post-viral myositis, 45-year-old farmer who had some exposure to toxin, but the illness had went on in subacute fashion, so toxin myopathy was almost not there. Steroid and IVIG was given, which probably all of us will do, but by the time in I think 2-3 weeks we were with the investigations and the muscle biopsy, we was very sure that it is probably post-viral myositis, and the crux was the very good supportive care the ICU team did, and that led to the survival of patient. Our third case was the 61-year-old male patient with MI2 myositis. I think he was being managed very well. What tipped the balance was the flu, H1N1, that probably triggered macrophage activation, alveolar hemorrhage, and a macrophage activation kind of thing where ferritin shot up to 40,000 range. And then a patient developed secondary sepsis and succumb to it. So that also goes for all our illness. Most of our patients are immunosuppressed, and in our patients, if slightest of infection develop, we need to be very aggressive to treat the infections. Viruses, we have not been able to win over till date. So probably the patient and the complication was unfortunate. The fourth case, last one, where the NXP2 positive myositis lady, she has also been managed very well. The points we learned from this case, that a bit of subclinical myositis, a subclinical neuropathy can be present in patients with myositis. But we need to search for alternative causes if we are seeing a clinical neuropathy in patients with myositis. When we are doing muscle biopsy, we can ask our pathology colleagues to look into the vessels feeding the nerve to look if there is a vasculitic component which can be due to myositis itself, or other differentials could be a overlap connective tissue disease with myositis, a primary vasculitis, malignancy. We should always look for if there is an overt neuropathy in patients with myositis, and nowadays a history of treatment with immune checkpoint inhibitors or other toxins or other associated diseases like diabetes which can cause neuropathy. Thank you.
So I think we learned a lot more from the cases and also from you, Pooja. And the most important thing is, the other thing I missed out, the other thing I missed out is the prevalence of these disease. If you know that rheumatoid is 1 in 100 and SLE is 1 in say, 10,000, who can tell me what is the best prevalence of myositis? So the best is 9 in a lakh. I mean, those rheumatologists who survive on recognizing myositis. And you can, when you see a patient, I mean, these matters. Of course, we are going to talk on vasculitis, which, which is as rare as myositis. So if that is knowledge, then we wind up and be very, know some basic clinical medicine would help patient, not so much the serology. The serology is a support system for you. So, Molly, is that okay?
Yes, sir.
Sir, is it over? Concluding. Thank you. So we have a big problem now. Just recognize yourself. Are you there in the picture or not? Yeah. So if you all give permission, then we'll take another picture. Luckily, our president, Dr. Chandrashekar, he has got a very good camera, Samsung camera. We'll try again if you all permit. Do you all agree or not? Please, you have to cooperate because you don't want to miss the memorable photograph. Please come to the center again. Again, exercise.
బస్ కెమెరామెన్ స్టాండ్స్ మీ బ్యాగ్స్ మొత్తం తీసేయండి అక్కడ నుంచి. కెమెరాస్ స్టాండ్స్ బ్యాగ్స్ మొత్తం తీసేయండి అక్కడ నుంచి. ఐటీ ఒక ఫోటో పంపించాను కదా, అది ప్లే అది. హలో. दिस इज ये वाला लास्ट पिक्चर लास्ट ईयर का है. जैसे पोजीशन है वही पोजीशन में आप लोग आना चाहिए, तभी आपका पिक्चर आएगा. आप लोग फर्स्ट रो वाले बैठ जाइए. फर्स्ट रो सेकंड रो बैठ सकते हैं आप. प्रोजेक्टर आईटी. सर ये जो भी जितने भी खड़े ये सब नहीं आएगा सर. ये बॉर्डर के अंदर ही आना पड़ेगा, चेस के अंदर ही आना आप लोग. सर नहीं आएगा सर. ये सर यहाँ पे जो भी इधर नहीं आएगा सर, सिर्फ लास्ट चेयर तक ही आएगा, इधर नहीं आएगा.
When we talk, we always say,
అంటే ఎక్కడ రావాలి చెప్పు ఎక్కడ రావాలి సార్ ఇక్కడ సార్ ఈ సైడ్ ఉన్న వాళ్ళందరూ ఇటు పక్క రండి సార్ ఇటు పక్క రండి ఒక లైన్ మొత్తం వచ్చేసాను సార్ ఒక లైన్ కిందకి వచ్చేసాను సార్ మేడం రండి మేడం ప్లీజ్
Okay, sir.
Say knees. Not actual knees.
Yeah, now we'll go for a quick tea break. We'll assemble back in 10 minutes. So please be back in the auditorium at 4:20. Thank you.
Vikas Agarwal and John, Jacob, always get Ashish Matthew, and we have a wonderful repertoire. And I will invite Dr. Augustine Jose to present his first case.
Thank you, sir. Thank you, CRC, for the opportunity. Good evening, everyone. I would like to take you through a story of an unconventional low backache we encountered. So our patient was a 49-year-old man who was overweight. Otherwise, he was healthy with no significant family history. He came to us with low back and pain around the hips on both sides for a duration of 1 year. To start with, his symptoms were gradually progressive. There was a persistent feeling of painful restriction around his hips, especially in the mornings. But as it progressed, he started experiencing worsening of pain at night, and pain would worsen after activity, however, would improve with rest, and he had poor NSAID response. Now, if we look at the timeline of his workup and his symptomatology, he had onset of back pain around April 2021. Within 1 month, he had onset of left shoulder pain with limited abduction. And by November, there were fluctuation of symptoms, and by November, he sought medical attention. He was evaluated and treated as inflammatory arthritis outside. His rheumatoid factor, ACPA, HLA-B27 by flow cytometry were negative. His X-rays were normal. He was given methotrexate, hydroxychloroquine, and glucocorticoids, and he perceived around 20% improvement with this. By February 2022, he had admission with exacerbation and severe functional limitation due to the pain. By March 2022, he was evaluated for the first time by a rheumatologist who did HLA-B27 PCR, which was negative, and he also underwent an MRI. So I unfortunately could not get the film or the complete report of the MRI, so I could gather from the notes that the MRI was reported as right sacroiliitis with minimal hip effusion. There were also signal changes in the femoral head suggestive of infarct, and there was also a mention of possible bone marrow reconversion changes. So appropriately, he underwent a bone marrow aspiration and biopsy, which actually revealed grade 2 fibrosis of the marrow. Otherwise, there was no remarkable finding that could be gathered from the report. Yet, he was continued on sulfasalazine and NSAIDs due to unknown reasons, and by February 2022, he had severe pain and he was nearly bedbound, unable to move even a little bit. Probably out of desperation, he was started on tofacitinib and methylprednisolone, covering both spectrum of arthritis. And then he reached us by May 2022, and he was admitted, and he was already frustrated with all the workup that he had to go through. Just to clear the concepts, bone marrow reconversion is a physiological reversal of the normal process of maturation of a red marrow into a yellow marrow that happens over the progression of age. So this usually happens, we find this in MRI as a symmetric change with low signal intensities on T1 images. They are usually happening with hypoxic stress or stress to the bone marrow. Also, to add to this, we are very familiar with this table, which are the most common causes of myelofibrosis, and we can note that most of them are really malignant causes, and grade 2 fibrosis is really significant finding. So when we review the case, we have a middle-aged male with chronic, severe, and progressive low backache, and he had no typical inflammatory features. There was no peripheral joint involvement, there were no extraarticular manifestations of spondyloarthropathies, there were no radiculopathy symptoms, there was no bowel involvement or bladder involvement, and there were no neurological deficits. There was no fever, weight loss or cytopenia, no renal dysfunction, no smoking or alcohol use. On examination, he had no pallor, lymph node involvement or organomegaly. There were no skin rashes, nail changes, signs of uveitis, there was no peripheral synovitis, there was no sacroiliac joint tenderness specifically. However, he had mild diffuse tenderness over the spinous processes and the iliac crest. There was no other endothelial site involvement or dactylitis noted. His evaluation revealed a normal hemoglobin and a normal platelet count. WBC count similarly was normal. He had low albumin, his calcium was normal, ALP was slightly raised with a normal PTH, creat and renal function was normal. His CRP was 28.5 milligram per liter and ESR was 120 mm. And alarmingly, LDH without any liver involvement or any hemolysis, the LDH was 783. The X-ray pelvis and spine were within normal limits, chest X-ray was within normal limits. His peripheral blood smear was not contributory, however there were target cells that were noted. HB electrophoresis was within normal distribution, serum protein electrophoresis had no monoclonal proteins, tumor markers were within normal limits. So these were his X-rays which were not really contributory. We tried to get the bone marrow slides and review them. However, our pathologist was not happy with the slides. They were inadequate for opinion. So we went ahead and did MRI spine and pelvis again. However, while he was in hospital, after 1.5 years of illness, we noticed a serial drop in blood cell counts for the first time. So with great difficulty, we convinced him to undergo a bone marrow biopsy and aspiration. So these were his MRI images. No major changes on the T1 sequences. However, the T2 as well as the PDFS and TIRM sequences showing significant marrow edema and signal changes, which were involving the sacrum, the iliac bone, as well as the iliac crest, with some adjacent muscle edema. And if you note, the wipe sequences are not showing any major erosions within the sacroiliac joint. So we got the report of the bone marrow biopsy by then, so which showed B-cell precursor acute lymphoblastic leukemia with extensive myelonecrosis and WHO grade 3 fibrosis. So this is one review from Jimmer itself showing the prevalence of different causes of myelonecrosis, and out of this most 64% being malignant, and the non-malignant causes being TB with HIV and hemophagocytic syndrome, sickle cell anemia. So the outcome, he was a pH negative B-cell ALL with molecular markers negative. There was no CNS disease. He received induction and consolidation with MRC UKLL protocol. His MRD was declared negative. His remission was documented. CNS prophylaxis was given. So regarding the symptomatology, severe pain persisted again for another 2 months into the induction phase. He required opioid analgesics and NSAIDs continuously. There was gradual reduction in pain from month 3 to 6 post initiation of treatment. At 20 months post treatment, he was asymptomatic, and he is currently on regular follow-up and monitoring. So this case has been pretty straightforward right from the beginning. All of you must have been thinking about malignancy. So this is just a reminder of to investigate aggressively when we find odd points, and also to note or revise certain mimics of axial spondyloarthritis. So these are the key questions I would like to pose to my faculty. What are the common clinical and imaging mimickers of axial spondyloarthritis that we encounter commonly in your experience? What are the red flag signs you would look for in a patient with low backache and hip pain? What are the MRI findings that may suggest an alternate diagnosis in a case of suspected spondyloarthritis? And what are the musculoskeletal manifestations of hematological malignancies? Thank you.
Thank you for Dr. Jose for a very crisp presentation. And I'll hand over the mic to Dr. Vikas and Jacob Matthew for the answers.
Yeah, Ashish. Nice presentation. The only thing is that generally acute leukemia, they tend to come out very clearly within 3 to 6 months, untreated cases. So very odd point for this patient to have a manifestation after 15 months. So any explanation for that?
Not that I can think of.
Yeah, so I think that is for the audience, because he received glucocorticoids.
Yes, in between.
So they had actually suppressed the lymphoblastic proliferation. So do not use glucocorticoids early when you are not sure of the diagnosis. That is for sure. Clinically, there were a lot of pointers to suggest that patient is having underlying malignancy, because patient was not having a significant morning stiffness, not responding to non-steroidal anti-inflammatory drugs, and patient has got nocturnal worsening. Now, this is very important to understand that patients who tend to have out of proportion pain and nocturnal worsening, that too in the early part of the night, they tend to have, or they should be looked for possible underlying malignancy. That is one thing. You yourself has given a list of mimickers of axial spondyloarthropathy. So I think they are there. Besides this, I would like to point out to all the postgraduates here, please go and look for the normal variants of sacroiliac joint and the bone development, which can mimic like seronegative spondyloarthropathy or sacroiliitis. To name some of these manifestations which can mimic or pseudo-mimic like sacroiliitis is iliosacral complex. There are ossification centers in the sacral wings, which if they are very near to the SI joint, they can mimic like a sacroiliitis. Then there are paraglenoid sulci, bipartite iliac lines, and lumbosacral transitional vertebrae. Even sometimes spina bifida occulta can also be mistakenly labeled as spondyloarthropathy. So, and besides that, I think there are a lot of conditions that you have already mentioned here. And to add to this, I think everybody knows how to differentiate dish and the osteitis condensenza ileae. And sometimes even unilateral fracture, whether pathological or insufficiency fractures, can also falsely give rise to an impression that there may be a unilateral sacroiliitis. So I think clinically and imaging wise, these are the pointers which can be kept as a differential diagnosis of spondyloarthropathy. Your third question was? MRI findings which can suggest, yes, in this particular case, if you look at the MRI picture, can you show that slide actually, where you have shown the marrow reconversion? Marrow reconversion.
So this picture was not actually showing prominent changes of marrow reconversion. That was prominently in the head of the femur.
Can you go to the previous slides? I just wanted to show. Yeah, this one. So if I hope this is from the patient only?
No, sir. This is
okay. Because you can see a lot of patchy involvement of the marrow in the femoral head as well as in the shaft, which can suggest that there is a disease which is replacing the bone marrow. Right. This is very important pointer to suggest that there may be some underlying pathology which may not be suggestive of inflammatory arthritis. If you look at in children, if you look at the X-ray, then you can see metaphyseal lucent bands and periosteal reactions, which can give rise to some suggestion or some suspicion of underlying malignancy. In MRI, like I said, the bone marrow signal intensities are patchy and wavy. And then there could be periosteal reactions, and some of the lesions can be seen only in the bone away from the joints. So that can again suggest that possibly the marrow is involved and not the joint pathology is there. And if you happen to do the CT scan, then again you can confirm the findings more sensitively, what you tend to see on the X-ray, like cortical destruction or moth-eaten appearance or periosteal reactions. And maybe you can better visualize the lytic reactions, which might suggest that patient might be having some alternative diagnosis to your inflammatory arthritis. And the last question was? What are the musculoskeletal manifestations? Oh, then there is a huge list actually. If you clinically ask me arthralgia, arthritis, tenosynovitis, fibromyalgia like presentations, so all can be a clinical bone pains. They can all be manifestations of, and in muscles you can have muscle weakness also, which may not be corroborating. It is a generalized muscle weakness rather than anything else. Ashish, will you like to add something?
I think that is pretty much what I wanted to summarize. The only thing is, I had one question about why was PD used for T1?
So that was done as a routine protocol for the soft tissue enhancement for most of the
because
joints.
You did a SIJ centered
it was
imaging,
pelvis,
right?
hip, and SI joint all together.
Yeah,
so probably for the ligaments, they would have added the sequence.
And the other thing was, again, back to what Dr. Vikas was saying about the history.
Yes.
I think that's the most important thing. First, the age was around 46.
49, sir.
49. Then itself, I'm 50% out.
Yes, sir.
Then you have night pain, which is just night pain, right? Yeah. I mean, the mostly inflammatory pain is around 4, 5 early morning when a patient gets woken up.
Yes,
and of course, your back pain also is not really characteristic of an inflammatory thing. The other thing is we need to, when you read an MRI, I think what we need to understand is how a normal marrow should appear and how is the progression of the red-yellow marrow, that conversion. And of course, only then we can appreciate the reconversion bit. Right. And here the patchy bit is mostly a category 3 kind of a thing, which is you get a patchy. The other one, generally in SPA, what you get is homogeneous, which is just periarticular, and it has to be a homogeneous right across still with a clear border. Yes. I think that's very important. And of course, OCI dish, these are the most important ones generally we come across, which are often mistaken as AxSpA. And I think these things can coexist with AxSpA. So that's when it just takes it to the next level. And of course, one of the major thing what we need to understand while looking at the MRI is the anatomical variations of the SI joint itself can lead on to lesions like erosions and fat metaplasia. So those things you need to be wary of. Thanks.
Thank you, Dr. Jose. See, this case illustrates the difficulty a rheumatologist faces. And rheumatology is a dumping ground for the clinicians who meddle with, or whatever you call it, with the patients. What they know, they try. And when things are not going right, they send the patients to us. And we are at tremendous pressure to give a diagnosis and treat. And many a times we try to fit in the patient to our diagnosis rather than what the patient has. This is the probably common thread of all the patients, all the cases we have seen from the morning. So we fail to look at the odd points and we ignore the non-responsiveness to the conventional classic treatment. And we try to treat the patients with the diseases which we are familiar with. So that's a common mistake most of us are making. And this kind of the conferences which highlight these factors. And I'm also thankful for the presenters, because it requires a lot of guts to come and present their cases here, and to a lot of specialists who are there to criticize and find fault with what you have done, what you have not done. But we all do that, and don't worry about your mistakes you might have made. And you have done a good job. Thank you very much. And one more last point is, we should not forget pregnancy can cause bone marrow sacroiliac changes in the sacral changes, which can last for up to a year or more than a year. So if the woman had delivered in the recent past, and if they comes to you with back pain, even if the MRI is reported as sacroiliitis, think twice, thrice whether the patient fits into your diagnosis, classical features or not. Thank you. Thank you very much for the wonderful presentation. Then we will move on to the next presentation from Dr. Lakshmi Manikumari Rahulan. Her case is titled as When the King's Disease Broke the Patient's Back.
Thank you, sir. Good afternoon, everyone. I'm Dr. Lakshmi from SGPGI Lucknow. So today I'll be taking you all through a story of a young male who presented to us with chronic low backache. As we know, the prevalence of inflammatory low backache in adults is estimated to be around 5 to 6%. However, the prevalence of spondyloarthropathies is about 0.9 to 1.4%. But the prevalence is even lower in Asian population. So a significant number of patients have etiologies other than spondyloarthropathy spectrum of disorders as the cause for their inflammatory low backache. So coming to my case, so we have a 28-year-old gentleman who is a resident of Uttar Pradesh, and he is symptomatic since the age of 21 years. So in 2015, he started developing inflammatory low backache, which was often associated with alternating buttock pain, and he complains of an early morning stiffness of about 2 to 3 hours. And he says that it used to beautifully improve with NSAID intake. And sometimes, even without any treatment, his symptoms used to disappear. And it was episodic, and each episode used to last around 1 to 2 weeks, and he used to have 6 to 8 episodes per year. However, in 2018, he started developing inflammatory polyarthritis, which was again episodic, lasting for about 7 to 10 days, again 5 to 6 episodes per year. It used to also respond to NSAIDs whenever he used to take NSAIDs. Otherwise, it used to respond on its own. And on-demand NSAIDs and sulfasalazine was used to manage his symptoms for 3 years till 2021. And in 2021, he had a flare of both his axial as well as peripheral arthritis. And this time, he went and he started taking Ayurvedic medications. Till 2023, he used to be on Ayurvedic medication, and then he presented to us in our OPD. So when he presented to us, he had an initially intermittent arthritis, which has gradually evolved into a chronic debilitating polyarthritis, and he had lost the initial response to NSAID at this point of time. And prior to presentation, 1 month before, because he was doing well, he has stopped all his Ayurvedic medications also. So he had come to us in a flare of both axial and peripheral arthritis, and he was bedbound. He also had active bleeding PR and melena. He had severe anemia with a hemoglobin of 5.5 grams per deciliter and requiring multiple blood transfusions. And he also had an acute onset swelling of his right big toe with erythema of the overlying skin. However, he had no enthesitis, there was no history of any psoriasis or uveitis. He was not hypertensive, he was not diabetic. And there was no family history suggestive of spondyloarthropathy or psoriasis. On examination, the significant findings were he had pallor, he had a BMI of 21.6 kilogram per meter square, he had active arthritis involving multiple small as well as large joints, including both hips, and dactylitis involving multiple fingers and toes. There was an erythematous tender fluctuant swelling of the right foot proximal to the first metatarsophalangeal joint. He also had features of steroid excess in the form of striae over his axilla and abdomen, and he also had a buffalo hump. And he had hemorrhoids. Investigations showed anemia with a hemoglobin of 7.2 grams per deciliter. He had leukocytosis, thrombocytosis, and an elevated CRP and ferritin, all suggestive of a very high inflammatory state. He had a normal creatinine. In view of his anemia, we did an upper GI scopy, which was normal. He had an HLA-B27 done from outside, which was again negative. And his musculoskeletal ultrasound showed synovitis involving all the MTPs, both ankles, wrist, and knees had significant effusion also. So at this point, our differentials were seronegative spondyloarthropathy spectrum of disorders, psoriatic arthritis, and considering his severe anemia and melena, along with polyarticular presentation with axial features, we considered IBD-associated arthritis also. His imaging revealed, however, asymmetric sacroiliitis, and his X-ray of both hands showed erosions, and there was some radio-opaque soft tissue densities also. So we had gotten certain diagnostic clues which made us clinch the diagnosis in this young gentleman. So the patient said that his symptoms were often triggered by alcohol consumption and large protein meals. And we aspirated around 5 ml of chalky white fluid from the right foot soft tissue swelling. And on polarizing microscopy, there were needle-shaped negatively birefringent crystals. That is, when a red compensator is used, the crystals which were parallel to the beam appeared yellowish in color. And this is a characteristic appearance of monosodium urate crystals, which made the diagnosis of gout in this patient. And as we all know, during an acute flare of gout, uric acid levels may not be elevated owing to the high inflammatory state and elevated IL-6 levels, which has a uricosturic effect. But still, our patient had an elevated serum urate level of 10.9 milligram per deciliter. And the musculoskeletal ultrasound also showed double contour sign in both his MTPs, first MTPs, and there were hyperechoic aggregates in all his toes, suggestive of multiple tophi. So there was a diagnostic dilemma in this patient. So he definitely has gout. So are the axial symptoms also part of gout? If not, are we missing any coexisting spondyloarthropathy spectrum of disorder that requires a DMARD for its management? So we sought help of DECT. So DECT is an imaging technique where we use two X-ray tubes which are placed perpendicular to each other at different voltages, and these beams are aligned in such a way that this uric acid crystals, because of their particular crystalline nature, will cause less attenuation of the X-ray photons that are tracking through them. So they will, compared to the surrounding bone, which is rich in calcium, and the other soft tissues, they have a characteristic appearance which will help us distinguish these crystals from the rest of the surrounding area. So the crystals, as we can see in this picture, they appear as greenish aggregates. We can see there are uric acid crystal deposition in SI joints, predominantly in the juxta-articular areas. There is also on the spine, and both hips are also showing presence of urate crystals. So DECT has a sensitivity of 84 to 90% and specificity of 83 to 93% in detecting urate crystals. However, we should also keep in mind that there can be false positive results with DECT, especially when there is a very degenerative arthritis that has destroyed the joint, or it can be negative even in the early stages of gout. So we managed the patient starting with NSAIDs, then we started him on colchicine, and we started also allopurinol and slowly uptitrated the dose of allopurinol. So 1 month after initiating the therapy, his peripheral arthritis have completely improved, low backache improved by 90%, CRP became negative, and uric acid levels decreased to 7.6 milligram per DL. So SI joint, gout, and spine involvement is 14 to 17%, and this being the presenting manifestation is rarer. So there are reports of psoriasis and gout coexisting, and gout in psoriatic arthritis. The juxta-articular punched out erosions and overhanging edges are clue to clinching the diagnosis. So episodic axial symptoms should not always be labeled as SPA. Crystal arthropathies should be considered in such cases, and DECT is useful in confirming the diagnosis. So my queries to the expert panel are, I think the first question has already been answered, how to distinguish inflammatory lower backache, when should we suspect other diagnosis than spondyloarthropathy. My second question would be, how long should we give colchicine prophylaxis ideally, especially on the basis of recent evidence which say that if you start slow and increase gradually, we can maybe do away with colchicine. And considering the age of onset of 21 years, should we also go ahead and look at certain genetic analysis for the cause of hyperuricemia in this patient? Thank you.
Unique case with a very unusual presentation. And over to Dr. Ashish for answers for the questions.
Thank you, Dr. Lakshmi. That was a good presentation. I just want to reiterate a few points. One is about the incidence, or rather the prevalence of peripheral arthritis in Indian population in SPA is known to be higher than in Western population. We don't have much data out there, but we have 3 studies from Dr. Malviya's group in which it was around 60%. The second point is about the coexistence of SPA with gouty arthritis. Now, I was a little intrigued about why did you have to move out from the diagnosis of SPA and call this purely gouty arthritis? Or do you still think they can coexist in this particular patient?
Sir, we got...
Because you started off with a good inflammatory back pain, you showed everything, I was pretty much convinced. And then towards the end, you just blew it up. I mean,
Sir,
I'm just wondering why you had to...
Initially also, it was very unusual for the inflammatory low backache in this patient to resolve without any treatment. See, if it is spondyloarthropathy, it usually requires treatment. And gout is self-limiting. The inflammation, like, it will take care of itself, like, with various mechanisms of why gout is self-limiting. So probably that is why his inflammatory low backache to begin with also subsided after 1 to 2 weeks without any treatment. That is one point which is for gout in this patient. And his symptoms improved with urate lowering therapy and colchicine. We did not give him any steroids. We did not give him any disease-modifying agent. Of course, NSAID can cause relief in SPA spectrum disorders also, but considering his severe disease.
That's fine, thank you. The other question was about the X-ray. You showed that the patient had a unilateral sacroiliitis, right?
Asymmetric sacroiliitis, right, more than left.
Right, more than left, I was not so much convinced.
Yes.
Why didn't you go ahead with an MRI then?
So we initially planned of an MRI, but
because
then...
because the reason why I'm harping on that is AxSpA with gout is not rare. You yourself said it's close to about 20%.
Yes.
Right? So it's not a rare entity. In fact, if I were to quote our study, Dr. Sandhya had done a beautiful study way back in probably 2012, 13 or something, when we did a CT comparison of patients who had gout with those who had SI joint, AxSpA. And a couple of things which came up was the erosions are pretty larger in gouty patients. They are para-articular as opposed to peri-articular in SPA.
Yes.
Of course, they have overhanging edges. And the other thing which is more important was a multilobular base. So these are a few things which we found that we could compare. The other thing which generally presents as a unilateral sacroiliitis would be infectious in nature.
Yes.
So I think that has to be brought over here. And I think the last question about do we need to do some genetic analysis, probably because of the age of the patient.
Yes, sir.
I can't help but quote this here. The first publication, one of the first ones which I had done with Dr. Danda was way back in 2005 when we had published a series of few patients. We had called it Yogi because it's young onset gout in India. And there was quite a few patients. So that was just about 4 years data what we had. Don't really remember the number, but it was quite a high prevalence of young onset patients with gout. So in Indian population, I won't be surprised that we do have probably, just like rheumatoid or whatever, we probably have a early onset of gout as well.
Okay, sir. Thank you.
Just a message to the postgraduates. When you see a patient of back pain or inflammatory back pain, don't think of gout as the first possibility. Don't get this message from this case actually. This is a very rare case, and I think in last 25 years, I'm also listening to her for the first time here only. Though we are coming from SGPGI, but I was not aware of this case. And every time I teach, wherever I go, that if you have a back pain, please don't consider gout. Because this is a very out of context case and very rare case. That is one thing. But there were few pointers which could have suggested that this was not a clear-cut case of a seronegative spondyloarthropathy. That intermittent nature of the back pain, spontaneous resolution. Generally, gouty attacks, they last 1 week or 2 weeks at the best. Whereas if you have a flare of seronegative spondyloarthropathy and you have a sacroiliitis or inflammatory back pain, generally it takes few weeks to resolve. Even if at all, it has to resolve on its own. So that could be one thing which you can take home from here. She has asked another question, how long to give colchicine prophylaxis. So I'll quote a paper from 2001 published in American Journal of Medicine by the rheumatologist Waltman, and he has suggested that one should give at least for 15 to 18 months of colchicine prophylaxis. Now one should understand why we give colchicine prophylaxis when we are starting allopurinol. Because even if you have a serum urate level of 12, 13 or 14 for a long time, you may not get any gouty attack. Whenever there is a fluctuation in the level of serum urate levels, the crystals they get precipitated in the joint. So once you start allopurinol, so there is a sudden fall in the levels of serum urate levels, and which can cause precipitation of attacks. And you don't want patient to experience that inconvenience of getting an acute attack. So you need to continue for that. I think, but the recent guidelines had actually cut down to 6 months of colchicine prophylaxis, though I still follow whenever I see a case more than a year of colchicine prophylaxis.
But sir, there was this paper which came in NEGM last year. In that, they have done an RCT with 200 patients in whom one group received placebo and the other group received colchicine along with allopurinol. And it is shown that those who received colchicine had a lesser number of flare at the end of 6 months. But after stopping colchicine, the flare rate became similar. That means once we stop colchicine after 6 months, there is a rebound flare. So should we give it for a longer time?
Yeah, that's what
Yes.
sir was trying to tell.
Yes.
And some patients, depending upon the uric acid load, if you have lot of tophi in the body, it takes longer time. As long as tophi is there, I continue. I have had patients on colchicine for 2 years, 3 years. As long as tophis disappear, I would not stop colchicine. And we know that colchicine is cardioprotective now. There is a brand of colchicine is approved for ischemic heart disease prophylaxis. So it's a reasonably safe drug. And of course, keep a watch for muscle disease and neuropathy, etc. If somebody puny and taking it for a long time. Otherwise, I think this is a rare patient. When the things are not fitting into our diagnosis and the patient is not responding to our conventional treatment with your diagnosis, always take a pause and try to revise the diagnosis, and you will always be right. Thank you very much.
Thank you, sir. Thank you, CRC, for the opportunity. Thank you.
That's one of the reasons. Thanks for reminding. I'd forgotten that.
Sir,
I was just wondering, why didn't you do a scopy?
Sir, the upper GI scopy, both the scopies were planned, but he was bedbound. He was not in a state to undergo colonoscopy, and he denied. Upper GI scopy was normal. Fecal calprotectin was normal. We have done it. And since he improved dramatically after urate lowering therapy, we did not go further.
And good question. And if you are suspecting IBD, if fecal calprotectin is normal, then probably you could conveniently rule that out. Is any other comments? Sorry, I forgot about the audience. I'm in a hurry to go to catch the flight. So I was trying to finish the meeting early. So anybody has an urgent point to add? Yes, sir.
Really necessary to demonstrate crystals when you have found ultrasound?
Sir, this was for the academic purpose. We usually don't see the crystals, so we had got a fluid from the tophi, so we ourselves, me and my colleague, went to pathology and saw it, and we got the images.
Sir, that's good learning experience, but with recent criteria, it's not.
Yes, it is not necessary.
But if you have a joint which can be aspirated, and I think we should strive to get our diagnosis double right.
Yes, sir.
Double contour may not be enough all the time, and not all radiologists are capable of picking it up.
Yeah, in your investigations, you have showed ferritin levels were very high, more than 1,000, I think. So is there any correlation between the high ferritin in gout? Like sometimes we can see in hemochromatosis patients.
Sir, actually, we attributed it to the very high inflammatory state that the patient was having. He had other features like leukocytosis and thrombocytosis also. And his blood picture was showing a dimorphic picture. Of course, he might be having iron deficiency, but it was maybe superimposed by the high ferritin levels due to the inflammatory state. And we haven't actually repeated the ferritin levels, whether it has come down or not. We have to see. And
yeah, I think the ferritin was because of the acute phase response.
yeah, inflammatory.
Just for the postgraduates here, whenever you tend to see a case like Dr. Saab is asking whether we should have aspirated the joint or not for demonstration of crystals. It is not only for the joint, even for kidney biopsies or any tissue biopsies. Wherever you can get the evidence, please go for it. Because you never know, many times you will be surprised. And you don't want to miss out even a single surprise in your life because it matters most to your patient.
Just one more to add to that is always remember ultrasound is an operator-dependent procedure. So this double contour could well be a figment of imagination.
Yes. Yes, sir. Actually, he had tophi in all his toes and around 4 to 5 of his fingers. He had, in the X-ray had shown, there were hyperechoic radiodense aggregates in his fingers, and his all toes had gouty tophi, which are still, they are painless, but they have decreased in size, but that's still there. He's on treatment.
So, okay, thank you, Dr. Lakshmi, for a wonderful case. Then I'll call upon Dr. Ruby Taparia. Her title is named Beneath the Aching Joints.
Good evening, everyone. I'm Dr. Ruby from KIMS Hospitals, and today I'll be presenting a case titled Beneath the Aching Joints. This is a story of a 45-year-old male who presented with a forward stoop, reporting back and neck pain, which was associated with stiffness throughout the day for the last 3 years. He also reported pain in multiple ribs, both knees and feet, without any swelling. He was managed predominantly with analgesics by multiple doctors outside. He first saw a rheumatologist 6 months back outside, where he was investigated, and inflammatory markers were normal, ESR of 11 and CRP of 0.2. And HLA-B27 was also done, which was negative. So these were the MRI results that were done by the rheumatologist 6 months before he came to us. You can see a focal subarticular stir hyperintensity along the sacral aspect of both SI joints, as marked by the arrows, which was suggestive of probable sacroiliitis. An MRI left knee showed minimal marrow edema in the lateral tibial condyle. So an isotope bone scan was performed, which showed increased perfusion and early blood pooling in both the SI joints, and increased tracer pooling in both knees, ankles, wrists, and small joints of feet. So he was diagnosed as a case of spondyloarthropathy with axial and peripheral involvement. He was initiated on methotrexate 25 milligrams weekly, which he used for 3 months. And because of lack of response, adalimumab was added, which he received for 2 doses. But because of financial constraints, the combination was changed to methotrexate along with tofacitinib 5 mg BD for the next 2 months. So he presented to us with this combination of medication, but he had no response to the given treatment. So we reviewed the history. It was persistent back and neck pain, which was present at rest as well as with activity, with stiffness, which was present throughout the day. There was pain in hips, knees, and feet on weight bearing, with no swellings. There was diffuse bony pains and rib pain as well. Inflammatory markers were persistently normal. On examination, vitals were normal. His general physical examination was unremarkable. Musculoskeletal examination revealed a tender joint count of 12, but no swollen joints. Fevers was negative. There was diffuse bony tenderness over the ribs, but there was no spinal or paraspinal tenderness. The rest of the systemic examination was unremarkable. So our differentials at this point was it still a case of spondyloarthritis? But at the same time, we were looking into metabolic bone disease, or unlikely, but kept as a differential malignancy. So we followed him up with further investigations. A complete blood count was normal. Creatinine was normal. He had hypocalcemia and hypophosphatemia. Alkaline phosphatase was elevated at 239, but vitamin D levels were normal. Parathyroid hormone value was high at 122, and tumor markers were normal. A DEXA scan was suggestive of osteoporosis. So at this point, we were investigating him for causes of hypophosphatemia. So a fibroblast growth factor was elevated at 245 picograms per milliliter. And because FGF23 was elevated, we were looking for mesenchymal tumors. So we went ahead with a whole body DOTA-NOC PET CT. This revealed a gallium-68 DOTA-NOC concentration corresponding to a well-defined soft tissue density in the nasal septal bone. There were also few cortical breaks noted in both ribs, bilateral ribs. He underwent a nasal endoscopic excision and biopsy of the mass in the sphenoethmoid recess. Histopathology revealed a sinonasal glomangiopericytoma. So we diagnosed him a case of oncogenic osteomalacia or a tumor-induced osteomalacia secondary to sinonasal glomangiopericytoma. Follow-up 1 month later, his FGF23 levels normalized from 245 to 42, and his parathyroid levels also improved. And 3 months post-operatively, he had complete recovery from bony pains, back pains, as well as stiffness. So just a brief discussion on the role of FGF23 in oncogenic osteomalacia. So it's a paraneoplastic syndrome of renal phosphate wasting, which is caused by small endocrine tumors that secrete fibroblast growth factor 23. How this causes hypophosphatemia? So FGF23 downregulates the sodium-dependent phosphate co-transporters, which is responsible for phosphate reabsorption and reducing the excretion. So increased FGF23 will reduce the reabsorption and increase its excretion, resulting in hypophosphatemia. It also acts on vitamin D metabolism by increasing its catabolism, by increasing the enzyme 24-hydroxylase, and reducing its production by reducing the 1-alpha hydroxylase enzyme activity. This thereby will reduce the intestinal absorption of phosphate. So by these two mechanisms on the intestine as well as the kidney, it can result in hypophosphatemia and phosphaturia, which can result in musculoskeletal disorders like defective mineralization, osteomalacia, bony pains, fractures, and muscle weakness. A functional nuclear imaging is preferred for localizing these tumors because they're slow growing. They're usually small in size and located in unusual anatomic sites, which could be anywhere in the body. It could be either found in the bone or connective tissues. These imaging techniques exploit somatostatin receptors, which are highly expressed in these phosphaturic mesenchymal tumors. And gallium-68 dotatate has high affinity to these somatostatin receptors. So differentials for hypophosphatemia, just a large, broad outlook, hereditary and acquired. Hereditary causes include autosomal recessive and dominant hypophosphatemic rickets and X-linked dominant. Acquired, more common ones like hyperparathyroidism and vitamin D deficiency. Lesser commons like direct renal tubular damage because of drugs or toxins, oncogenic osteomalacia, Fanconi syndrome, and hematological malignancies. So my questions to the panelists. What are the clinical clues to differentiate inflammatory versus non-inflammatory low back pain? What are the drawbacks of using isotope bone scan to diagnose inflammatory arthritis? And what are the differentials for sacroiliitis on imaging? This point has been covered.
Thank you, Dr. Ruby, for a good case and presenting it in time. And I will hand over the mic to Dr. Vikas to answer these questions.
I think we had already discussed how to differentiate inflammatory versus non-inflammatory low back pain. I'll come directly to the drawbacks of using isotope bone scan to diagnose inflammatory arthritis. One need to understand how the picture looks like. Can you go back to your slide where you have shown that bone scan picture? Actually, the diagnosis was very much evident on that itself before the patient has come to you. Yeah, this one. So if you can see, there are a lot of sacroiliac joint is normally hyper signaling is there on technetium bone scan. I think this is a technetium bone scan which was done. So never report a sacroiliitis on a technetium bone scan. Or if it has been reported on a technetium bone scan, just ignore that. Number one. Number two, the early pooling phase, don't pay any attention to that. you always look for the late phase perfusion. If the late phase perfusion is showing that there is a uptake is increased, that means that joint has got an increased vasculature, or the vascularity of that joint is increased. That is one thing. Other thing is, unless and until you provide correct information to the person reporting the bone scan, they will never be able to report it correctly. 99% at our place, whenever we ask for a bone scan, they report it wrongly. When we go back to them, discuss with them, 99% times the reports are changed. Because they will find whatever is being written here. They don't understand the clinical context. But when we say that this looks like more of a CRPS or reflex sympathetic dystrophy, then they will say, oh yeah, this is fitting in a pattern of dystrophy. Now, if you look at in this picture, the rib cage at the costochondral joints is showing an increased uptake. Very classical feature to suggest osteomalacia. So you could have picked up right from here itself. Okay, this patient has got a metabolic bone disease, and you could have straight away gone ahead and look for workup for a technician, look for a metabolic bone disease itself. So one has to be careful in interpreting. Now, once you have a tumor, now when to suspect tumor, like they have suspected oncogenic osteomalacia, how? If you have a persistent hypophosphatemia or hypocalcemia, for which you do not find any vitamin D deficiency or hyperparathyroidism, then you should suspect oncogenic osteomalacia. And correctly, they have done the FGF23, which is secreted by these mesenchymal tumors. And there are other isotopes, DOTA-TATE, DOTA-TOC, as well as DOTA-NOC, what they have done here. They all have got a very high affinity to bind to the these receptors, somatostatin receptors, and that is how they have picked it up. So one need to be very choosy about which isotope you are actually trying to identify what lesions here. So okay. I think I have answered your question. Okay. Yes. The last part of the last question was?
I think that was covered in the other presentation, sir. The differentials of sacroiliitis.
Sacroiliitis, I just mentioned
yes,
that normal variant to the disease is what
yes,
we have listed in earlier. Anything, Ashish?
Just one point is, you just put up a MRI image there, MR image there. I said that shows sacroiliitis. And I was, it was reported as sacroiliitis.
It was reported, but it was just on the,
and still you put spondyloarthritis as the first thing out there. So yeah. I think the only thing what I have to mention beyond what Dr. Kasar has said is never look at images in, you always have a T1 and a STIR whenever you look at images. You look at, this is not an X-ray. MRI is a dynamic thing. It has to be seen from anterior to posterior, posterior to anterior to figure out what's going on with a T1 as well as. And always remember, whenever you ask for imaging, please give adequate history to the radiologist. If you just tell them back pain, query SPA, answer will be yes, SPA. That's it. So I'm sure that there is a paper coming up in maybe a couple of months' time. It's been held up for a long time, where the ASAS clearly mentions what a rheumatologist should ask a radiologist while ordering an MRI, and what a radiologist should inform the rheumatologist while reporting an MRI. So I think that would be a fantastic thing. Should be out in a couple of months' time. Thank you.
Thank you for the wonderful discussion.
Thank you.
I want to make a comment.
Yes.
Treating physician for this case. It's a very interesting, case. The patient was treated by, around 4 or 5 rheumatologists around. 3 years he had been suffering. And when he came to us, initially we also waited for a month because diagnosed and treated by a very expert rheumatologist. So we all respect that, the diagnosis and treatment. So rather than taking immediate action, just wait and see. Then waited for a month. Always say to my residents, listen to the patient words. Ask him one question, how are you? So not even 1% improvement. So then ask a few questions like, what is the nature of inflammatory pain? No inflammatory pain. Pain all day, but no, not related to rest or activity. Then the credit goes to Dr. Amrita. Now, she passed out from our institute and she joined with Dr. Lisa. Dr. Amrita, are you here? Yeah, thanks. Please stand up. The credit goes to you. So I told her, we are missing something. Please take the history and present to me. She took 1 hour. And by the, at the 1 hour, she cracked. She suspected in the, first instance. In 1 week, 10 days time, we did all the tests. Patient, we have the diagnosis. And we presented this case in Asia, that Ruby presented this case in Adult Use Market 2023. So always listen to the patient. We all know that. Never always go by tests alone. You have to interpret the history and objective findings and the labs put together. Thank you.
Thank you, Dr. Sarath, and thank you, Ruby, for a wonderful presentation. So, and I can probably vouch for what Vikas was telling. Never use bone scan to make a diagnosis of inflammatory polyarthritis. And if anybody has worked in England, if we send a request for a bone scan with a diagnosis of polyarthritis, the radiologist will refuse to do it. So it is not indicated at all. Do it only when you suspect a metabolic bone disease or a CRPS or a Paget's, etc. So that's very important, because extremely common for a bone scan to come back as suggestive of polyarthritis. That may prompt us to make a diagnosis of inflammatory arthritis and start. And another point from here is not even 1% response to adalimumab and tofacitinib. I think we should pause there. We should pause there and ask a question again. Ojana?
Probably people had less than 1.6 is too low.
Too low, yeah. Yeah, but it was not done by the other doctors. So when it was done after when they are suspected. So one advantage of US system is everybody goes to a doctor, they will get a complete biochemical. So they pick up asymptomatic hypercalcemia, they pick up a lot of hyperparathyroidism. So alkaline phosphatase is high. And I think we should also probably do calcium phosphorus alkaline phosphatase in our patients, particularly who present with non-arthritis musculoskeletal aches and pains. Not only osteomalacia with low phosphate, look at alkaline phosphatase as well. Very low alkaline phosphatase called hypophosphatasia. They can produce a lot of spondyloarthritis-like symptoms. So if we keep on doing it, we may pick up one. But calcium phosphorus, alkaline phosphatase should not add too much of burden to the patient's purse as well. I think with these comments, I think we'll move on to the last patient. Last case, Dr. Jabon Diol. And I'll excuse myself and I'll ask Vikas to carry on the proceeding.
Thank you, sir. Myself, Joban Deol. I am from PGIMR Chandigarh. I am going to present the last case for the day, an intriguing case of arthritis and chronic diarrhea. This is a 42-year-old female who presented with multiple joint pains involving both small and large joints for 5 years. It was associated with swelling and early morning stiffness lasting for more than 1 hour. Rheumatoid factor was found to be positive, and she was labeled as rheumatoid arthritis outside and started on methotrexate, which she took for only 6 months, and then she was non-compliant. Then she resorted to complementary and alternative medications that also she took for another 2 years and then left all the medicines. She was having on and off joint pains. Now this time she presented to us with loose motions for 2 months, which was 4 to 5 episodes per day. There was no blood or mucus in stools. Tenesmus was there, lower abdominal pain was there, and low backache. She developed new onset low backache for 1 month, which was insidious onset, more during rest, relief with activity, and associated with early morning stiffness lasting for 30 to 60 minutes. And on examination, she was having nodular episcleritis of the left eye, and bilateral shoulder, bilateral elbow, left wrist, right knee, and bilateral third metacarpophalangeal joints were tender, and the right knee was swollen as well. And she was having bilateral elbow and knee crepitus. Bilateral elbow joints were also damaged, and bilateral fibers were positive. Investigations revealed anemia. There was elevated ESR. Rheumatoid factor was 48 international unit per ml. Anti-CCP, HLA-B27 were negative. And as an evaluation for chronic diarrhea, IgTTG was negative, TSH was normal, HIV was also non-reactive. And we also thought of amyloidosis in the setting of chronic inflammatory arthritis. So 24-hour urine protein was also only 54 milligrams. Anemia workup revealed iron deficiency anemia. Stool workup was negative. Stool calprotectin was raised. Upper limit usually is taken as 50 microgram per gram. It was 90 microgram per gram here. Amyloid fat per biopsy was also negative. colonoscopy revealed multiple aphthous ulcers throughout the colon, terminal ileum, as we can see here. And there was a multiple compact non-caseating granulomas with the giant cells also scattered throughout. And the second image is showing architectural crypt distortion. There was crypt dilatation and crypt loss. And so this histopathology was consistent with Crohn's disease. MRI sacroiliac joint T2 stir images shows hyperintensities in the iliac sides of both the iliac bones, which was more on the right side, which was consistent with sacroiliitis. So the final diagnosis was Crohn's disease, manifesting as extraintestinal manifestations in the form of nodular episcleritis and peripheral arthritis type 2 with axial spondyloarthropathy and bilateral knee osteoarthritis. She was treated with prednisolone 40 mg per day, which was gradually tapered over 4 weeks and stopped, particularly for the colitis part. Joint pains and diarrhea improved. She was then started on azathioprine 50 mg or OD, increased to 125 mg per day for the colitis part, and tablet sulfasalazine 1 gram BD. So she is now for 4 months follow-up. She is doing fine. She has no diarrhea, and all the joint pains and the back pain is also improved, barring the knee pain, which is persisting because of the osteoarthritis part. So important messages is arthritis, it can predate the onset of GI symptoms by many years in IBD arthritis. Around 15 to 20% patients can have arthritis preceding the IBD manifestations. Maximum time which has been reported in literature is from 9 months to 25 months, but in this index case it was 5 years. And rheumatoid factor positivity, particularly low titer positivity, can be seen in less than equal to 10% of patients of IBD as well. So my questions for the panelists are, is it a case of overlap of IBD arthritis with rheumatoid arthritis? I religiously stick to the slides, that's why I have not put the images of X-ray hands and wrists. They are just showing juxta-articular osteopenia. There are no evident erosions. There are no narrowing as well. Although the bilateral elbows, they are showing narrowed glenohumeral joint, and X-ray knees are showing the advanced osteoarthritis changes. My second question is, what are the causes of chronic diarrhea in long-standing rheumatoid arthritis, which we usually see encounter in our practice? And the third question is whether it could be a case of RA with Crohn's disease rather than IBD arthritis, because as per the largest database of 65,000 patients, there was of IBD patients, 3.3% patients were having rheumatoid arthritis, while 1.9% patients were ankylosing spondylitis. So that overlap can also occur.
Thank you for your very crisp presentation. And so I'll start asking from you only. Sure. Why did you consider this as an overlap of IBD with rheumatoid arthritis?
Well, I have given the X-ray for the reason being that it's just I put it here, but I definitely don't go for rheumatoid arthritis because this patient never took DMARD. She took it only for 6 months, and then she resorted to complementary alternative medications. Still, she has not developed any erosions. So for me, rheumatoid arthritis doesn't seem, it seems more like a IBD arthritis only.
Okay, so I'd like Dr. Ashish to respond to the...
I was just telling Dr. Vikas also, there's only one answer, no. That's it. Yeah. Okay, if I went to one long answer, thing is, I think if we understand the construct and concept of spondyloarthritis over the past couple of decades, we understand that this whole thing is one disease, right? If you have a spondyloarthritis, you have axial, peripheral, and of course your IBD is one of those small circles. Now, what I wanted to point out is actually now as we understand the disease more with imaging modalities, be it ultrasound or MRI, we are again trying to understand this whole gut joint skin axis, right? We have lab work happening as well as the imaging work happening, and now we know that most of the patients are, in fact, if I were to quote it, there's a recent study from the Copenhagen group in which they did ultrasound in an IBD clinic, which showed 50% of patients had peripheral ultrasound manifestations suggestive of arthritis in an IBD setup. If I were to quote Carl Gaffney's paper, which was published a few years ago, in which he did MRI of SI joint, 20% of patients with IBD had structural changes and inflammatory changes suggestive of axial spondyloarthritis. So we understand that's all one spectrum. And if you look at the treatment also, we know that TNFI works pretty much for all. And there are some caveats, which one of them includes if you give vedolizumab, your arthritis increases, and then you need to give TNFI first. So you have, in fact, trials going on with vedolizumab and golimumab at the moment. So is it an overlap? Not really. It's all, for me, it's just one spectrum of disease, which is the spondyloarthritis spectrum, in which you do have dactylitis, axial disease, and peripheral arthritis.
So I just want to say, not in this index case, here definitely we are considering IBD arthritis. In routine OPD care, like how frequent we have seen the overlap of spondyloarthropathy with rheumatoid arthritis.
It again depends on how do you define rheumatoid arthritis. If you say that 48, no.
Yes.
If you say it's like, and again, if you look at psoriatic disease, there are reports where your ACPA results, ACPA units are quite high, rheumatoid factor is high, still the patient is psoriatic arthritis. And there are a few studies from Japan in which they showed that joint involvement is rather fast and quite debilitating in those patients, but still they are PSA patients. So just by having an ACPA or, first of all, why was it sent? That is the first question. So no, I'm not in this case, since you said that,
This was all done outside the investigation.
Yeah, no, that's fine. So what I wanted to say is, for me, it's all just one spectrum, and we take it from there.
Please, Vignesh.
Since I've asked for causes of chronic diarrhea and arthritis, I think another important differential diagnosis is a common variable immunodeficiency, because CVD has two spectrums actually, infection predominant and inflammation predominant. So unexplained interstitial lung diseases, chronic diarrhea, in combination especially with arthritis. I think CVID should be one differential type, important differential which you should consider. And simple immunoglobulin would give you the clue.
Sure. Any questions from the audience?
Basically, sir, I wanted to ask, there can be two types of things.
Use the mic.
Basically, there are two types of thing. One, primary bowel disease deriving the joint inflammation like Crohn's disease, arthritis in Crohn's disease. Another thing is primary diagnosis is Young's-Pond, and then we have a subclinical or clinical bowel involvement. I wanted to ask, what is the MRI picture? How is it different in both the diseases? Can it help to cleanse the diagnosis? What is the primary? Because in many Young's-Pond patient, we can have severe bowel disease also, presenting with anemia. So is MRI helpful to differentiate two entities?
Between Young's-Pond versus?
Like in this image, can you show the image? There is a asymmetric involvement in this. SI joint involvement, right is involved more than that.
Yes.
So is it more commonly seen in Young's-Pond or IBD? Like we know that in IBD it is a symmetrical involvement, what I know.
So there is a lot of overlap between the imaging findings in between Young's-Pond and the IBD associated arthritis. IBD associated arthritis can exactly mimic like Young's-Pond. Rather, sometimes it is called as a secondary Young's-Pond when you have a bilateral sacroiliitis. And sometimes even Young's-Pond can begin asymmetrically, can have unilateral sacroiliitis. So we cannot differentiate based on MRI finding whether this is IBD or whether... Yes, patients of Young's-Pond up to 60% can have subclinical colon involvement, whereas frank involvement is seen in around 5 to 10% of the cases only. Whereas in IBD associated arthritis, around 40 to 50% will be having a gut involvement as compared to Young's-Pond, which is having only 5 to 10% of the gut involvement. The question here is that don't get carried away by rheumatoid factor. So always keep your mind open. Rheumatoid cannot involve the axial joints. So here this lady, though she has developed after 5 years of initial presentation, axial involvement, if you combine the two things together, peripheral plus axial and gut involvement, this is nothing but IBD associated arthritis. Yeah, Sapan.
The other two diseases that, talking of diarrhea and arthritis, is one is celiac and the other is Whipple's. And I remember a case of celiac who was diagnosed by the neurologist. That patient came with cranial nerve palsies and had weight loss and some arthralgia or arthritis. And as a routine, I did not know they get TTG as a workup done. So the TTG was positive and the CCP was also positive. I don't know, they did CCP just because of those joint pains. And then I went and read that TTG can actually give a lab false positive CCP. The patient didn't have rheumatoid arthritis according to me because the x-rays are all normal. So that is when I learned KIT can give a technical fallacy. I never knew that. That's one. But celiac sometimes, I think GIA there are associations of celiac. And the other is Whipple's, which I've never seen and never diagnosed, but I've read. In arthritis rheumatology, there was these photographs of Whipple's causing erosions. But they would obviously have other features suggestive of malabsorption.
Yeah, yet to see a case of Whipple's.
Yeah, this is another example of don't get carried away by antibodies. Okay, today we've been learning everything about antibodies. Don't get carried away, especially rheumatoid factor. When values come mild or moderate or very high rheumatoid factor values. And here you have a very nice clinical diagnosis. It's always nice to put everything in one basket. Very simple. Why go searching for so many different things and rack your brains and wonder? See, we know IBD has two varieties of arthritis, no? Acute and chronic. And you have asymmetrical, you have bilateral symmetrical, you can have sacroiliitis, you can have everything. So it should come in the DD of polyarthritis, never get carried away by this. And chronic diarrhea, you went out of the way to ask a question about diarrhea and rheumatoid, long-standing rheumatoid. Amyloid, it's out of this case at all, totally. Amyloid is one of the things.
With this, I thank you for your nice presentation. And with this also, we conclude the session. Oh, yes. Oh, sorry. The rapporteur is here to summarize the cases.
So good afternoon, everyone. So I made few slides actually beforehand, already going through the cases. So first case we had was beyond the surface, a case of unconventional low back pain. So as we think, I think since morning we have been going through this red flag scenario. So this case actually had lots of red flags. Symptoms started above 45 years, no typical inflammatory back pain. There was a lot of bone pain, HLA-B27 negativity, poor response to non-steroidals, and I think adalimumab and tofacitinib. So there is this risk of incorrect, so what we learned is that risk of incorrect diagnosis of axial SPA only based on sacroiliitis on radiography or MRI. And in the scenario of atypical musculoskeletal pains and bone pains, hematological malignancy should be considered if there is a bone profile is not explaining. And so the common hematological malignancies which are associated in spondyloarthritis, which we should be aware of, or we should be looking out if the symptoms are not typical, are leukemias and lymphomas. And in discussion, we had this, and if we are thinking of hematological malignancies, we should not be giving, or even for that matter, we should not be giving steroids for any undiagnosed joint symptoms because they may in future alter the bone marrow findings. Nocturnal pain, we should always be suspicious of malignancy. And we should always be looking for the normal variants of sacroiliitis on imaging that should be looked for. And there was another suggestion of the CT scan. If we are worried about that not typical findings, CT scan sometimes can give us some clue of diagnosis other than spondyloarthritis. About the second case, so episodic back pain in young. Spondyloarthritis is not episodic, as been we have pointed out. Patient on Ayurvedic medicines, as we are aware that most of them have steroids, so we should be aware. Lots of peripheral involvement, HLA-B27 negativity, sacroiliitis on imaging, so lots of red flags. So when we are getting these back pain patients and when the history is suggesting of all these things, we have to be mindful of this. There might be something else going on. And then this very well discussed, this dilemma of overlap of gout in ACE or gout causing all spondyloarthritis symptoms, so that we have to be mindful. Probably in our case, which was discussed, gout was the primary diagnosis, but overlap can also happen. And as has been discussed, that about 14 to 17% of gout patient can have, chronic gout patient can have sacroiliac involvement. And chronic gout can involve any of the structures of the vertebral column, pedicles, lamina, epiphyseal cartilages, and sacroiliitis is also there. And there was the discussion about dual energy CT scan. It's very well, it can diagnose, suggest gout involvement there, but we have to be careful that the gold standard for gout diagnosis remains aspiration and looking for the crystals. Coming to the third case, a 45-year-old male, back pain, bone pain. Again, we are talking bone pain, back pain with bone pain, normal inflammatory markers, HLA-B27 negative, MRI again showing sacroiliitis, and again there was no non-response to our DMARDs. So lots of red flags are also here. And here also, which raises an important point about the difference in identifying bone pain versus arthralgia versus fibromyalgia pain, because we know AS patient can have fibromyalgia pain. So that needs to be seen. And once we are certain that there is a suggestion of bone pain, it needs in-depth analysis for looking for the metabolic bone markers like calcium, phosphorus, PTH, thyroid profile, vitamin D, ALP. And if any of this is suggesting hypocalcemia, hypophosphatemia, FGF23 should be estimated. And then there was this discussion about isotope bone scans. So bone scan should never be done for any of inflammatory arthritis diagnosis. Even if they are done, look for the late phase, not the early phase. And if there is a suggestion, if there is in the blood test, if there is suggestion of persistent hypocalcemia, hypophosphatemia, always think of any malignancy. And there was the discussion about MRI. So MRI for sacroiliac joints very well pointed out that we should always be giving a history to a radiologist that what are we asking for MRI. Ideally, radiologists should be aware of that spondyloarthritis protocol. They should be doing proper sequences, looking for the whole spine properly. And then the diagnosis or the radiological finding of sacroiliitis should be mentioned, or axial spondyloarthritis should be mentioned in MRI. So just on the basis of sacroiliitis on MRI, we can't make a diagnosis of axial spondyloarthritis. And coming to the case number 4. So here again, 42-year female, persistent rheumatoid. So she was initially diagnosed as rheumatoid arthritis, probably just because of just a positive rheumatoid factor. But then she developed inflammatory back pain and diarrhea. And then there was this again suggestion of sacroiliitis on MRI. Other thing which was slightly there in the case was that she had all the large joint involvements, and there was in fact destruction of the joints. So crepitus of elbow and crepitus of knees. So that was something which was suggesting of inflammatory arthritis here. And we should be aware of this. So the numbers have been discussed that about 20% of IBD patients can have arthritis, peripheral arthritis, and about 10% of IBD patients can have sacroiliitis, while about 50% of axial spondyloarthritis patients can have ileal or chronic inflammation. And there was this mention of eyes. I think there was this, the patient developed episcleritis, so that is also a suggestion. So if you are thinking of back pain and eye issue, usually axial spondyloarthritis is associated with uveitis, and episcleritis probably is associated with IBD. So this was also discussed. So this is sort of a great learning point here. So if I summarize, so from all these 4 excellent cases, so what we learned, so I think how to avoid getting stuck in loop of this spondyloarthritis mimics. So if in a young patient, back pain, axial or spondyloarthritis remains a diagnosis, but we need to exclude other possibilities. As we have been seeing since morning, patient history is crucial. Spondyloarthritis, axial spondyloarthritis remains a clinical diagnosis. So we have to exclude everything. And even if we make a diagnosis and patient is not responding as with medication, always we should be reconsidering our diagnosis. Thank you.
Thank you, SPA faculty, Dr. Dharmanand, Vikas Agarwal, Ashish Jacob Matthew, and Himanshu Pathak. Now we are moving on to the next exciting session, the last session today, rheumatology quiz for trainees. This is in it's a 2-day thing. First day prelims, preliminary round, is going to be conducted by Siddharth Jain, Shaunak Ghosh, and Amrita Gopalan. So, can I ask the panelists to take over? Dr. Siddharth Jain, Shaunak Ghosh, and Amrita Gopalan. And here, this quiz is only for the trainees. And there are no groups, only individuals. The panelists will announce the rest of the rules of the game.
So, welcome everyone. I think we have a lot of exits happening, but just like to put a disclaimer before the exits happen. So, we have slightly deviated from the pattern of the quiz that was conducted the last time around.
A quick note I want to share with you. We have a gala dinner here itself. Okay? After this session, we have a half-an-hour cultural program followed by a gala dinner. So don't miss that. Enjoy the Hyderabadi food. We're arranging a special dishes for you all tonight. Don't miss that.
So we have more than one reason to stay back now. So as an introduction to the quiz, so I am Siddharth Jain. I am an assistant professor at AIMS Delhi, and I have with me Shaunak Ghosh and Amrita Gopalan. So they are all here coordinating and distributing the answer sheets. So what we've done differently this time is we have divided the quiz into 2 sections, prelims and finals. So because we have so many trainees around and a single round of displaying questions and choosing out the winner seems to be slight injustice to the pattern of quizzing that we are used to. So today in the prelims, what we'll be doing is shortlisting 6 top people out of all the trainees and fellows we have amongst us. So for the first thing, I would request everyone to maybe come in the center because we'll be displaying all questions here. And if you're not able to visualize the questions properly, and we won't be keeping a lot of time for the questions, so you might miss out on certain important information. So if we can request all the interested trainees, fellows to probably come in the center, it'll be more useful. That is point number 1. And I'll just brief you about the rules of the quiz. So as far as the prelims are concerned, so we'll have a set of 25 questions. They'll be displayed here on the screen. And on every 5th question, you'll notice a big, difficult to miss asterisk mark. Kindly note that those asterisk marked questions will have significant importance. Why? Because the unmarked questions have a +1 for the positive, but no negatives. But the star mark will have a higher positive, that is +3, a negative in the form of -1. However, no answer will not attract a negative. And in case there's a tie, which we anticipate there will be because there are so many of you, we will be selecting the top ones based on whoever has marked more of the star marked questions correctly. And based on the prelims, we will be selecting the top 6. Are the rounds clear to everyone? And as far as marking are concerned, so for the prelims, all of the questions are MCQ type. So all you are supposed to write in the answer sheet that has been provided to you is the option that you want to answer. That's all. We don't want detailed answers on anything, just the correct option in your answer sheet. Clearly write your name and clearly write your university or training institution on the names on the sheets so that it's easier to and also your phone number, so in case you disappear or we're not able to trace you, then it's easier to give you a call so that we can let you know that you've been selected for the finals. Being selected for the finals is important because there's moolah involved. So the top 3 have cash prizes which have been organized, which have been finalized by the organizers, and there are also some surprise gift hampers which are in queue for the audience correct questions. So, right, so everyone has a sheet, everyone has a pen, everyone is all set, everybody has written their names, institute, phone numbers? Yes? And everybody is clear with the rules. So should we start?
They're all seated together. We have lots of ties, lots and lots.
Should we?
Space them. Yeah.
It's okay.
No, space them.
Okay.
Hello, fellow quiz-loving mortals. Please space yourselves out a bit. Otherwise, all we are going to do all evening is we are going to go into tiebreakers because all of your answers are going to look the same. So space out, space out, space out. Leave a couple of seats in between, please. And we are going to start very soon.
Now all the faculties are please. You can occupy your faculty chairs early. Please. You don't need to wait for the clear up. Come this side, to the center. Here it is visible.
And the pattern of the quiz that we have made is predominantly clinical. So we have kept a good mix of things. So the prelims may seem slightly straightforward, but that is how prelims are. But the mains tomorrow, you will be up for quite a lot of surprises because a lot of effort has gone behind making the quiz that we have planned for you. So this is entirely clinical, has a lot of translational value, a lot of educative value. So I hope you enjoy the quiz. So let's start. So the time, I forgot to mention the time, so there will be 20 seconds per question. Most of them are one-liners, so time should not be an issue. But in case I see a lot of people are struggling around writing the answer, I can prolong it by 5 or 10 seconds. Is that fine? So let's start with the first question. So which of the following is wrongly matched? So this is based on the ANA patterns. Which type of pattern and how does that help with the disease prediction? Rim pattern, nucleolar pattern, centromeric pattern, speckled pattern. So please read the statement carefully because seen and seen most commonly or relatively specific, all of that would have a bearing. So next question. What is true among the following? So this deals with complements and how we interpret them. So the first option is low C3, low C4. It indicates alternate complement pathway activation. Low C3, normal C4 indicates classical complement pathway. Normal C3, low C4 means heterozygous C4 deficiency or a low level complement activation which may be happening in C1 inhibitor deficiency. All are false, all are true. So you see three various permutations and combinations. Let us know which of these are true. So move on to the next one. All are features of RTA in primary Sjogren's except. So we all know primary Sjogren's is associated with RTA, many kinds of RTA. How do we diagnose it? What are the features? This is an all except question, so 3 are correct, 1 is wrong. So all of them are just single correct answers, no multiple choice. Next question. So we have a whole lot of outcome measures in rheumatology. The increasing focus is towards patient-reported outcome measures. So out of these 4 outcome measures that are listed, which of them is a patient-reported outcome measure? DAS28, RAPID3, SLE-DAS, ASDAS. Next question. So this is a star marked question. Has a negative, has a higher positive. So patient, female, gravida 4, para 0. 2 spontaneous abortions at 8 and 10 weeks of period of gestation. Now comes with another pregnancy, this time 13 weeks pregnant. Lab evaluation shows prolonged APTT. APLA workup shows positive anti-beta 2 GPI. So how would you like to manage her? Would you want to give her heparin bridge to warfarin? Would you want to give her enoxaparin, that is low molecular weight heparin, and aspirin? Enoxaparin alone or warfarin? Next question. Which of the following histological features is least diagnostic of vasculitis? So as we all understand, vasculitis is predominantly histopathological diagnosis. There are some serologies which help, but the definitive diagnosis comes from histopathology. So out of the various histopathological features you are used to reading on the pathology report, which of these is least diagnostic for it? Again, we just want the option numbers in your answer key, nothing else. Next question. So, COVID saw a rise in the number of publications, COVID saw a rise in the number of classification criteria, management guidelines, everything has been revised. So this is about the APS classification criteria. The newer ones have included non-criteria manifestations, one of which is the cardiac involvement. Regarding that, which of the following is true regarding valve thickening? So as we can see, we have various sorts of valves, various sort of valve thicknesses, and various sort of age categories. So which of the following is correct? Done? So next one. So expanding into immunology rather than just clinical rheumatology. So true Nikolsky sign is elicited in which of the following conditions? Epidermolysis bullosa, pemphigus vulgaris, bullous pemphigoid, or dermatitis herpetiformis.
So moving on to question number 9. The relatively recent Triton study has demonstrated the efficacy of initial triple drug therapy in the management of pulmonary arterial hypertension. So what were the 3 drugs in this regimen? So we have 4 options here. I'll move on to the next question. So question number 10 is again a star mark question. So we have a 50-year-old male who comes to us with progressive skin lesions over the lower extremities. He's been facing increased weakness of his limbs, more so in his right upper hand. He does not have abdominal pain, shortness of breath, or cough. He's been an IV drug abuser in the past, but not now. On examination, we see palpable purpura over the lower limbs. Power, detendon reflexes, and sensations are reduced in the right upper limb. All peripheral pulses are normal. Lab evaluation shows a raised creatinine of 1.3, high AST and ALT. He tests positive for hepatitis, anti-HCV and HCV RNA being positive. He also has a low C4. Elastography shows mild hepatic fibrosis. So what do you think is the best initial step of management for him? High-dose prednisolone with rituximab, DAA, plasma exchange, or IVIG? DAA is directly acting antivirals. So we'll move on to the next question. Number 11. Giant cell arteritis is unlikely to involve which of the following vessels? Vertebral artery, pulmonary artery, subclavian vessels, or the carotid artery? So the next one. Which of the following syndromes is not a type 1 interferonopathy? Chilblain lupus, Majeed syndrome, Aicardia-Goutieres syndrome, or SAVI? The next one, question number 13. Which one is a statistical test for continuous variables? ANOVA, chi-square, Fisher's exact test, or McNemar's test? The next one. Eichenholz's classification is used for the radiographic classification of which of the following conditions? Hypertrophic osteoarthropathy, avascular necrosis of the hip, ochronosis, or Charcot's arthropathy? So we move on to question number 15, which is again a star mark question. Identify the false statement about ultrasonography in giant cell arteritis. A halo is a homogeneous hypoechoic wall thickening of the artery. Halo score measures the thickness of the temporal artery, its branches, and the axillary artery. A higher halo score identifies patients who are at higher risk of ocular ischemia. Or EULA recommends temporal artery or axillary artery ultrasonography as a diagnostic tool for GCA. We'll move on to the next one. Question number 16. Which is the true statement about netosis? Extrusion of nuclear DNA takes more than 24 hours. Vital netosis occurs more quickly than suicidal netosis. Release of nets is always associated with suicide of the neutrophil. And netosis promotes undesirable immune response.
Moving on to the next one, but before that, there's pin drop silence in the hall. I don't think I've ever witnessed a quiz contest happening where each participant is so focused. So either we are going to have very high scores, or we have messed up and made such a tough quiz that we are going to get only zeros. One of the two things is going to happen, Siddharth, at the end of this. Moving on to question number 17. Which of the following statements is false about limited cutaneous systemic sclerosis? Does it have a higher prevalence of calcinosis than the diffuse subtype? Does it have a higher prevalence of renal crisis than the diffuse subtype? Are telangiectasias a prominent feature of this disease? Or it may have PH without the presence of ILD. Select the false statement. Moving on to question 18. In 2016, the company Merck had to discontinue the manufacture of the anti-osteoporotic medication because of the data that came up on increased cardiovascular event risk as compared to placebo. So which drug am I referring to here? Bazedoxifene, cetrusumab, blosozumab, or odanacatab? Moving on, question 19. Which of the following serologic tests is not part of the, within quotes, diagnostic criteria of autoimmune hepatitis? Is it A, SMA, AMA, anti-SLA, or anti-LKM1? Clearly, I'm not giving out the full forms right now. That's part of the question as well. Question 20, yet another star mark question. Going back to the bench side again, which of the following statements is wrong? C ANCA in formalin fixation will give a cytoplasmic pattern. P ANCA antibodies in ethanol fixation will give a cytoplasmic pattern. ANA in formalin fixation will give a negative result, or ANA in ethanol fixation will give a nuclear pattern, which is wrong. Moving on to 21, what is the drug of choice for osteoporosis in a patient with stage 4 CKD? Is it teriparatide, is it denosumab, is it zoledronic acid, or romosozumab? Question 22. The new 2017 ACR and EULAR classification criteria for idiopathic inflammatory myopathies has drawn criticism for including only one MSA or myositis-specific antibody in it. Which one of the following has been included? MDA5, JO1, MI2, or TIF1 gamma? Question 23. Which of these is not a component of the ITAS 2010 score? Vertigo, abortions, headache, or severe abdominal pain? Which is not a component? Question 24, the penultimate question. Which of these conditions is due to crystal arthropathy? Little leaguer's elbow, Kienbock's disease of the lunate, skier's thumb, Milwaukee shoulder. And finally, question 25, we are ending with yet another star mark question. The TULIP 1 trial for patients with lupus did not meet its primary endpoint. However, for TULIP 2, the endpoint was changed, and that was successfully met by the drug that was being tried. So what was this change? Was it LL-DAS changed to SRI4 as the outcome? SRI6 that was changed to BICLA, BICLA? BICLA that was changed to SRI4? SRI4 changed to LLDAS, or SRI4 changed to BICLA? I'll give you 10 more seconds to work this out, and after that, we are going to end the prelims. And there's your time. So with that, we come to the end of the prelims. The way we want to work this out marks-wise is, kindly hand over your answer sheets to your trusted / not so trusted neighbor or frenemy, whoever is sitting around you. They are going to mark the scores for you. Then you're going to get them back, cross-check once, and finally we're going to select the top 6 participants for tomorrow's mains. So kindly exchange your sheets, please.
And there's no scope of Ghapla because we'll verify the top 6 and the top 10 to see they've marked correctly or not.
That's all. Still, you can just explain. Exactly. That should be it. I don't think so. I think what I spoke about, I spoke about. कौन सा प्रेफर करोगे ये श्योर अब वी कैन जस्ट इन आवर
why they collecting the sheets?
Ensure that they don't take it. Don't bring back the sheets here, please. We want to make our work easy. Redistribute to other participants. What if? Sorry? No. Hopefully not. That was the point of trying to give it to your neighbor. Give it to different rows or segments at least. Whoever, वहाँ से जो लिया है ना, just bring it over here. Amrita, get those papers वहाँ के लिए. Change the entire segment. हम जाके डिस्ट्रीब्यूट कर दे थोड़ा
Those who don't have sheets, please raise your hands. It will make us, yeah. Please raise your hands, those who don't have sheets. Udesh.
Just a reminder about so just a reminder about the scoring. So all the non-star mark +1 and 0, so no negatives, correct +1. For the star mark, that is the question number 5, 10, 15, 20 and 25, correct +3, incorrect -1, no answer 0. Is that correct? So let's start. So this was fairly clear. So rim pattern is produced by which what is the incremental antigen for producing the rim pattern? dsDNA. So dsDNA, besides producing a homogeneous pattern, can also produce a peripheral/rim pattern. So that is what it is. So it's very specific for lupus. Nucleolar can be seen in diffuse systemic sclerosis, as by virtue of RNA polymerase 3 U3 RNP, centromere pattern was very clear. Speckled pattern can be seen in lupus, but that's not the most common one. When we see a speckled pattern, the common things that we get to see are Sjogren's most commonly, or can be in few types of systemic sclerosis as well. Wrong is zeros. So next was about complements. So as we understand, so C4 and C2 are a part of classical pathway. So obviously both C4 and C3 are low, that will suggest classical. So basically A and B were actually reversed if they were to be true. And as we know, isolated low C4 in an appropriate history should make us think of angioedema. And so one question that I would want to ask is, so if this was C1 inhibitor, C1 esterase inhibitor deficiency, that is angioedema, how would you distinguish whether it is hereditary or acquired, apart from family history and stuff? Which lab test? Yes, C1q. So C1q, if it is normal, that goes more towards hereditary. If C1q is low, that goes more towards acquired, seen in some cases of lupus as well. We often see such a case once in a year. So this was about RTA.
So anyone, the correct answer? All of you have got it, I hope.
Right.
It's already there.
Right.
So as we know, the lesion in renal tubular acidosis is the inability of the kidney to acidify urine. So low urine pH is the wrong option here. The patient will have acidosis but an alkaline urine.
So the cutoff that we follow is 5.5, yes.
So this is again a simple, straightforward question. As we know, RAPID-3 is a patient-reported outcome measure for rheumatoid arthritis. All the others are physician-reported.
So we don't get to use it these days, but if you see the landmark RCTs in RA done previously, you would see RAPID-3 creeping in somewhere there. So this was one clinical question. The important point is there is evidence to suggest that addition of low dose aspirin to low molecular weight heparin improves outcomes in these patients rather than low molecular weight heparin monotherapy. So enoxaparin and aspirin, this is more being treated like obstetric apla. So least diagnostic, very important clinically, because we would see that a lot of pathologists at a lot of centers or a lot of pathology labs would report a diagnosis of vasculitis just merely on the presence of perivascular infiltration, which is incorrect. So unless we actually see the evidence of inflammation in the vessel wall, which is producing either karyorrhexis or leukocytoclasia or fibrinoid necrosis, or we see a breakdown in internal elastic lamina. So we use special staining, which is called as the EVG stain or elastic von Giesen stain. So a lot of people don't do that stain as well. So that stain helps us pick a break in internal elastic lamina. And if that is present, that is telltale evidence of vasculitis. Being aware of this is very important, because unless we know what is the real point, we cannot ask our pathologists as to what we really want.
So in the newer classification criteria for APS, we have several non-criteria manifestations which have been included. So it is important to define what is mitral valve thickening, because we know that there are a lot of differentials to mitral valve thickening. So the correct answer here is mitral valve more than 3 millimeter. So the wrong answer here. The correct answer is more than 4 millimeter for the age group of 20 to 39. As the age advances, the thickness, the elasticity of the mitral valve comes down, the thickness increases. That's why we have a higher cutoff of 5 millimeter for people who are aged more than 40.
Next question, true Nikolsky sign elicited in which of the following conditions? So what is true Nikolsky sign basically? Any intraepidermal pathology limited within the epidermal layer, there will be acantholysis, separation of the cells because of the desmosomes, hemidesmosomes loosening up. That is true Nikolsky sign. You open a blister, it spreads. False Nikolsky signs are seen in subepidermal conditions. So only pemphigus vulgaris, toxic epidermal necrolysis, staphylococcal skin scalded syndrome. These are intraepidermal. Everything else would be false Nikolsky. The relatively recent Triton study, so follow-up after Griffon, where selexipag was one of the main drugs, but of course it was a triple combination of macitentan, tadalafil, PDE5 inhibitor, as well as the oral selexipag, prostacyclin analog.
So this was one clinical question, although we had decided to keep clinical case-based scenarios for the mains, but we thought we'll just creep in a few. So, so we have already displayed the correct answer. How many got it correct? Can I have a show of hands? So very nice. We have numbers going to double digits, so that's nice. So the entire concept is, so the diagnosis is very clear. What is the diagnosis? So HCV related cryoglobulinic vasculitis. So it is important to understand that merely a diagnosis of HCV cryo does not warrant immunosuppression. So milder cases will be managed with two, that is direct acting antivirals. However, if the manifestations are severe, organ/life threatening, then taking care of the inflammation by use of rituximab or high dose prednisolone takes precedence. And then subsequently, after an interval of probably 2 weeks, we would be introducing antivirals. So that was the concept of this question, and that's why we decided to make it star marked. Intuitively, we might want to think that there is role of plex, but we need to understand that that role is limited to very select few cases, including when the cryocrit is very high. So cryocrit is basically quantified cryoglobulin. So when the cryocrit percentage is very high, say more than 10%, so there is risk of flare once we give rituximab. So to reduce the cryocrit levels, we sometimes have to administer plasma exchange, but that's not the first line therapy. So I'm glad so many of you got it correct. So next was GCA. Did everyone get it correct? So I was expecting more of you to get it correct. So as we understand, so GCA is, so apart from a general understanding of it being temporal arteritis, that is cranial GCA, there's a large chunk of GCA which is extracranial or large vessel GCA, which has some overlaps with the conventional LVV that we see, that is Takayasu. So vertebral, subclavian, carotid, all of them can be seen, but pulmonary artery involvement is very, very uncommon in GCA. It is uncommon in Takayasu as well, but we do see it in a cases in the, so the percentage varies from 5 to 40% depending on what the series you are seeing, but it is seen. So I'm sure most of you would have seen in your training years pulmonary artery involvement in Takayasu, either clinically or subclinically. But if you talk about large vessel GCA or extracranial GCA, pulmonary artery involvement is seldom reported. So this was about autoinflammatory syndromes.
I think we had a discussion today morning about, the pediatric session on type 1 interferonopathies. So the answer is Majid syndrome because, as most of you may know by now, familial chilblain lupus, Aicardi-Gutierrez, Savi, Candle, these are all syndromes where there are defects in various molecules which are part of the interferon alpha or beta signaling pathway. Although Majid syndrome is also presenting with high levels of IL-1, IL-1 beta, the basic defect is basically high M2 macrophage activity instead of interferon pathway molecular defect. So that is not a type 1 interferonopathy. And it presents as multifocal recurrent osteomyelitis without infections.
So where did we hear about Aicardi-Gutierrez today? In what context? Intracerebral calcifications. So that was the easiest, I think.
This requires no explanation. There's just
anybody
one right
doubt?
answer.
Anybody has a doubt? I'm sure
There's not much to explain. It is what it is.
What is the full form of ANOVA? I'm not hearing as much as I should be. Analysis of variance.
So Eichenholz classification. Did any one of you get this right? Great, excellent. So this is for Charcot's arthropathy. Avascular necrosis has a different sort of classification system. We have the Ficat staging, we have Steinberg classification, and hypertrophic osteopathy, they are just primary and secondary. I don't think there's a staging system there. So Charcot's arthropathy is the answer.
So the right answer in this is EULA recommends temporal artery and axillary artery ultrasonography as a diagnostic tool for GCA. So temporal artery ultrasonography is sensitive, while axillary artery ultrasonography is specific. So combining both yields improves the diagnostic yield of GCA. I hope quite a few got it right.
So this was a tricky one. So the only thing here was or and. So we were dealing with Boolean operators. So that was difficult to pick up. But I think that's the quality of a good MCQ. So you have to focus on the relevant part. So the only incorrect thing is the or here. It should have been an
Yes, yes. So halo sign is different, count is different, score is different. In halo score, the sonographer measures the thickness of the artery, of the temporal artery, the two branches, and the axillary artery and counts it. So that is halo score. Halo count is different, score is different. Yes. Yes. Yes.
Okay, but then halo is part of the.
But halo sign is part of the artery, isn't it?
No, your point is well taken, but I think you're digging into the nitty-gritties. So amongst 2 and 4, so your point is well taken, you are absolutely right. But amongst 2 and 4, once you point out the and the or, maybe you'll also feel that 4 was more incorrect than 2. Yes, yes.
So this is again the other way around. Suicidal netosis occurs quickly than vital netosis. So this requires in-depth reading of netosis. So I don't think we have time for further explanation now. Next. Sorry?
True statement.
Oh, okay. Oh, sorry.
We have to mark this. Yeah.
We have.
Yeah.
Oh,
false.
False. Okay, this is an error.
Please do take notes. So everyone will get +1 for 16 then. It should be a blanket.
We'll omit 16 then.
Yeah.
So please don't score.
Yeah. Please don't score it as 0 and then 1 in certain cases.
So it'll be omitted. It'll be omitted.
Of course.
But isn't it is true, right?
Then
No, I
just
think
have
we'll check.
Exclude. This is.
Maybe I mistold the answer.
I think it's correct. No.
No, I think this is correct. I mistold the explanation.
Let's take the top 6 and then we have to offer it as a.
We'll check. I'll check on this.
So we'll get back to you on this. So keep it in a limbo till then.
So this should have been relatively easy. So of course, diffuse cutaneous subtype is the one where there is a higher prevalence of renal crisis and not the other way around. So I think this was slightly interesting. How many of you got this right? You must have. I mean, many of you might have. So danacatab, of course, is an anti-cathepsin K. It's a cathepsin K inhibitor, and that was stopped because there was a higher incidence of stroke as well as MI events coming up from the LOFT trial. So it's made no more. Question 19, which of the following serologic tests is not part of the diagnostic criteria? Again, quite self-explanatory. AMA or anti-mitochondrial antibody is part of the so-called criteria for PBC and not exactly part of the algorithm or score used to classify autoimmune hepatitis. So AMA is the incorrect one.
Yeah, so we got it correct?
Yeah, I hope this is also explanatory. You know the differences between ethanol and formalin fixation, how typical P-ANCA versus atypical P-ANCA is differentiated on the basis of ethanol versus formalin. So something that looks perinuclear on ethanol will change into cytoplasmic pattern on formalin, and that is truly P-ANCA. C-ANCA will remain cytoplasmic throughout. So
I'll just add a point.
Yeah.
So formalin is basically a stronger fixating agent than ethanol. So it basically doesn't allow MPO to migrate. Ethanol allows MPO to migrate, and that's why it goes from the cytoplasm to the perinuclear area and gives a perinuclear stain.
easy answer, I guess.
So straightforward again.
So it is important to remember that a lot of drugs we have for osteoporosis become redundant in advanced CKD. So it's important to remember that that is where denosumab can be safely used.
So the part of the criteria, we have been discussing a lot about MSAs. Professor Mishra was telling us not to, put too much weight on it. And it's true. So even the classification criteria has put in only Jo1, and it makes no sense to give a +2, +3, -1 score based on one antibody when there are so many number 1 and when they are still not known whether they are just associated with certain things or causing them. So Jo1 is the only one which is strongly pathogenic for certain cases, certain syndromes. That's why it has been put. The others have not yet.
Yes. So there is an update in process. So Dr. Rohit Agarwal had recently visited. So there is an update in criteria that is being actively worked upon, will be released pretty soon. So they'll have more of the MSAs.
Has everyone got this right?
Just part of the score, so there's not much to explain. So this is a set score for aortoarteritis or Takaisu-arteritis, the Indian Takaisu-arteritis score 2010. This has been improved upon using the inflammatory markers later, inflammatory markers and radiology changes later. So it does not include headache. Everything else is part
Though
of
the
the
most common symptom, headache, is not in the score. Genitourinary system is scored, and that's why we have abortions.
So if somebody has scored the ITAS 2010, then it's fine, but otherwise it's very counterintuitive. So if we are routinely doing it for patients, this would be easy, but otherwise it's very counterintuitive.
This is one of those just nomenclature questions. So Milwaukee shoulder is crystal arthropathy, basic calcium phosphate deposit disease of periarthritis of the shoulder. Skier's thumb, also called as gamekeeper's thumb, is ulnar collateral ligament injury, mostly due to twisting injuries of the hands. Kienbock's disease is osteonecrosis of the lunate. Little leaguer elbow is apophysitis. One back. Yeah. So question 24 is Milwaukee shoulder.
Should we rerun? Is there a sequence problem? Should we rerun? Maybe we can have a rerun after the last one, just so that we've not missed out on anything.
And finally, start question 25. So the TULIP trial was for anifrolumab in patients with SLE. The first trial outcome that was chosen was SRI-4, SLE Responder Index 4. It was a little more stringent, so it required at least 4 points decline in the Selena-SLEDAI total score, along with, of course, no worsening according to the physician, no new bilag A, or at least not more than one bilag B. BICLA is a little modification. It requires no worsening of the Selena-SLEDAI index. So that's possibly one of the explanations by changing the goalpost, how anifrolumab passed TULIP-2 trial. SRI-4 was changed to BICLA.
But the controversy around this was done midway into the trial. So there was a lot of controversy regarding, so this is ideally not allowed. If you go by statistical robustness, then the outcome of one trial should not, interim outcome of one trial should not lead to change in outcomes midway. So that did lead to a lot of controversy, and we can see TULIP-1 was published in Lancet Rheumat, but TULIP-2 was published in NEJM. So that's how a negative trial and a positive trial makes a difference. But there was a controversy, but nonetheless, it did give us a lot of insight into how to design lupus trials. So for a huge amount of time, about a couple of decades, most trials in lupus were negative. But because of a recent spike in trials, we've really identified that working on lupus or researching on lupus really requires choosing an appropriate outcome measure. And as Shaunak discussed, so maybe BICLA is the better outcome to study, and that's why it's revealing the differences which would otherwise not have manifest. So we'll just have a quick run through from 1 to 25 for the correct answers in case somebody lagged behind. Just a reminder, question 5, 10, 15, 20, 25 are star marked. So +3, -1, 0. And question number 16 is omitted. So please don't score question number 16.
Don't exchange papers right now. So we are going to just ask for scores beyond a certain limit. That will make it easier for everyone to ensure that there's no changes in papers going to this person to that person, and we'll ask whoever is the highest top 6. Okay.
And we'll just run through once. So 1 was D, 2 was C, 3 was B, 4B, 5B, 6A, 7A.
This is B.
B is.
Oh, so we marked it incorrectly. So this was B. So we
7B.
communicated correctly, but we
marked
it
it in red wrongly. So B is
that's
correct
B.
for 7.
7 is B.
7 should be B. Please make a note. 7 should be B. Well pointed out, really. I mean, seriously.
But we did convey correctly, but marked it incorrectly.
The red thing is A, but the answer is B.
8 is B, 9 is B, 10 is A, 11 is B, 12 is B, 13 is A, 14 D, 15 D, 16 B, 16 is omitted,
cancelled.
16 is omitted, 17 B, 18 D, 19 B, 20 B, 21 B, 22 B, 23 C, 24 D, 25 E. So we know if somebody had marked all B's, they'll be in.
So right away,
Yeah,
tally
yeah,
your
please,
scores.
there's some confusion there. Yes?
Yep. There is entry.
Yeah, there's one. ऐसे मत करो यार.
I don't think so. Check कर लो एक बार. Just check because if it is there. What does not include? Vertigo.
I'm so sorry.
Vertigo is the answer. This just looks bad, but ठीक है देखो.
Yeah, it looks bad.
See, the
So
abdominal
sorry.
pain तो है.
Abdominal pain.
We have to squid this as well, so 2 will go away. 2 will go away.
2 will go away.
Yeah, yeah. Cancel out 23 as well, please. Yeah. Cancel out 23 and 16. No, it's also a part. Dizziness, vertigo is also a part. No marks. No marks for genitourinary system is there. GU. Yeah, it's part of it. The rest are sure, but there was a confusion about the answers. So 16 and 23 will be cancelled. I'll ask them to tell you, na?
Just apologize for the...
No, that's okay. That's okay. What am I doing? यही होता है जब.
Yes, sir.
Yeah. No, sir. So,
Sir, so
not in
there
this.
is some evidence to suggest. Guidelines is both, sir. So that is, yeah. So I'm not saying, sorry, sir? Yes, sir. So obstetric APS and oxapan in combination with aspirin, sir.
This is part of the guidelines. So just to get a tally, what we are going to do
That's why,
is...
ma'am, no answer did not. Actually, if you see the options, so we hadn't kept no anticoagulation as an option, that's why.
We count 16 and 23 are not being counted. Only 16 and 23. Oh, you won the answer for 15. D. D. Yeah. So just to get a tally, does anyone have a score more than 25? Any one of the mark sheets present in your hands, is there a score sheet more than 25? Wait, one by one. How much? Okay, come down, please. We'll just cross-check as well once. That's not your sheet, I hope. Yeah. Sorry, my friend. Yeah, how much is the score? Come on, come down. We'll collect all these. 26. 3 of you come down. Anyone else above 25? Anyone else has a sheet with a score above 25 with 16 and 23 muted out? We're going to cross-check that, of course. Wait. So we have 3. Anyone above 22? So 23, 4, and 5. Anyone with scores with 22, 3, and 5? How many? 2. Please come down. We have 5, right? Cross-check करेंगे before announcing.
We have 3 now.
No, so 2 more. Above 22, please. So just 1. 2 sheets? Yeah. Anyone with a score of 22? That's where things will now get rolling. Just 1. And just to keep a gray area in case there are ties, anyone with score of 21? 22? One more? No, so 21. Anyone with a score of 21?
Keep 3 or 4.
Anyone with 20 now? Sorry for making you go back. 20? Any more with 20? No more scores 20 and above, right? Am I right? Perfect. So just give us 2 minutes. We are just going to cross-check these 8 to 9 sheets. We're going to announce the top 6 winners for tomorrow's mains and then a fee for the cultural program.
So we did identify some errors even in the eyeballing. So let's just hang around before really saying that these are the true scores.
No, I took till 20.
He's given +3 for all the questions.
So this needs to be remarked. So एक बार we'll just
we'll keep this aside. This score wouldn't be as high as this,
but
right?
much low.
low.
So this would
3
be
for everything.
3 for everything.
I give just 3 and -1.
Yeah, this wouldn't be there.
Next
then we have
Wait, still don't announce.
This is also seemingly fine. This is also seemingly fine.
Yeah, this is right.
इसका कितना हो?
I think this is fine. We have gone through. This is fine.
नहीं एक बार कर लेना फिर भी ठीक रहेगा. It'll be better, I think. Because we have changed 2 answers as well. 10, 10, 20. ठीक है. Might have a tie for 20.
That's okay. As long as there are 3, we are okay. If there's more than 3, the problem is. Oh, that is ma'am. We'll announce this, but you can take her. Because that is surveyed also.
We need to clarify this thing, answers.
Yeah.
Verify. Give it to more people. Give it to more people.
Call.
Screen share off.
Where is?
Screen off. Thank you.
So ये ना distribute कर दो.
किन में सब?
एक उनको बुला लो. उनको बुला लो.
हाँ, दो students. Make sure they check the list.
Bhavna.
Screen off.
You don't have to. Just please. I will just.
DD. Yes, this is right.
हाँ?
These are DD.
नहीं, what I'm trying to say is जो जिसका ओवर मार्क किया था उसका भी तो रियल स्कोर तो निकालना पड़ेगा ना.
No, it doesn't matter. This is out now. We don't have to inform this. ये तो clearly qualified आएगा.
चलो ठीक.
So at least 12 is going to go down.
Take one.
This cost.
Commutable little side. Okay, right, next.
So I think if they are correct, so I need
Yeah. You need one more positively. I can do one more.
Yeah, I'm checking what you have. 1D, 2C, 3B, 4B, 5B, 6A, 7B.
7 is omitted, no? 7 is omitted.
7 is B.
Okay, we are keeping it. Yeah, okay. 7 is B, correct. Okay, right. B, okay.
Yeah.
Next.
7 is counted.
Counted. B. Okay.
8 is B. 9 is B.
B, right?
Yeah. 10 is A. 11 is B. 12 is B. We are anticipating a couple of try breakers, so please hang around. 12 is B. 13 is A. 14 is B. 15 is B. 16 is cancelled. 17 is B. 18 is D. 19 19 is B. 20 is B. B for Bombay. 21 is B. 21 is B. 22 is B. 23 is cancelled. 24 is D. 25 is E.
25 is E, right?
Not minus 1.
Is plus 3. Minus 4, right?
Minus 1. Minus 1. Minus 1 total.
Program is going on.
Because some time.
No, but tiebreaker. It was just 2 minutes, sir. Tiebreaker might be wrong. Paper.
So minus 4.
Seven, 8, 11, 12, 13, 1, 2, 3, 6, 7, 8, 11, 12, 13, 14, 17, 18, 19, 20,
Just few minutes. I think we are going to have we have some tie break. They're going to sort it out. Probably they will throw some few more questions to all of you. Can I take a minute of your time just to express how you feel about this conference? Shall we continue? Because it's not easy to organize this kind of conference because we have to collect a lot of material. And being a full time, we all work full time. On the top of that, doing this kind of work, we need a lot of commitment, cooperation from you all guys, collect all the cases. So, and also fundraising and, involving people like Dr. Moli Taba, a lot of, academicians. It's not easy, putting them onto a single platform, coming up with this. And also I have to be an event organized also. It's all event organized, isn't it? So if you say it's a good thing, we can continue further. So I want to have your, ideas.
plus 3, minus 1, plus 3, plus 3. So 1 incorrect. One incorrect.
Good evening, sir. I'm Dr. Tejaswini from ESI Medical College. I think it's a wonderful conference being arranged in Hyderabad, and basically it's more clinical oriented, useful for trainees, and we are happy to be a part of it. Thank you, sir.
Thank you for organizing this, sir. A very wonderful conference, clinical-oriented case and case discussions with the expert panels, getting to know and learn a lot of things. Thank you, sir.
So we are ready with the results, sir.
Sir, we are ready with the results. Yeah, we can announce.
Like Sumna said, we are happy with the program, and if it's 3 days, we'll be even more happy. Thank you. If it's 3 days, we'll be even more happy.
I think next time I'll make you organizing secretary.
I think this is the only clinical case-based conference I have come across. This is the very new format and teaches you clinical pearls. Lots of take-home messages. I love it.
Thank you, sir. Over to the quiz masters.
So we have the top 4 for sure. Five. And then we have a tie break. So we are going to announce the names of the top 5 participants, do a quick tiebreaker, and then you're free to meet us again tomorrow, the top 6 participants.
So without any sequence or any incremental or decremental order. So Augustine Jose, 3rd year JIPMER. Congratulations. Sanjay Pruthi Raj, 3rd year KGMC. Congratulations. Nidish Chandra, 3rd year KGMC. Very nice. No cheating, right? No, different sports. Dr. Prithvi, third year, AIMS Kochi. Nice. And Dr. Lakshmi, third year, SGPGI. So these are our top 5. So we'll see you tomorrow. Tomorrow will be much better and less error prone, so to say. So that is more ratified. So for the 6th one, we have a tie between 2 people. So and it stays a tie even after checking for the star marked questions. So for the 6th, we need 6, and we have 5, and we need to select 1 out of 2. We need 1 out of 2, and we are not able to shortlist just based on star mark. So we have Dr. Hiren Kalyani, third year resident from Max Super Specialty Hospital.
Come down, please. We'll just have a tiebreaker rapidly right now.
And we have Isarul, Dr. Isarul, second year from IPGMER. So please, so both of you got the same score of 20. Both of you got 4 star marked correct out of 5. Both of you got 1 star marked incorrect. So there was no way we could choose 1 out of you. We don't follow the age protocol. So we will be following, or your date of birth. So we will be following a tie break. So, sir, should we go ahead on this only, or we can do it in separately as well? No, we'll make them write on their sheets.
Yeah.
So are both of you ready? So
So write down the answer for this. We are going to check immediately. This is sudden death. One gets it right, one gets it wrong, so one advances.
I will check the answers. Sorry. I will just check it.
शीट्स या पेपर देखना पड़ेगा.
Not yet known, ma'am. Both correct?
Both are wrong.
This is why it gets difficult.
So we go on to the next one. Please like a penalty.
So this is the second question. Do we have a correct one, or are they both differently wrong? Great.
So the correct answer is CD27, and we have Dr. So we have our top 6 participants. Thank you all. I hope the questions were of educative value, and we have now planned Dr. Sharath has now planned a...
No, please don't go away. I have ordered 300 dinner packs, please. Only 200 left. My heart will be broken. Please. We have 15 minutes of, one girl waiting for us. Please come on, ma. Just few minutes of dance performance, a local traditional dance, followed by dinner. It's ready, available. Just wait. Just encourage our own culture.
So don't
Please.
So don't break heart of Sharath sir, who had given this to all of us. So wait for some more time. So now I will introduce you one of the brightest youngster, Sahana Umesh. Sahana Umesh is trained in classical Bharatanatyam, and she has an experience of more than 10 years in giving various shows. She started performing from the age of 5. She has been trained by Rajeshwari Sainath, who is a Padmasri, and she has been performing in various multiple stages like Mylapore Fine Arts Academy, Kalasagaram, Hyderabad, and recently she has performed in Melbourne Fine Arts Festival, Melbourne, Australia, and Nairobi Brahmotsavam Festival, Kenya. And lots of areas, lots of like she